هاي.
مش مشكلة. أنا بعرف حالي. بس تأكد الصوت بس. الو. اوكي. بسم الله والحمد لله والصلاة والسلام على رسول الله. بسم الله نبدأ مؤتمرنا 12 لجمعية أمراض الدم الأردنية. أرحب بكل الزملاء ممن هم مسجلين وممن لم يسجلوا. بس حبيت أعطي يعني لمحة سريعة عن جمعية أمراض الدم الأردنية، والتي أنشئت عام 2008 وتعتبر جمعية نقابية، هي متفرعة عن نقابة الأطباء الأردنية، وبالتالي بعرف الجمعيات تعتبر جمعية ناشئة لأنه ما مضى عليها وقت طويل. كما أن الجمعية ما تزال غضة، بحيث أنه أعداد الأعضاء فيها ما يزال محدود. عندنا 67 عضو. نأمل أنه في السنين القادمة الأعداد هاي راح تزيد. وجمعيتنا هي الهدف الأساسي منها هي تثقيفية تعليمية. وين الصلاة؟ تثقيفية وتعليمية لزملائنا الأطباء لتحسين سوية الفهم السريري والممارسة السريرية، مما ينعكس إيجابا على المرضى في بلادنا وأي بلاد أخرى يشاهدون فيها. طبعا زي أي جمعية نقابية، الهيئة الإدارية منتخبة، تنتخب كل 3 سنوات، بما في ذلك الرئيس وأعضاء الجمعية. وهناك اشتراكات سنوية للجمعية. طبعا الاشتراكات السنوية رمزية. أعطيني السلايد اللي وراها. الجمعية نشيطة بموضوع النشاطات العلمية. على سبيل المثال بعام 2024 نفذنا 32 نشاط، بما في ذلك ورشات العمل، المؤتمرات، المحاضرات اليومية، المحاضرات الأسبوعية كيس اوف ذا مانث. ويعني عمالنا نشتغل كمان على شغلة مهمة كثير، اللي هي إصدار الأدلة أو الجايد لاينز، الأدلة العلاجية. وبدأنا الآن في عندنا 3 أو 4 جايد لاينز شغالين عليها، 1 انتهى و3 على الطريق. نأمل إنه هاي السنة راح ننفذ 5 جايد لاينز، وهاي نحطها تحت تصرف الزملاء في البلاد العربية وفي الأردن بشكل عام. طبعا احنا احتضنا الإيها، امتحان الإيها اللي هي الجمعية الأوروبية لأمراض الدم، وسوينا دورتين منه ونجح فيه مجموعة كثيرة من الزملاء، وحتى من خارج الأردن يجوا يقدموا عنا. اللي وراها، حط لي اللي وراها لو سمحت. عندنا من ضمن النشاطات ننظم هناك نشاطات اجتماعية، بما في ذلك الخلوات في أماكن مختلفة كالبحر الميت على سبيل المثال. وإحنا جمعيتنا نشيطة بالدعم المالي لزملائنا في مختلف الجمعيات الأخرى التابعين لنقابة الأطباء الأردنية، وكذلك طلبة الطب سواء في الأردنية أو الجامعات الأردنية الثانية. ويعني عندنا كم كبير من التبرعات تمت خلال السنوات السابقة. لما النقابة كمان تطلب منا نتبرع للكوارث الطبيعية أو الأشياء اللي بتحدث زي الكورونا، زي الهزات الأرضية، زي الحروب اللي موجودة في منطقتنا بكثرة. أينما تبرعت النقابة فإحنا نكون دائما في المقدمة لإعطاء ما يلزم من الدعم المالي. بالنهاية الجمعية هي عبارة عن جمعية نقابية هدفها الأساسي هو رفع سوية الممارسة السريرية عن طريق التعليم الطبي المستمر. وإحنا بالتالي ندخل في العلم والعلم فقط، ما لنا علاقة بالأمور السياسية، هي متروكة للسياسيين يعملوا فيها. وأنا سعيد أنه هذا المؤتمر اليوم يبدأ بكرة ينتهي مساء، وراح يكون عندنا حوالي 21 محاضرة من خيرة الأطباء اخترناهم بعناية، سواء بالمواضيع أو بالمتكلمين. بس للزملاء اللي متواجدين حوالينا نرجو إذا غدا مساء آخر جلسة نرجو من الحضور من الشباب إنهم يحاولوا يحضروا شخصيا، لأنه هاي الجلسة الوحيدة اللي خليناها in person ويتبعها عشاء، فبرضه بنحب نشوفكم على العشاء، بنحب ندردش معكم بالعشاء، نعتبرها جزء من نشاطنا الاجتماعي. وأتوقف هون، بس بدي أتكلم لزملائنا اللي غير أردنيين. For our friends who are not Arabic speaking, I wish to welcome you. This is the 12th conference of the Jordanian Society of Hematology, which is a young society, and we are extremely active in continual medical education. We support considerably the activities of all societies in the medical association, as well as we provide financial support to areas where disaster happens, such as the wars around us, as well as the earthquakes and so forth. Every year we conduct this conference, and it's carefully selected. It's a review conference in which we choose certain topics and we choose to give us an update in this direction. I will stop here and leave the floor to the first session, Dr. Mohammed Abedat.
صباح الخير للجميع، وشكرا للدكتور عبد الله for this nice introduction أو لافتتاحية المؤتمر. Our first lecture will be about the CAR T cell, and it will be introduced by Dr. Iacaboni. It's my great pleasure to introduce our today's speaker, Dr. Gloria Iacaboni. She's an hematologist and researcher at Vall d'Hebron Hospital in Barcelona, Spain, where she has been the leading work in lymphoma and CAR T cell therapy since 2017. Her career began as a medical student in the University of Valencia in Spain, followed by specialized training in hematology at La Fe Hospital. She then continued her deep expertise in Switzerland and Barcelona, focusing on lymphoma, stem cell transplant, and CAR T cell therapy. Dr. Iacaboni has made an important mark in the field, especially through their work with patients receiving CAR T cell therapy for aggressive lymphoma. She has published extensively in the top journals like Blood, Nature Medicine, and Journal of Clinical Oncology, helping to shape that what we understand and manage CAR T cell therapy. Today, she will talking about the current landscape of CAR T cell therapy, where we are, what we learned, and where we are heading. Please join me to welcoming Dr. Gloria Iacaboni. Dr. Gloria, thank you and gracias por estar aquí hoy. Sabemos que tu tiempo y tu experiencia son muy valiosos. Estamos deseando escucharte. Cuando quieras, puedes empezar.
Well, thank you so much for this kind introduction, and your Spanish is really amazing. Can you hear me all right?
Sí, yes.
Okay. Let me share let's see, the presentation. Give me a second to share the PowerPoint.
You have any problem?
No, I'm just trying to share. Let me see. Can you see the full screen?
No, not yet.
Okay.
Sorry, is your presentation started? Did you start it?
No, I'm trying to share it.
It's okay, but did you start it before? You should start the
let's
presentation before and share it, okay? And then you can share it.
It is open right now. I just think it's a matter of the.
And in the sharing block, you will find there is a presentation. You should select the presentation and then you start the process.
Oh, I know. I just think it's a matter of WebEx, I think. I'm not sure. Maybe block in. Yeah, because I think it's a WebEx thing with a computer.
Are you using Apple?
Yes.
Okay. I
That's
think you should give like a permission for using the presentation and using the storage at your laptop.
yes, I'm doing that right now.
So if you're still having the problem, you can start that again. Start all the process again. Okay.
Okay. So let's see. Can you see?
Yes,
I shared.
you've shared your entire screen. Would you move to your presentation? That will be much easier for you.
Yeah, and you can't see my presentation right now.
Okay.
No, you're still sharing your entire screen. Would you stop the sharing and then select the PowerPoint in specific?
Okay.
Sorry.
Yes, let's see.
Should be easier this time.
Believe me, I do this a lot. I just with WebEx, I think it's not as straightforward for my Apple computer. Let's see.
If it's not possible, you can send your presentation and we can control here. Do you think it's okay?
Yeah, sure. Let me just try one time to see. I think matter of WebEx and the problem. No. I'm trying to select the presentation, but it doesn't seem to be working.
Is your presentation running in the background? Is it running?
Yes, it's open. It's open.
Okay. I think you should find like in the block there is a presentation.
Can you see it? Could you perhaps see it now, or you're not seeing it?
No, not yet.
Not yet, unfortunately.
Okay. Perhaps now? If not, I'll send it over. I just like to usually control the slides, but if not, I can send it over.
Okay.
Could you send your slides by email?
I think she's sent.
Yeah, of course.
Sure.
We can.
I'll send them right away.
We can get the control.
I think Of course, yeah. I'm sorry. I just think it's
It's okay, but
it's a WebEx thing that the Apple doesn't let me
It's
open
okay.
because I usually use
which-
more Teams.
it's okay. Which email you've sent the presentation to?
Let me send that to. I'll tell you right away the email where I got the link.
If you have our info email, would you please send it?
Of course.
The hosting email, okay?
The email for the the Jordanian Society of Hematology, the WebEx email.
I've sent it. I've sent in the chat area. You can see our email. Would you please send that again?
Yeah,
To our
I'm
email. Okay.
sending it right now.
Yes, please. Thank you.
Great. Okay, I sent it now, so you should get it anytime soon. Let's see. Okay, let me know. Let me know if it comes into your inbox.
وصلك شيء؟
Okay, Doctor, I think you have some issues with the internet speed at your PC or at your location. Would you switch your camera off and try to share everything again? Could you please?
Yeah, sure.
Because it gives me like you have some issues with the internet there. Okay.
Okay.
Thank you.
I turned off the camera and I sent you the presentation, and
Yes.
I can nonetheless try to share it again.
It's okay. I'll check the email. Okay.
Thank you.
يعمل شير السكرين تبعتها بس هي مش عارف تعمل شير Okay. Okay, can you start sharing? Because I'm still waiting for the email, actually. Can you try to share it from at your end?
Yes, I am trying to. I'm so sorry. I'm trying to share all the time, all the time. I'm here, but it's. Let's see. Actually, I mean, technically I'm sharing now, but I guess you're not seeing it on your end. Did you not get the email?
Did you send your presentation by email, Zora?
Yes, yes, yes.
Could I send you my email? You can share
Yeah,
with
of
your email.
course.
ممكن حجمه كبير ممكن
I'll send it to this other email, info.
ما وصل.
إذا بتحب نقدم حدا تاني.
Okay, I sent it again. You may get it now. Perhaps.
Could you start your presentation without the slides? أيوة فتحة. Yes, we just received it.
Oh, great.
You can start now.
Okay.
Control والله. دكتورة, everything is okay. You can start, please.
Okay, I will need, I mean, are you going to share the slides?
Yes.
There we go. Okay, great. I see myself right now. There we go. There we go. Thank you so much. And I'm so sorry for the technical issues. It's true that I usually use Zoom or Teams, not so much WebEx. So that perhaps was my Mac. Anyhow, I'm really happy to be here. I'm Gloria Carboni. That was already presented by our colleague, and I will be talking about CAR T-cell therapy, focusing on large B-cell lymphoma and follicular lymphoma. And as we move to the next, starting with large B-cell lymphoma, so it's important to understand where we stand with CAR T-cell therapy in the large B-cell lymphoma setting. And this is a slide kind of summarizing the available trials and FDA approvals in the context of large B-cell lymphoma. So I've highlighted, as you can see, the 3 studies, 3 pivotal phase 2 single-arm trials, which led to the approval of CAR T-cell therapy in the 3rd or later line setting, Axi-cel, Tisagen, and Liso-cel, with the trials of ZUMA-1, Juliet, and Transcend. So moving on to the next slide, what we can see here is we now have long-term follow-up. This is very important, the pivotal trials in the 3rd or later line setting, which confirms the curative potential of this treatment option in large B-cell lymphoma and relapsed refractory large B-cell lymphoma. The longest follow-up comes with the ZUMA-1 trial in Axi-cel, now over a medium of 5 years of follow-up, with approximately 32% of patients which are alive and disease-free at this time point, and these patients are cured from the large B-cell lymphoma. We know that relapses beyond 5 years in the context of aggressive large B-cell lymphoma is very uncommon, so these patients are most likely cured. And we see a similar rate with Tisagen in the Juliet trial and Liso-cel in the Transcend trial, follow-up still a bit shorter than ZUMA-1, but we can observe that similar plateau of those patients who now, after more than 2-3 years of follow-up, are alive and disease-free. So across the studies, we see that plateau indicating that CAR T-cell therapy has curative potential in the context of relapsed refractory large B-cell lymphoma. Now, moving on to the next slide, the next important message will be that not only do we have long-term follow-up of the pivotal trials in the 3rd or later line setting, but we have real-world evidence, that is to say, thousands of patients treated outside of the pivotal trial setting in the real world, patients who are not cherry-picked for clinical trials, who have comorbidities, who have ongoing issues, who would not have been eligible for the pivotal trials. And we see that the same favorable efficacy results are reproduced outside of the trial setting. When we treat patients with Axi-cel or with Tisagen, we can see here the results. The American US data usually presents separately the Axi-cel and the Tisagen results because they have really large numbers of patients treated with these options. And the European data which has been published from the UK, from Germany, from France, from Italy, from Spain. Many real-world data publications usually join the Tisacel and the Axicel results. In general, Axicel performs when they are retrospectively and indirectly compared. Axicel performs slightly better than Tisacel, especially in terms of efficacy. It is true that it's associated to a higher risk of severe ICANS and severe CRS, so it is important to understand this higher risk for toxicity with Axicel. But in summary, as it does seem to have slightly better efficacy than Tisacel, that is the product which is generally selected for large B-cell lymphoma. Now, moving on to the next slide, it's important to understand that we have, prognostic factors we have identified in these real-world studies that help us select patients for CAR T-cell therapy. So, in the pivotal trials, kind of what they came to say is all patients benefit from CAR T-cell therapy, and that is kind of the general message. But it is true that some patients have a chance of performing better, and it's better to understand, it's good to understand these prognostic factors to aid patient selection in the clinic. So the most important prognostic factors we can see on the left. These are ECOG performance status and LDH. That is to say, patients with a poor performance status with an ECOG of 2 or higher. This is usually due to the underlying lymphoma. It's the lymphoma that is, not helping the patient perform well, and these patients will perform more poorly if they have an ECOG performance status of 2 or higher. And as we can see below, a markedly increased LDH. That means that their rapid kinetics, it's a surrogate for the aggressiveness of the underlying biology of that lymphoma. These patients with this markedly increased LDH will also have a lower chance of achieving a durable remission with CAR T-cell therapy. So this is important to understand when we are selecting patients and when we are informing patients, even if we do move forward with this treatment, inform them on the chances of achieving a durable remission with CAR T-cell therapy. Other prognostic factors, which we can also see here, inflammatory parameters such as ferritin, CRP, they also have an impact. Patients who have higher inflammatory markers prior to CAR T-cell therapy have a lower chance of achieving a durable remission, but we do not use them as much in the routine clinic to select patients. And response to bridging therapy, which is administered between leukapheresis and lymphodepleting chemotherapy, is also a marker of the chances of responding then to CAR T-cell therapy. So patients who achieve some kind of a response to bridging, PR or CR, these patients will perform better with CAR T-cell therapy than patients who progress to the bridging regimen. And on the right, we can see age and comorbidities. That is just to highlight that these factors, which have an important role in the transplant setting, do not have such a significant role in the CAR T-cell setting. So we do not exclude patients based solely on age or comorbidities. We treat patients up to 80 years of age and with moderate comorbidities. It is important, however, to understand that we do have to select these patients better. If a patient is older, over 75 years of age, we do just want to make sure that the other factors are in place, ECOG performance status, LDH, etc. And patients with multiple severe comorbidities can have a higher risk of not achieving durable remission, a higher risk of death with the toxicity that can come with CAR T-cell therapy. So we do not exclude patients based on these factors, but we do keep them into account to make sure we are selecting the patients with a more scrutinous criteria when they are older or have severe comorbidities. So moving on to the next slide. Up to now, we have third-line data, long-term follow-up of the pivotal trials, abundant real-world data, patients treated outside of the clinical trial setting with the same results as the pivotal trials. And we also have, interestingly now, results in the second-line setting. So moving on to the next slide, the two randomized phase 3 trials, which were positive and led to approval in the second-line setting, were the ZUMA-7 on the left and the TRANSFORM on the right. The ZUMA-7 on the left with Axicel randomized transplant-eligible patients to standard of care with platinum-based immunochemotherapy and autologous stem cell transplant consolidation versus treatment with CAR T-cell therapy, Axicel. These were transplant-eligible patients, second-line setting, who were refractory or had relapsed within 12 months of the end of their first-line immunochemotherapy cycle. So these early relapsing patients within 12 months of their first line were randomized to standard of care or Axi-cel. Axi-cel met the primary endpoint of event-free survival superior to standard of care. So patients who received Axi-cel had a significantly improved event-free survival compared to patients who received chemo and transplant. And not only that, but with longer follow-up, we've seen that there's also an advantage in terms of overall survival, which is, of course, always the most important endpoint for Axi-cel in comparison to standard of care with chemo and transplant. Now, what we see on the right, the TRANSFORM trial, similar design, but instead of Axi-cel, it's with liso-cel. Liso-cel also achieved a significant improvement in event-free survival compared to chemo and transplant. Not yet reached an advantage in terms of overall survival, but we do have to keep into account that in the TRANSFORM trial with liso-cel, patients could cross over from the chemotherapy arm to the liso-cel arm if they progressed to their salvage chemotherapy. They did not have to undergo the transplant, but could cross over to liso-cel if progressing on the other arm. So this could have potentially impaired the chance of observing an advantage in terms of overall survival. Moving on to the next slide, it's important to understand we have data in the transplant eligible setting. We've seen that with the ZUMA-7 and TRANSFORM, but we also have data for patients who are transplant ineligible in the second-line setting. And this comes from the Alicante trial and a pilot trial. So the Alicante trial with Axi-cel was a single-arm phase 2 trial for patients who are not candidates for an autologous stem cell transplant. They all received Axi-cel in the second-line setting. It was also for patients who were refractory or relapsed within 12 months of their first-line treatment. And we can see here the results for these patients. The efficacy results were very, very favorable. Close to 80% of patients achieved a complete response, and the 12-month overall survival was 78%. So efficacy was really favorable, much better than what we would expect with immunochemotherapy regimens such as our GMOX, which is what we would usually administer in this setting. However, we do have to keep into account that there was some significant toxicity. As we can see below, severe CRS 8%, severe ICANS 15%. Most patients required tocilizumab, required steroids, and 1/4 of the patients, 26%, required admission to the intensive care unit with grade 5 infections in 10% of the patients. So the idea here is Axi-cel can be an option in the second-line setting for patients who are transplant ineligible, just as it is for patients who are transplant eligible. But the risk of toxicity is there, and these older patients may not tolerate it as well. So they do have to be more carefully selected than young patients. And what we see on the right is the pilot trial, second line as well, but with liso-cel. Liso-cel is a safer product. So we can see severe CRS only 2%, severe ICANS 5%, and they were all grade 3, by the way. But efficacy is a bit lower, so only 54% of the patients achieved a complete response. However, this is important data that we have in the second-line setting for transplant eligible and ineligible patients. Moving on to the next slide.
Next slide.
There we go. So I've kind of covered the data that there is for third line, for second line, and this brings us to our treatment algorithm. This is how the treatment algorithm stands now. This is, personal view that I constructed for large B-cell lymphoma. We have immunochemotherapy in the first line, R-CHOP or Pola-R-CHP. In Spain, for example, we are still using R-CHOP. If a first relapse occurs within 12 months of the first line treatment, that patient can move forward with CAR T-cell therapy, irrespective of being transplant eligible or not. So we can offer CAR T-cell therapy for early relapsing patients, whether they are transplant eligible or not. If a relapse is later, after 12 months from first-line immunochemotherapy, then if they are transplant eligible, they will receive chemo and transplant. If they are ineligible, there are other options, such as our GMOX, Tafalen, or Bendapola, and of course, clinical trials would be our first choice in that case. And after the second relapse in the third-line setting, If a patient hasn't received CAR T cells, that would be the first option we would select. If the patient has already received CAR T cell therapy, then bispecific antibodies. And in the third step, we would have other options such as RBP, R-bendapola, tafalena, or loncastuximab. Now, moving on to the next slide, it's important to understand that trials are creeping into the first and second line setting, combining bispecific antibodies and CD19 targeted agents, which will definitely shape the future treatment algorithm of large B-cell lymphoma and call into question sequencing, which is very important currently. If we offer bispecifics or CD19 targeted options in the first or second line, how will that impact CAR T cell efficacy when it is administered after these agents? So that brings me to the next slide. I would like to offer some data regarding sequencing for these three topics: bendamustine, CD19 targeted agents, and bispecific antibodies, because many times we'll be faced with the question of, can we administer regimens which include these agents if a patient is a potential CAR T cell candidate down the road? So moving on to the next slide, I will cover briefly bendamustine first. Does it have an impact on T cell fitness? Should I avoid it prior to CAR T cell therapy? Moving on to the next, that brings us to our key study, where we analyzed 439 patients who had received commercial CAR T cell therapy, axi-cel and tizi-cel, outside of the clinical trial setting. Of these, 80 patients had been exposed to bendamustine prior to leukapheresis, and of these 80, 42 had a washout which was shorter than 9 months, and that was the cutoff in our study. Moving on to the next slide, when we analyzed these patients, we observed that patients who had a recent exposure to bendamustine, defined as an exposure within 9 months of leukapheresis, had a significantly shorter progression-free and overall survival compared to patients who had no prior exposure to bendamustine. So lower response rates, lower PFS, lower OS, if the exposure to bendamustine was recent, and recent was defined as 9 months due to statistical analyses in our study. Moving on to the next slide, we tried to understand why this happened, and we observed a numerically lower CAR T cell expansion in patients who had been exposed to bendamustine within 9 months. So this is one of the factors that indicates lower T cell fitness, lower CD4 count, lower CAR T cell expansion, and that could be one of the reasons why bendamustine has an impact on CAR T cell efficacy. Moving on to the next slide, not only with our study, but with other colleagues have shown similar results. This was presented at ASH this year and recently published as well, concomitantly with the oral ASH presentation, an American cohort of over 1,000 patients with large B-cell lymphoma treated with CAR T-cell therapy. Of these, 1/3 transformed indolent non-Hodgkin's lymphoma and 2/3 de novo DLBCL. And they also observed that patients with a recent exposure to bendamustine prior to leukapheresis, which they defined as within 12 months, 1 year of leukapheresis, these patients had a significantly shorter progression-free survival, as we can see in the blue curve, compared to patients in the green or red curves, which were patients with a longer washout or with no exposure to prior bendamustine. So our results have been reproduced in other cohorts of large B-cell lymphoma patients, and as we will see again with follicular and mantle cell lymphoma. Moving on to the next slide, that kind of brings us to the next topic, CD19 targeted agents. If they are moved into earlier lines of treatment, CD19 targeted agents such as loncastuximab, tafasitamab, will this cause a loss of antigen expression? Will this have an impact on the efficacy of CAR Ts? So moving on to the next slide, it's important to understand that this analysis was carried out in the ZUMA-7 study. So they analyzed patients who received axi-cel. We can see the blue and the pink curves. Patients who received standard of care are the brown and green curves. We can see that there was a significantly different event-free survival among axi-cel recipients, depending on the CD19 expression as assessed per immunohistochemistry. So patients with a high immunohistochemistry CD19 expression had a significantly better event-free survival than patients who had a low CD19 expression, as we can see here in the pink curve. So pink and blue, they all received axi-cel, but the blue performed better, and the blue were the ones who had a high CD19 expression, per immunohistochemistry prior to CAR T-cell therapy. So it does seem to be that the target, which is CD19 expression, is correlated with the efficacy of CAR T-cell therapy. Moving on to the next. The other concept is that when patients are exposed to CD19 targeted treatment, they can become CD19 negative. And this is an example of the CAR T. They did this very interesting study published in Nature Medicine, where they observed that over half of the patients who were exposed to CD19 targeted CAR T cell therapy became CD19 negative at relapse. This is with CAR T, but could it potentially happen after exposure to tafasitamab or loncastuximab? Could this impact the efficacy of CAR T cells later on? So moving on to the next slide, there is some data with tafasitamab and loncastuximab, which I will briefly review, but it's very scarce, to be honest. So loncastuximab from the clinical trials, which led to the approval of loncastuximab for large B-cell lymphoma, 14 patients who received loncastuximab and then received CAR T-cell therapy, and this was documented in the trials. We can see that it did not seem to have a high impact on CAR T-cell efficacy. 43% of the patients, 43% achieved a complete response as their best response to CAR T-cell therapy. However, it is true that all patients were tested prior to CAR T and they all tested CD19 positive. So that's very important information. Regarding data outside of the trial setting, real-world data from the CIBMTR registry with axi-cel, 16 patients, so low numbers. Again, these patients seem to perform fine, similarly to patients who had not been exposed to prior loncastuximab, but it is true that when there was a shorter washout between lonca and CAR T, so when lonca was used as bridging instead of as a last line of therapy, when the washout was shorter, the complete response rate did seem to be lower than when there was a longer washout. So we can see that when loncastuximab was used as bridging, that means closer to the CAR T-cell infusion, complete responses were 36%, a bit lower than when lonca was used as a last line of therapy, 60% of complete responses. So probably washout is an important factor, but we do need larger numbers to better understand the impact that exposure to loncastuximab prior to CAR T can have on the CAR T-cell efficacy. Moving on to the next slide, very briefly, there is very scarce data as well with tafasitamab. We can see here 15 patients from the DESCAR-T French registry. And of these, most cases, tafasitamab was used as the last line of therapy. Only in 3 patients, it was used as bridging. And CD19 expression prior to CAR T was not available in most patients, so there's a lack of that data. In any case, we can see 36% complete responses, which is more or less in line with standard efficacy, a bit lower, but as I said, very low numbers. So we're still struggling to understand if TAF and lonca exposure prior to CAR T could have a negative impact. Moving on to the next slide brings us to our last topic, which is exposure to bispecific antibodies prior to CAR T. Could T cells be exhausted if they are exposed to bispecific antibodies, and could this decrease the chances of efficacy with CAR T cell therapy? So moving on to the next slide, we conducted this study together with the French and the Spanish patients, collected 47 patients who had received bispecific antibody treatment as a prior line before CAR T cell therapy. So they received first bispecific antibody-based treatment, and then when they progressed, they moved on to receive CAR T cells. We analyzed these 47 patients and observed that efficacy seemed to be in line with what we could usually expect for CAR T cell recipients. The 1-year PFS was 42%, so that's more or less what we achieve with CAR T cells outside of the trial setting. There was no higher toxicity in this patient population. And what we see on the right is that, interestingly, responding or not responding to prior bispecifics did not seem to have a predictive, let's say, effect on the chance of responding to CAR T. So if the patient achieved a PR or CR to prior bispecifics and then progressed, this patient did not have a higher chance of responding to CAR T than if the patient just progressed to bispecifics and never responded. So we try to analyze that, right? Perhaps if they responded initially to bispecifics, chances of responding to CAR T were higher. We did not really see that. It did not seem to be correlated. So moving on to the next. to make this data more robust, we compared our patients, our 47 patients who were bispecific exposed prior to CAR-T with a control cohort of patients who were not exposed to bispecifics prior to CAR-T. These were patients selected from the DEST CAR-T registry, and we observed comparable outcomes in terms of progression-free and overall survival. We did not see lower efficacy in the bispecific exposed cohort. In fact, these patients even performed slightly better, the bispecific exposed patients, compared to the control cohort. So kind of our conclusions here would be, it does not seem to be that patients, because they are bispecific exposed, could have a lower chance of achieving a response to CAR-T cells. But again, washout is probably important. So our median washout was 50 days. You probably need at least 3 to 4 weeks to make sure that T cells are not exhausted when you move forward with leukapheresis and CAR-T cell therapy. Moving on to the next slide, that brings us to the end of the sequencing. There we go, sequencing approaches, and we are going to dig into follicular lymphoma as we come to towards the end of the presentation. These are the available studies for bispecifics and CAR-T cell therapy in follicular lymphoma, many approvals, and I will cover those of CAR-T cells in the following slides. Moving on to the next. The longest follow-up in follicular lymphoma comes from the ZUMA-5 trial, very exciting trial, enrolled patients with both follicular and marginal zone lymphoma. And we can see here the initial results that were presented. Close to 80% of patients achieved the CR. And these were patients who had been exposed to at least 2 prior lines of therapy, including an anti-CD20 monoclonal antibody and an alkylating agent. So 2 prior lines. This was a 3rd line or later setting trial. And still follicular lymphoma patients, close to 80% achieved the CR. Safety, toxicity was kind of in line with what we usually observe, 6% of grade 3 or higher CRS, 15% of grade 3 or higher ICANS. So important to take this into account. And interestingly, as we can observe on the right regarding those curves, very important to achieve a CR. Patients in PR will most likely eventually progress. So we need to achieve a CR because, in the follicular lymphoma setting, we thought maybe a PR is enough and that patient will maintain that PR over time. It's definitely very important that patients achieve a CR if they are receiving CAR-T cells for follicular lymphoma, just as it is with the large B-cell lymphoma patients. So if they are a true PR, if they never achieve a CR, these patients will progress and require other treatment strategies. Now, moving on to the next slide, this study was updated in the ASH meeting, which just happened in San Diego, 2024 ASH meeting. And now we have over 5 years of follow-up. The presenter, Sattva Nellapu, even ventured to say that it seems to have curative potential in the setting as well of follicular lymphoma. Perhaps we need a bit longer follow-up to be sure of that. But it is interesting to see that the number of patients who progress is being, is kind of dropping over time. So no patients have progressed beyond 5 years of follow-up, only 1 patient from year 4 to 5, only 1 patient from year 3 to 4. Kind of the trend seems to be that more patients progressed initially, but now we see very few patients progressing. So potentially there is a curative fraction of CAR-T cell therapy of axi-cel for follicular lymphoma as well. Moving on to the next slide, just to see the overall results, we see that, as we can see on the top left, the 60-month, 5-year progression-free survival for follicular lymphoma was 50% approximately. So 50% of the patients who were infused on the ZUMA-5 trial with axi-cel are still alive and disease-free after over 5 years of follow-up. And we may start seeing a plateau there in the curve. Not quite sure yet. We need more follow-up, but kind of exciting to understand that CAR-T cells may have curative potential in follicular lymphoma as well. As we can see on the right, bendamustine prior to leukapheresis, benda exposure also has an impact for follicular lymphoma. So as you can observe there on the top right corner, that blue curve, which is much slower than the other curves, those were patients who were exposed to bendamustine within 6 months. So exposed to bendamustine within 6 months of leukapheresis, significantly lower progression-free survival compared to patients with no exposure or a longer washout. So important to understand that let's avoid bendamustine if we think the patient is going to be a potential CAR-T cell candidate down the road. Moving on to the next slide. Here we have the ELARA trial, just to cover all the CAR-T constructs, very important. The ELARA trial is the pivotal single-arm phase 2 trial, which led to the approval of Tisacel or Kymriah in follicular lymphoma. Similar update at ASH, 4 years now. So it's kind of, close to the ZUMA-5 follow-up. ZUMA-5, 5 years, ELARA, 4 years. And we can see the efficacy, 72% achieved the complete response in this trial. Remember that it was close to 80% with Axicel, 72% here. So kind of in the same range. And as we can see regarding safety, Tisacel has a much better safety profile compared to Axicel. That is true. No CRS grade 3 or higher, 1% of ICANS grade 3 or higher. So definitely better safety, and efficacy seems to be slightly lower, but overall kind of similar, as we can observe here. Moving on to the next slide, we also have an update regarding progression-free and overall survival, which you will see. And in the subgroup analysis, the factor which definitely was highlighted, which kind of stuck out as being important, tumor burden, metabolic tumor volume. So we can see here they analyzed all the factors, POD24, prior transplant, LDH, and regarding follicular lymphoma, one of the most important prognostic factors, which I have highlighted, is metabolic tumor volume, and that refers to the tumor burden the patient has prior to CAR T-cell therapy. So a higher tumor burden has a negative impact on CAR T-cell efficacy, both for large B-cell lymphoma and follicular lymphoma. Moving on to the next slide, we have the update on PFS and OS, and we can see this on the right. Just I put down there the numbers so it's more clear. The 4-year PFS for the whole patient population was 50.2%, and that's similar to what we saw with Axicel at the 5-year follow-up. So Axicel 5 years, 50%. Tisacel, ELARA, 4 years, 50% as well. And we can see that patients who had a high metabolic tumor volume, as we can see on the last row, 23% of 4-year PFS. So definitely patients with a higher tumor burden have the lowest chance of achieving a durable remission. As we can see, that's the lowest number, patients with a high tumor burden or TMTV above 510 milliliters. Moving on to the next slide, we have the final trial, the TRANSCEND-FL of liso-cel in relapsed refractory follicular lymphoma. This is the trial in follicular lymphoma with the shortest follow-up, the one with liso-cel. This was recently published in Nature Medicine last year. Data was quite exciting. So we can see that complete response rate was 94%. That was higher than Axicel, higher than Tisacel. Let's remember, Axicel 80%, Tisacel 72%, and we see a 94% complete response rate in the 3rd line or later setting for follicular lymphoma patients receiving liso-cel. So very exciting. Also, very important to understand POD24 patients who relapse or progress within 24 months of first-line immunochemotherapy. Results were better with liso-cel when we compare them with Tisacel and Axicel. And we can see here, POD24 patients, 94% complete response rate compared to 59% and 72% with Tisacel and Axicel, respectively. And regarding safety, really good profile. It's similar to Tisacel, only 1% CRS grade 3 or higher, and only 2% ICANS grade 3 or higher. And many patients were actually managed in the outpatient setting. So good safety profile, really, encouraging efficacy. So we're looking forward to seeing longer follow-up. In the next slide, as we come to the end of the presentation, this study was updated at the ASH meeting 2024. So we can see this in the next slide if we click. And this was the 2-year follow-up that we had for this trial. So we do have to move forward to the next slide now. There we go, 2-year follow-up for the TRANSCEND-FL. This is, shorter than we saw with ELARA, 4-year follow-up, ZUMA-5, 5-year follow-up. So definitely we need longer follow-up for this trial, but still we can see that the 24-month progression-free survival was 73%. So that's looking good, 73%, but we'll see with longer follow-up if there are, more patients who progress, and we'll see if in the end, regarding durable remissions, the Transcend FL seems to be better than ELARA and ZUMA-5. So we'll see with longer follow-up what this looks like. Right now, we just have 2-year follow-up and a 24-month PFS, 73%. And finally, moving on to the next slide. This is the end of the presentation. Treatment algorithm, therefore, for follicular lymphoma. We still are doing first-line immunochemotherapy. At first relapse, we can repeat another schema of immunochemotherapy or use R-square, or lenalidomide. Bispecifics and CAR T-cell therapy right now are available in the third or later line setting. Which goes first, I think, is still an open question in the follicular lymphoma setting compared to the large B-cell lymphoma setting, where it's more clear that it's first CAR T and then bispecifics. Regarding large B-cell lymphoma, in follicular, it's kind of patient dependent. So you kind of have to go through pros and cons, and it's an individual-based decision. We have other options, such as zanubrutinib, obinutuzumab, and R-square for the third line setting, but we would prioritize first CAR T and bispecifics, and then go to the other options in case the patient require them. Just clicking on to the next and final slide, just to take into account many exciting trials with both CAR T-cell therapy and bispecific antibodies moving into the first line setting and moving into the second line setting, which will definitely shape the treatment algorithm of follicular lymphoma in the years to come. So right now they are in the third line, both bispecifics and CAR T, but bispecifics may sneak into the first line combined with immunochemotherapy or combined with R-square, and CAR T-cell therapy may sneak into the second line for high-risk POD24 patients if the trials are positive. So we'll see what that looks like when these trials are reported at future meetings. And with that, I'll go to my last slide, and just thank you for your attention and look forward to any questions you might have.
Thank you, Dr. Gloria, for this nice talk. And the floor is open for any question. تفضل دكتور عبد الله.
Thank you very much for this excellent presentation. My question is, traditionally, we consider the diffuse large B-cell lymphomas are potentially curable on traditional chemoimmunotherapy. What you have shown us today that with CAR T cells, follicular lymphomas are probably better treated, better response and possibly potentially more curable than the diffuse. Do I understand this well?
Yes.
So that's an interesting question. So in large B-cell lymphoma, what we kind of, I think the message is, from all the data we have, it seems that approximately 40% of patients that we infuse will achieve a durable remission. So that's kind of the number I usually have in my head when we look at the trial data, the real world data. It's approximately around 40%. That's the fraction of patients that will be cured, that will achieve a durable remission in the large B-cell lymphoma setting. Of course, this percentage, let's say this fraction, varies according to the prognostic factors I mentioned. So probably we're treating a patient with a good performance status, with an ECOG 0, with a low tumor burden, with a normal LDH. Probably that patient has a 60% or 70% chance of being cured with CAR T-cell therapy, and patients with a markedly increased LDH and a bad performance status has a 10% chance of achieving a durable remission. So it's important to kind of keep in mind that, that kind of middle percentage of 40% refers to all patients, and that includes really good patient profiles and really bad patient profiles. I think we still need more data in the follicular lymphoma setting to understand what is the cure fraction. So it is true that at 5 years of follow-up, so something similar to the ZUMA-1 trial, the number, let's say, of patients who are alive and disease-free is higher because it's close to a 50%, but we probably will see more relapses in the following years. So probably if we take the numbers, we'll have to see, let's say, at 10 years of the ZUMA-1 and 10 years of the ZUMA-5. I don't think that we will have more follicular lymphoma patients who are cured with CAR T cells than large B-cell lymphoma patients. I just think that right now at 5 years, the numbers are a bit higher with follicular lymphoma, but there will be more relapses over time in the follicular lymphoma cohort. So in the end, I think it will be similar or even a bit lower in the follicular lymphoma setting, just because patients, will constantly like relapse over the following years, at least some patients. So, and probably in the large B-cell lymphoma cohort, no patients will relapse. So eventually in the long run, when we reach like 10 years of follow-up, I do believe those rates of cure fraction will be kind of in the same range or perhaps even a bit lower in the follicular lymphoma setting. Because, the biology of the two types of lymphoma is different. So if, patient is alive and disease-free at 5 years with large B-cell lymphoma, that probably means is cured. It doesn't necessarily mean that same thing with follicular. So with follicular, we know that relapses can occur later on. So probably in the long run, that cure fraction will not be higher in the follicular lymphoma setting. It will probably be lower, that will be my bet, or at least in the same range. But we need longer follow-up kind of to make sure what the answer to that question is.
Dr. Gloria, do you think that ICANS or CRS could be higher in patients, those who didn't achieve the complete response or remission after bridging chemotherapy? Or it's not related? What do you think?
So I understood the question correctly. Response to bridging is definitely a prognostic factor. And if the ideal thing would be to achieve CR or PR on bridging. Those patients perform much better with CAR T-cell therapy than patients who you give bridging to, maybe a chemo cycle, and they progress. Because those patients, that means that they're chemo refractory. And that means probably that the lymphodepleting chemotherapy regimen with fludarabine and cyclophosphamide will probably have a lower impact, a lower effect. And that definitely influences, the CAR T-cell efficacy that we will give later on. So it's correlated, I think, in those two ways. If you progress to bridging, you will perform worse with CAR T-cells for two reasons. One, you will have a higher tumor burden, a higher TMTV or metabolic tumor volume. And we know that higher tumor burden, lower CAR T-cell efficacy. And that it kind of tells you biologically, if you progress to bridging, which is usually chemotherapy based, that patient is chemo refractory. And that means that probably when you give him the fludarabine cyclophosphamide lymphodepletion, he will not respond as well to that lymphodepletion. And therefore, that will have an impact on CAR T-cell expansion and CAR T-cell efficacy. So probably those are, overall, academically, the two reasons that influence the lower efficacy we see with CAR Ts when a patient progresses to bridging. Now, said that, we do not try to give a super intensive bridging trying to achieve a CR or a very good PR. We try to do a low dose, low toxicity bridging regimen, because we are just trying to kind of maintain the lymphoma under control until we get to the CAR T-cell therapy. So I think it is important to avoid high-intensity bridging regimens that can cause toxicity in the patient before CAR T-cell therapy. We do not kind of look for that CR. We're just trying to kind of maintain that lymphoma under control. But it is true that if the patient responds to bridging, chances of responding to CAR Ts are higher because of those two reasons.
Yes. And do you think that using of bispecific antibody as a bridging therapy before CAR T-cell, do you think we're losing one of the options or one of the amazing options in the treatment of lymphoma?
So that's a great question. I don't think we are losing that option. I think we can, if we use it as bridging, we could do a couple of cycles, 2-3 cycles, and then do CAR Ts. And I think if the patient progresses to CAR T-cell therapy eventually, we could probably consider repeating the bispecific antibodies if there was an initial response to the bridging bispecific antibody treatment. So we could probably do that treatment option again. I think the only thing I'm kind of wary of is I'm not sure if so the data I presented is bispecifics prior to leukapheresis with a median washout of 50 days. And that did not seem to impact negatively the efficacy of CAR T cells. Now, if we do bispecifics closer to the CAR T-cell therapy, that will cause potentially T-cell exhaustion in the endogenous T cells, not in the CAR T cells, but in the endogenous non-CAR T cells, which also are key in the efficacy of CAR T-cell therapy. So when we infuse the CAR T cells, the non-CAR T cells also help the CAR T cells work. If we are exhausting those, endogenous non-CAR T cells, then these perhaps cannot aid the CAR T cells in doing their job as well. So I just think there's a lack of data, and there's a lot of trials and studies going on. So I think we'll have data in the coming years. But I just would be perhaps wary of using it like routinely in the bridging regimen prior to CAR T. Not so much because I'm going to burn that option. I think we could do it later on again if needed. But I'm not sure the impact that will have on CAR T cell efficacy. So I just think, let's see what the data looks like. I think our study only looked at bispecific exposure prior to leukapheresis, long washout. So that has nothing to do. It's a totally different scenario if you're doing bispecifics as bridging right before CAR T cells. We do that only when the patient is like primary chemo refractory. We have no bridging options, and then we decide to do bispecifics because we need to control lymphoma some way, and chemo is not doing the job. Patient is not a candidate for radiotherapy, so we sometimes have to do bispecifics in that scenario. But I think we still need data to better understand if that can have or not a negative impact. Perhaps not, but I think the lack of data is still very important to make an assumption.
And nowadays we started to see a lot of patients relapsed after the CAR T cell. Do you think that's going to allogeneic stem cell transplant to those patients who underwent CAR T cell is different from those who didn't had a CAR T cell therapy before?
Yeah, so that's a great question. The truth is our rate of transplant, of allogeneic stem cell transplant has really gone down in lymphoma since the introduction of CAR T cells. And not only CAR T cells, but as you mentioned, all the great options we have. We have CAR T cells, we have bispecific antibodies, we have TAFA, LONCA, rituximab, bendapola. So we have all these options now that we didn't have before. So briefly, before, when we did CAR Ts in the third line, we only had CAR Ts in the third line. If the patient progressed to CAR T in the third line setting and we salvaged that patient with bispecifics or with another treatment option, we would definitely consider consolidating with an allogeneic stem cell transplant. That was always kind of a discussion we had on the lymphoma tumor board. Now that CAR T has moved earlier, into the second line setting, and most of our patients are receiving CAR T in the second line setting, probably we do think there's still many options that the patient can receive after CAR Ts, so we do not automatically consider thinking of the allogeneic stem cell transplant. If the patient achieves a CR to bispecifics, we would, have that discussion, but we do not automatically consolidate those patients because there are more, let's say, options down the road the patient can receive, including trying, if needed, again, chemo and an autologous stem cell transplant if the patient received CAR Ts in the second line. So the truth is we are performing very, very little allogeneic stem cell transplantation in the lymphoma setting right now, only to patients who have received multiple lines of therapy and are bispecific refractory, CAR T refractory, chemo refractory. Then those patients, we would consider them for allo, but very few patients, fortunately. And our autologous stem cell transplants have also decreased because now most patients relapse within 12 months. So most patients will receive CAR T, will not receive chemo and auto transplant. So in general, both autologous and allogeneic have really dropped in the lymphoma setting with the introduction of CAR Ts. And when we consider allogeneic, when the patient has progressed after both CAR T and bispecifics, that's when we are considering salvaging the patient with something else and then potentially considering an allogeneic consolidation. But there we do see that, what does donor availability looks like? What is the age and comorbidities of the patient? So we do discuss these patients kind of on the lymphoma board on a one-to-one individual case-by-case basis.
Thank you so much for دكتور.
ممكن سؤال محمد؟ ممكن سؤال؟
اتفضل دكتور مجدي اتفضل.
Thank you very much for this actually nice presentation. I have actually two short questions. The first, CAR T cell has still depend on auto T cell. What's about allo T cell? The second question, what's its use in solid tumors?
So really exciting questions that, I think that there's no clear answer. So I have, as you mentioned, really well, just talked about autologous CAR T cell products because these are the ones which are out in the market. Allogeneic products are also being tested in multiple clinical trials. And, I think the results are encouraging, but they are not still mature enough to consider that we will have them available in the clinic in the short run. So I think it's still many years until we have these products available to offer to our patients outside of the trial setting, mainly because responses do not seem to be durable. And that is one of the main issues. So I think there's still a long life left for autologous CAR T-cell products. Allogeneic still seem to, they still seem to be immature, and they still need to work out how to make them persist longer and how to make sure these remissions are durable. So right now, all we have is kind of data looking at preliminary efficacy, which, is looking good, a little bit lower than with autologous, and lack of like GVHD and lack of severe ICANS and neurotox, higher than autologous. But they seem to be safe and kind of encouraging preliminary efficacy, but we still need, to have, more durable remissions. And I think it's still a long way before these are available in the clinic. We will have a couple of trials with allogeneic CAR T cells, but probably still very preliminary. And for patients who relapse after probably an autologous CAR T cell product, or very interesting setting as well, for patients, there is a couple of trials looking at this, patients who receive a CR by PET, but are ctDNA positive after first-line immunochemotherapy. So they are looking in one trial to offer allogeneic CAR T-cell products to consolidate this response. So patients who achieve a CR or PR per PET after R-CHOP, after 6 cycles of immunochemotherapy, if they're ctDNA positive, then you can offer them allogeneic CAR T-cell product to consolidate that response they achieved with immunochemotherapy. So there's, it's definitely many trials going on with these products, but I think it's still a long ways before we can offer them to the public. And regarding solid tumors, we are treating in our center solid tumors, which we care for on our ward regarding CRS and ICANS, not so much with CAR T cells, but with similar products, TCRs and other similar products, TILs, tumor infiltrating lymphocytes. Probably also still a long way far from getting CAR T-cell product approved in solid tumors. The target antigen is definitely a problem for solid tumors, and that's where hematological malignancies have an advantage. So I think it will still be a long time before we see a CAR T-cell product approved for a solid tumor. Just very, very preliminary efficacy and not as encouraging as in the hematological malignancies.
Thank you so much for you, Dr. Gloria. We appreciate your participation at our meeting. And I would like also to thank you for your support during my stay at your units. It was very interesting rotation. Thank you so much, and muchas gracias.
Thank you so much for the invite. It was a pleasure being here, and I look forward to working with all of you in the future.
Thank you. Bye.
Okay. Assalamu alaikum. Our next speaker, Dr. Eleni Gavriliaki, MD, PhD, received her medical degree from the Aristotle University of Thessaloniki in Thessaloniki, Greece, in 2010, where she then participated in a postgraduate program in medical research methodology. In 2014, Dr. Gavriliaki completed a residency in internal medicine and at the General Hospital of Edessa in Thessaloniki, Greece, followed by a postdoctoral fellowship at the Johns Hopkins School of Medicine in Baltimore. MD. In 2016, Dr. Gavriliaki completed her PhD
with the Aristotle University of Thessaloniki and went on to become a hematology fellow at the George Papa Nikolai Hospital in Thessaloniki, Greece. Dr. Gavrieliaki currently serves at the Aristotle University of Thessaloniki in Greece, speaking on monoclonal antibody therapies for TMA. Dr. Gavrieliaki research is primary in the field of transplantation. She has published many studies investigating the treatment of transplant-associated thrombotic microangiopathy, an endothelial damage syndrome that is increasingly found as a complication of autologous and allogenic hematopoietic stem cell transplantation. Many of these investigations have explored the therapeutic potential of monoclonal antibodies. Dr. Eleni, the floor is yours.
Hello, I hope you can hear me well.
Yes.
Thank you very much. Thank you very much for the kind introduction. It is my great pleasure to be among you today. Can you see my slides?
Yes.
Can you see my slides now?
Yes.
Great. Thank you. So it is my great pleasure to start the benign hematology talk, and I find your program really interesting and really balancing between malignant and benign hematology. As you kindly introduced my story, you can see that I started basically from malignant hematology, but I always had a love for platelets and bleeding disorders. And I think it is a very nice spectrum that may not seem so high-tech right now, but is certainly beneficial for patients. And I want also to highlight that these patients usually do not have an underlying malignancy, and these patients should have a normal life expectancy, which sometimes we kind of neglect in our everyday clinical practice, that we deal mostly with malignant hematological diseases. So my topic here is acquired bleeding disorders, and I think these three are the most important key takeaways from this talk, and these apply to all bleeding disorders. So we should first assess the when, the timing, and the duration of the disorder, then assess the degree of bleeding, and we have several tools to do that. First, an experienced clinician can do that by a very short history, but we also have dedicated tools like the ISTH BAD score, which is very convenient and very easy to use, and then have our eyes open for other findings which might help us guide the diagnosis and the treatment of our patients. Of course, we know the difference between petechia and purpura, which we see in the patients with bleeding disorders, and the difference between them and the chemosis. We have to really pay attention and really describe well which kind of bleeding disorder our patient has. That might lead us to the component that starts this disorder, and this is hematoma in the arthrosis, hemarthrosis, if you can say that. And also this leads us to factor disorders, factor-related disorders. So we have seen the major types of bleedings, and this leads us to the major components of hemostasis. Where is in our patient. It may be in the coagulation. I like this timeline because it gives us a historical perspective of how much we know and maybe how little we know on some components. So the coagulation has been described since the 1950s with this relatively old and teaching material of the intrinsic and extrinsic system that all lead to the common pathways we know. However, we have now updated our knowledge to the cellular model that we will discuss later. I think for teaching purposes, however, and also for all of us to be reminded in our everyday clinical practice, we have to learn the intrinsic and extrinsic system. As we will know, as we will see later, this interprets the factor times that we measure. Then we discovered the platelets. This was my PhD topic. Platelets, as you know, are very hard to study, and we have very few biomarkers to platelet activation. And finally, we discovered endothelium, and this has been a very important target of studies in the last decades that may lead to translational perspectives in some of our patients. So these three major components, we divide them, of course, for our thinking reasons, but are in constant collaboration with each other in this cycle. Of course, what happens in our body cannot be really described into steps. It is a simultaneous process where vascular injury leads to the activation of the coagulation cascade and platelet activation and vasoconstriction as well. So we have to think that everything happens in one time in our patients. But what happens in our everyday coagulation testing that we use to assess our patients? We know then that we have to think with the intrinsic endogenous pathway or the extrinsic exogenous pathway. We know that different extrinsic, it's easy to remember that the exogenous pathway is mostly through tissue factor and factor 7, while the endogenous is 12, 11, 9, 8, and then we have the common pathway where factor 10, 5, 2, and fibrinogen play a role. So we know that in our everyday clinical practice, we measure APTT, where we can assess for all proteins except for tissue factor and factor 7, and we measure the PT, which we can assess for the factors of the 7, 8, 5, 2, and fibrinogen. So how to interpret the PT? If we have an isolated prolonged PT time, we have a factor 7 deficiency. And this prolonged PT may be also in association with other coagulation abnormalities when we have all these potential underlying causes, which we have to always remember, because sometimes we try to find a rare or acquired bleeding disorder, but eventually we have an underlying disorder, which might be a simple vitamin K deficiency, or the patients might be in vitamin K antagonist, liver disease, malabsorption, high concentration of unfractionated heparin, a direct thrombin inhibitor, factor 10A inhibitors, we know them as DOACs. Important but easy to find is afibrinogenemia and dysfibrinogenemia, which measured by fibrinogen levels. We have, of course, to take into account that this regulation might be delusional in a massive blood transfusion. We might have concomitant clotting factor deficiency, and this happens in real life. In our Hemophilia Center of Northern Greece, we do have patients with coinciding deficiencies. We might have some more rare abnormalities of the vitamin K cycle or chromosomal aberrations which are more difficult to detect. And the shortened PT, of course, is a result of our treatment with recombinant factor 7A or Novo7. So, what do we do when we have a prolonged PT? We always do these mixing studies with normal plasma, and this is very easy to do in our lab. And if the PT corrects, we have a factor deficiency, accordingly, as we said in the previous slides. If the PT does not correct, it means that we have an inhibitor present. And more rarely, a lupus anticoagulant, which might be more common in APTT prolongation.
ايش صار؟
Surgery, and thanks God someone checked their PT and APTT time, and it is important because this might an isolated prolonged APTT is a result of certain deficiencies of certain factors, so we have to check only these factors. And it may be a result of the contact factor deficiency, and most importantly, which is an emphasis for our talk, is the acquired clotting factor inhibitors. These are most commonly detected against factor 8 and may occur as either autoantibodies, that means we have acquired hemophilia A, or as alloantibodies, which are the inhibitors we know in patients with a history of congenital of severe hemophilia A following exposure to our recombinant factor 8. And they are very rare, these inhibitors, but they also may occur to other factors. And most importantly, the lupus anticoagulant means that this anticoagulant targets the phospholipids and can result in an isolated prolongation of the APTT. And this, of course, does not mean that the patient has a bleeding diathesis. It might need, we might need to check the patients for a thrombotic diathesis. A short APTT, an acute phase response leading to high factor 8 levels and difficulties in collection of samples, which may seem very raw and very easy, but we have in these samples to take exactly the required amount of blood, as we know. So how do we interpret an isolated prolonged APTT time? We do again the mixing studies as shown in this recent diagram, and if we correct and we have again an isolated APTT prolongation, which means that we have a normal prothrombin time, we have we assume that we have a factor deficiency. If they do not correct, we screen for lupus anticoagulant, and if it is positive, this is the reason of our prolongation. If it is negative, we have to do more specific factor inhibitor assays. We do not have to forget the role of fibrinogen. Of course, this is more often in our routine testing and more easy to assess in everyday clinical practice, along with the role of D-dimers. So, how does a patient with acquired hemophilia present? It's usually an older patient that presents with prolonged APTT, isolated prolonged APTT, that means normal PT. We do this mixing study, and normally this mixing study is inhibited, which means that we might have specific factor inhibitors. This is a dramatic clinical phenotype, and if you see it once, then I don't think you can never forget it. These are this is one of our patients, and these are the images from the recent educational article at Blood. Very similar, as you can see, and very quick progression of these hematomas. These patients might have a severe underlying disease, but they often do not have a very difficult history, and we have to assess them mostly for cancer and other autoimmune disorders. So why do some patients have this acquired hemophilia? Do they have a genetic predisposition to it? And this is a question that we raised because we had the feeling that we had more diagnosis of acquired hemophilia A into our population, which are referred to us because of the hemophilia center need of recombinant factor 7 factors. And this is a very nice review article that you can read online. It is publicly available, where we try to explain the genetics and epigenetics in acquired hemophilia A and what leads to a severe clinical manifestation. And these are genes, polymorphisms, and some comments. It's very interesting that we might have the rare diseases, but we still have a genetic susceptibility due to a common polymorphism, a common variant. I think this is something that we will see in other rare disorders in the future as well. So what do we do with this patient? We say that we need immediate treatment, and of course the most important component of this treatment is the recombinant activated factor 7 when we have a clinically relevant bleeding. And this is very important for us to understand and also to explain to our fellows that recombinant factor 7 does not have a clear role when our patient does not have an active bleeding. Or to say it in other words, if we have an active bleeding, then we consider recombinant activated factor 7. We always have to have its availability when we have a patient with acquired hemophilia. So if the bleeding is stable, then we can stop for several doses the factor 7 and then start again if we have an active bleeding, because the factor 7 just bypasses our clotting ability and does not really treat the underlying condition. So to treat the underlying autoantibodies, we have to eradicate them with traditional treatments with steroids alone, or we try, because these patients are mostly of higher age, to add a low dose of cyclophosphamide or rituximab as early as possible. This depends on the treating physician decision. Moving on to another acquired disease, I think this is also a neglected disease, and we hope that we will diagnose it more in the future. And I urge you to search it more in your departments also of hematological oncology, because the acquired von Willebrand disease is just the tip of the iceberg and might be the reason of unexpected bleeding in many of our disorders, lympho-myeloproliferative disorders, but also other disorders such as cardiovascular, immunologic, cancer, and drugs. So again, the diagnosis is simple. If we are able to interpret the test, we test for factor Willebrand from Willebrand factor, and we typically test for both the antigen and the activity, the aristocytin activity, and we also have this ratio of the activity to the antigen. So if the ratio is the antigen is reduced and the ratio is normal, and we have an underlying condition, then consider the acquired disease. Again, this is the same if only the ratio is reduced. We should always consider the acquired from Willebrand disease. So it is very interesting that we need to have this Willebrand testing before surgery or intervention with high bleeding risk, and again consider acquired for Willebrand disease in these patients. Interestingly, we might the acquired Willebrand disease might be sometimes the first finding in our patients, and then sometimes in some of our patients we have discovered a few years later a monoclonal gammopathy and then multiple myeloma. So we talked in the beginning, and we want to think more how this happens in our body with this cellular model of the coagulation cascade. So. And everything happens simultaneously. We talked about isolated prolongations, but we may have, of course, combined prolongations, with is mostly due to underlying causes, as we said, and then medication is acquired antithrombin 3 deficiency. My understanding is that many of us may test for antithrombin levels, but we may not be able always to explain why we have this deficiency. And so this might happen due to liver dysfunction, consumption, in preeclampsia, in AML, in association with L-asparaginase that we should not forget in patients with ALL mostly, due to proteinuria, due to heparin therapy, active Crohn's and ulcerative colitis due to poor nutrition, dilutional due to hemodialysis, in cardiopulmonary bypass, and in plasmapheresis. So these are all important factors, and acquired antithrombin deficiency should not be neglected. And similar are the reasons for acquired protein C deficiency, and what in this case we may have apparently low levels in factor V laden patients, in patients with elevated plasma factor 8, in patients with dyslipidemia. What about S3 levels? This might also be low due to similar causes, may also be low in sickle cell disease. Another, I think, very important for clinical practice and consultation issue is postpartum hemorrhage that may be a part of acquired bleeding disorders. And what does this mean? We usually get a call from our OBGYN colleagues, and they say we have a blood loss within 24 hours of delivery, and the definition is either more than 1 liter or blood loss with signs or symptoms of hypovolemia, and we all know what does that mean. This is a quite common complication of delivery. It's a leading cause of obstetric maternal death worldwide, and there is this 4 T's rules: the tone of the uterine, the trauma, the tissue, and the thrombin. And we see that most causes are localized or OBGYN, and unless we see an inherited or acquired coagulopathy. Please. So most of them are obstetrician driven, and rarely we have hematology driven causes. due to hypopharynginemia, which we need to do transfusions, but as well due to hyperpharynolsis, we can give tranexamic acid, which is very important to remember that we need to give the appropriate dose for our patients who are indicated because many of us tend to give lower doses of tranexamic acid than what is considered. So there are guidelines, and we always can take a look on them. This study administered 1 gram of tranexamic dose and additional 1 gram if continued bleeding at 30 minutes or if bleeding restarts within 24 hours. We have to highlight that it's a very low-cost drug and very efficient when indicated, and many more studies can be seen in the literature. What about platelets? We do have acquired platelet disorders. We have these general causes that we all know about, renal disease, liver disease, bone marrow disease, of course some drugs, cardiopulmonary bypass, antiplatelet antibodies, and some acquired storage pool disorders which are more rare. So thank you very much. I hope this was useful and practical, and I'm ready to hear your questions.
Thank you, Dr. Eleni, for your interesting talk. And the floor is open for 1 or 2 questions.
Can you hear me?
Yes, we can hear you.
Dr.
I have a
Abdallah.
question, please. How would you approach a patient with factor VIII inhibitor of 3.4 Bethesda units who is asymptomatic but requiring an operation?
Apologies, but I cannot really hear you.
I'm asking a question concerning your approach to a patient with factor VIII inhibitors who is asymptomatic with Bethesda units 3.4 who needs an operation. How would you approach such a case?
I'm not sure if you have asked something. I cannot really hear the questions.
Did you hear me, please, Dr. Eleni?
Excuse me, you have some
Maybe,
problem with your speakers.
do you
Could
want
check the
to-
speakers?
Type something in the chat.
Can you hear us?
Can you check your speakers, please?
Can you hear us?
عندها في مشكلة عندها مش سامعة. احنا عندنا صوتنا طالع.
No?
سامع من عندها؟
Can you hear us? ما بتسمع.
في عندنا مشكلة من الأول السماعة مش شغال عندها، في عندنا مشكلة.
خلاص.
Dr. Eleni, please, did you hear us?
لا مش سامعتنا. Okay.
أشرنا هذانا.
Very interesting question. I hope you can hear me. I will also write down in the chat. So it's important to see, I are talking about an acquired hemophilia A patient, and this patient, when we have the APTT, the prolonged APTT, and then we found that the presence of the inhibitor, we always have to treat these patients even if there are still no symptoms there with eradication of the autoantibodies. So we have to postpone the operation if needed. And if there are no symptoms, we only have to treat the inhibitor without factor VII. If we have bleeding, we add factor VII. If the operation cannot be postponed, then our suggestion is, it's very critical, our suggestion is to proceed with factor VII to eradicate the bleeding risk as we do with our hemophilia patients. And then thank you for this question. Another important thing is that I didn't have the time to mention was that we, in very refractory cases, we have also We have also administered and considered off-label use of emicizumab, which is a new agent in hemophilia A. Maybe we will have to discuss it later in later lectures. And we had a very good result in these patients.
Is there any questions? Thank you, Dr. Eleni. Thank you. دكتور إليني ما يسمع حدا. مين السكند سبيكرز؟
Thank you so much. Bye
Thank
bye.
you, Dr. Eleni. Thank you for your interesting talk.
Good afternoon. Yes, I think Dr. Ruben.
Hi, Faraz.
Hi, how are you?
I'm good, thank you.
Yeah, thank you for joining us. So we're starting. We're good to go, Dr. Ghadir? Yes, we go. Okay, so yeah, I'm very pleased to introduce our next speaker to talk about an important topic, which is multiple myeloma in the relapsed refractory setting. And it gives me a great pleasure to introduce Dr. Ruben Benjamin, a clinical senior lecturer at King's College Hospital, London, and King's College London. He's a honorary consultant hematologist. Dr. Benjamin is a clinical senior lecturer and with a special interest in multiple myeloma, stem cell transplantation, and CAR T-cell therapy. He's the academic lead of the CAR T-cell program at King's College Hospital, London, and he runs a research group at King's College London focused on investigating mechanisms of resistance to CAR T-cells, developing the next generation CAR T-cell targeting cancer and autoimmune diseases, as well as exploring the biology of multiple myeloma. Dr. Ruben was the chief investigator of the CAN trial, which is the first allogeneic CAR T-cell trial of its kind, and he is currently setting up a point of care for CAR T-cell manufacturing at King's to support in-house academic CAR T-cell trials. Dr. Ruben, we are pleased to have you again in our Jordanian Society of Hematology conference that we run annually. I think this is your second or third time with us, and we are always pleased to have you. So please, the floor of yours to give us your talk. Thank you.
Thank you, Faraz, and thank you for the invitation to speak at this meeting. Yes, you're right. I have spoken at this meeting twice before. I think the first time I came in person, it was just before the COVID pandemic, and then we didn't really do very much traveling for a long time afterwards. So yeah, it's great to be back. Let me just see if I can share my screen. Have I been given permission to share yet? Because it says...
No, yeah, you need to share the window of your presentation.
But have I been given permission to share? Because it says...
Okay, is your presentation is running in the background? Please make sure that your presentation is running before you start sharing.
It is running, yes.
Okay, and then go to the sharing box and select the PowerPoint logo. بعت لنا اياها تبعتوها مش يعني
Permission to share content. It says, make sure you've allowed permission to share content. Is that some other setting I have to change?
Yes, you need to give a permission for the sharing due to the security issue, the restrictions from the Apple OS.
Okay. How do I do that?
Midhat, do you know how he can give access or?
Does it give you any indication about the share or like daily box? It says that you should or you can do something. Any notification from the PC? Okay, if you have some issues with it, can you send
Yeah,
it by
I
email?
think I've sent you the slides. Yeah.
Okay, let me check. Okay.
Yeah, Dr. Ruben, I think your computer is iOS. Are we
Mac.
okay? I think you could share it. Or did you send the slides?
I have sent you the slides. Yes.
Oh, okay. So I think we can view the slides from our side, and but you need to tell us when to move to the next slide.
Yeah. I can do that. Yeah.
Midhat, you will be moving slides. No, this is not the one. No. Sorry, we opened another presentation mistake. This one, yes. The one, yes. That's it. But would Dr. Ruben be able to see also the slides as he speaks? Okay. So Midhat, you are running the slides. It will be from our side. Okay. Okay. Oh. Oh. Okay. So now we are starting slides from our side, and Dr. Ruben, you can see them also.
Yes, I can see them. Great, thank you.
So I will be moving the slides as when you say next, I will move it to the next one.
Sure. Okay. So, you know, I've been very fortunate to be involved in the field of myeloma for the last few years, and we've seen enormous advances, you know, in the treatment of patients with multiple myeloma, although the cure remains elusive, sadly. So what I wanted to do today is just really to highlight some of the more recent treatment advances, you know, some of which you may be familiar with, but just try to put that into context with some case studies. Next slide, please. Next slide.
Yeah.
Yeah, so you know, this slide really illustrates the timeline of the treatment advances in myeloma. So back in the 90s and 2000s, we had the introduction of the IMiDs and proteasome inhibitors. But it's really been since 2015 when we've had this explosion of drugs that have been approved for treatment. And you can see that we've had a number of different monoclonal antibodies, as well as in the last few years, most excitingly, you know, the advent of CAR T cells and bispecific T cell engagers. Next slide. And if you look at what these treatments have resulted in terms of outcomes, you know, we can see that probably about 50% of patients now will reach 5 years, you know. But that doesn't tell you the full story. Next slide. Because if you were to break down patients based on their genetic profile and risk status, you will see that if you are a standard risk patient, you know, your chances of surviving to 5 years is well over 80%, whereas if you are a high risk patient, your chance of surviving is still only about 40%, you know, and PFS is down to about 24%. Now, this particular slide is a few years old because it is just possible that with the advent of cellular therapies and immunotherapies that these numbers might change, including for the high-risk genetic patients. Next slide. But when you try and look at the outcomes, you know, based on sort of lines of treatment, this is just a very crude slide that highlights that with every relapse, a myeloma patient has progressively shorter and shorter periods of remission. So now we are very fortunate as upfront setting, you're having up to 5 years potentially of a remission with standard first-line treatments. With a second-line regimen now, you're getting about 2 to 3 years. Third line, maybe just under 3 years, but then it suddenly falls off, so that by the time you got to fourth line and beyond, your survival is less than 6 months. Next slide. Next slide.
Yeah, just 1 second. So.
But, one thing that may make a big difference is the advent of CAR T cells. So this was the first CAR T cell product that was introduced for myeloma, ide-cel. This is targeting anti-BCMA. And the very first sort of pivotal study was the KarMMa study that led to its approval initially at sort of 5th line by the FDA and 4th line by the EMA. But then last year we had the KarMMa-3 study where this CAR was given earlier in the disease, and that's led to its approval after 2 or more lines of treatment. Next slide. So if we were to just remind ourselves of the original KarMMa study, which enrolled patients who'd had at least 3 prior lines of treatment, including an IMiD, a PI, and an anti-CD38 antibody, you will see that although the vast majority of people responded, well over 80% of patients had at least a partial response, if you looked at the durability of the response, that wasn't as good as we had hoped. So at the highest cell dose, you were getting a PFS of about 12 months. But if you were to look at patients who had a deep response, so those who achieved a CR, which was about a third of the patients, they had a duration of response approaching 19 months. But nevertheless, the plateau in the survival curve that we had hoped for and that we were seeing from the lymphoma settings, we have not seen this with ide-cel. Next slide. But naturally, as this whole field has progressed and CAR T cells have been brought further up in the treatment algorithm, in KarMMa-3, patients who had 2 to 4 prior lines were treated. Now in KarMMa, the median prior lines was 6, so here it was 2 to 4. And in this study, it was a randomization between patients receiving the ide-cel product versus standard of care. And you can see that there's a number of different chemotherapy regimens that were allowed as part of the standard of care. And again, you can see that those who received the ide-cel regimen, had the best survival, 13.3 PFS compared to just 4.4 months in the standard of care regimens. There was some criticism with the study that the standard of care arm had a much worse PFS than you might expect for patients receiving the kind of regimens that they received on this study. But nevertheless, about 13 months is what these patients were getting if they received the ide-cel product. Next slide. And whilst we're all very aware of the toxicity of the CD19 CARs for lymphoma and for ALL, fortunately in the myeloma setting, these CARs seem to be very, very tolerable. So if you were to look at cytokine release syndrome, although the majority of patients do develop some form of CRS, if you look at grade 3 or more CRF, it's less than 5%. And similarly, if you were to look at neurotoxicity, less than 3% it had grade 3 or more ICANS. Next slide. In parallel, there was another CAR T cell product being developed, and this was the cilta-cel product, again targeting BCMA, but with a different binder. And in the initial studies, the LEGEND-2 and the CARTITUDE-1 trial, where patients with late relapse were treated, we had some very impressive results. And this was then followed more recently by the CARTITUDE-4 study, where patients who'd had just 1 prior line of treatment were offered this drug. And again, the results were pretty amazing. And this has led to its approval now at 2nd line for those countries that have access to it. In the CARTITUDE-1 study, you can see that 97% of these patients are responding, and deep responses for that matter as well. So 67% of patients are getting a complete response. And the median PFS is 34.9 months. So this is the best response you're getting for any drug in relapsed myeloma, 34.9 months. But if you are to look for a plateau, unfortunately, it doesn't seem thus far that there is a plateau in the survival curve. So it looks like, for whatever reason, there is a mechanism of tumor escape at some point in patients who receive cilta-cel. Next slide. So, if you're trying to see whether cilta-cel in an earlier line of treatment works better, in CARTITUDE-4, where again it was a randomization between cilta-cel and standard of care chemo, either Pom-Velcade-Dex or Darapom-Dex, and you can see that at the time of publication, that the 30-month PFS was well over 59%. So again, you're talking about a median PFS of probably higher than 34.9 months that the CARTITUDE-1 trial showed. So you can see that as you start to give products earlier in the disease, you are starting to see better results. And that kind of makes sense because the T cells that you collect from patients earlier in the disease are likely to be sort of fitter than the T cells that are collected once you've had multiple lines of prior treatment. So now in the United States and some parts of Europe, patients at first relapse are getting the cilta-cel product. Next slide. Just a few other things to mention about cilta-cel. We've talked about the ide-cel toxicity profile. Again, with cilta-cel, CRS and ICANS risk is very low. But what did emerge in the early study is a novel neurotoxicity complication called MNTs, motor neurocognitive toxicity. And this was an unusual phenomenon where patients were getting it probably beyond about 30 days. And they were developing Parkinsonian-type symptoms, cognitive impairment, and it was not responsive to steroids or anakinra or siltuximab in the way that ICANS usually does respond. And it wasn't clear what the cause of this was. Was it an on-target effect with BCMA being expressed on basal ganglia, which was one of the hypotheses, or is it some other kind of cross-reacting antigen that the BCMA CAR is binding against? It is still not very clear. But what does seem to be emerging, and there's a number of publications that have come out in the last year, in the US in particular, where they're treating quite a few patients with cilta-cel in the real world, is that the development of MNTs seems to associate with developing very high levels of CARs in the peripheral blood. And, the thing to do is to try and give potentially chemotherapy regimens that will bring down the level of the CARs in order to restore the neurological function. And so people are given cyclophosphamide, people are given intrathecal chemo, and it hasn't wiped out the CARs, but it has just brought the level of the CARs down from the very high levels that they achieve. And so I think this is something that we're going to start to see much more as more and more patients get treated with the cilta-cel product. There will be a need to try and look at CAR levels in the blood, or at least a surrogate marker of the CAR, like the absolute lymphocyte count. And if that was extremely high in a patient to develop MNTs, then the recommendation probably will be that chemotherapy should be considered. And just one other thing to mention is about the second primary malignancies. At the time of the original publication, this wasn't reported, but now, we have seen a number of cases of T-cell lymphomas being reported in patients that received CARs across the board. So this isn't just restricted to cilta-cel. And people are still looking into the mechanism behind this. Is it the CAR that's driving a T-cell lymphoma, or is the T-cell lymphoma just an incidental kind of consequence in patients that have been heavily pre-treated with chemotherapy before? That's still an open question. But there have been some patients where the CAR construct has been found in the lymphoma tissue itself. So if anyone develops a T-cell lymphoma who's had a previous CAR, the recommendation now is that biopsy needs to be sent to look for integration of the CAR in the lymphoma tissue. Next slide. Now, the sort of new kid on the block is this product, anito-cel, not approved yet, but looking very, very good. This is a slightly unusual binder called a D-domain binder. So it's not your traditional scAV or VH domain CAR. It's a small protein that binds very effectively to its target, and the authors claim that it causes less tonic signaling, therefore less exhaustion, therefore potentially more efficacy. And in the phase 1 study that was presented in 2023 at ASH and then subsequently updated last year, you can see that the response rate is 92%, MRD negativity in the vast majority of these patients, and the 24-month PFS is 56% still. the median PFS has not been reached yet, but this is looking like a really good competitor to the cilta-cel product now. And again, the toxicity profile is very good. And importantly, there's late MNTs that you're seeing with cilta-cel has not been seen so far, at least with this anito-cel product. Next slide. So, can we be even more ambitious and say, well, for myeloma, can CAR T cells replace stem cell transplantation? Could it be used as part of upfront treatment? CARTITUDE-6 study is looking exactly this question, randomizing patients following induction treatment to stem cell transplant versus cilta-cel, and we'll see what that shows. Keep going. Carmen-9 study is looking at using ide-cel to consolidate patients who've had a autologous stem cell transplant in patients who haven't reached a CR, so they're trying to deepen the response to the transplant. Unfortunately, I think this study has now just been pulled, and so we may not get a readout from this study. Next slide. And CARTITUDE-5 is a study that's looking at the use of cilta-cel product in older, frail patients, who are not considered to be suitable for stem cell transplant, because of the concept that perhaps a CAR might be better tolerated than a transplant. And this study has completed enrollment. We'll probably see data being presented maybe at ASH next year if we're lucky. Next slide. And then even more ambitious, to use cilta-cel to try and treat high-risk smoldering myeloma. So as you can see, that we've started off in the late relapse setting, we brought it up into the early relapse setting, and now we've gone right to the other end of the spectrum and trying to treat even sort of precursor disease. Next slide. So I want to briefly now mention about an alternative type of CAR product, which is the allogeneic CARs. And so, for a whole host of reasons, there is a desire to try and see if we can have an off-the-shelf product that can be given to patients where you have cells that are pre-manufactured, you don't have to actually generate the product in real time. And the Universal study was the first study that looked at an allo-BCMA CAR product for multiple myeloma. And they looked at various different doses here. They also looked at various different lymphodepleting strategies, most of which required the use of alemtuzumab, unfortunately. And if you look at the results, next slide, you can see that, unfortunately, although the responses were not bad, 50 to sort of 70%, the durability of the response was not great. I think in the best sort of group, which is the 320 million CAR group, you were getting duration of response about 8 months. So I think the main reason for this is the lack of persistence of these CARs in the allogeneic setting. Even though you're lymphodepleting the patient heavily, the host immune system recovers and rejects these CARs. So if we want to see allogeneic CARs really become a thing in myeloma and in cancers in general, we have to improve the functional persistence of these products. Next slide. So this is a case study of a 46-year-old with myeloma, high-risk patient who had standard first-line treatment at the time, Velcade, thalidomide, dexamethasone, and transplant, and relapsed at 2 years. Went on to second-line treatment with Dara-Velcade, Dex, and then third-line with ixazomib, Dex, and then relapsed, and then was referred for CAR-T at the time to a clinical trial. During the trial, the patient needed bridging treatment with elotuzumab, Pom-Dex, but there were manufacturing delays. And this seems to be a feature with a lot of myeloma patients where manufacturing the product is often problematic. And during this bridging period, the patient developed infectious complications, the disease progressed, developed cord equina, needed treatment with local radiotherapy, but luckily managed to get the patient back under control. And then on the second attempt at manufacturing the CARs, that was successful, and the patient received the CARs. But by the time the patient was treated, the patient had very high levels of disease in the bone marrow. And this then translated into a reasonable level of CRS grade 2 lasting 5 days, needing toci, steroids, and anakinra. We don't normally need to do such intensive CRS management in the myeloma setting, but occasionally this can happen. So it's just to illustrate that you can develop complications during bridging, particularly in the myeloma patients receiving CAR-T, where manufacturing can be an issue, and the high disease burden therefore can be sometimes problematic. Next slide. A second case study of a 46-year-old with standard risk myeloma who presented with a very interesting kind of rash called pityriasis rubra pilaris. he was treated with standard first-line treatment and had a transient response, but then progressed shortly after his stem cell harvest with a very kind of proliferative picture, high CRP, fevers, and myelofibrosis. At that time, there were a number of options. Do we go to standard second-line treatment? Do we escalate to DT PACE? Or do we consider a CAR-T trial? And we had a trial open for high-risk first relapse patients, and the patient opted for that. But again, the manufacturing failed in this instance, but second time around was successful. So the patient was bridged with IRD and then DT PACE, and then finally received CARs. But this patient developed full-blown aplasia, which did not recover with just standard sort of GCSF, and so we had to do a stem cell rescue. It was just fortunate this was a myeloma patient who'd already had stem cells collected. Therefore, we had the opportunity to give stem cells. We're not always faced with this luxury. But this case, I hope, highlights that sometimes the cytopenias associated with CARs can be quite significant. So these are some open questions for the myeloma CAR-T field. Are there alternative strategies, to CAR-T cells? Can you do a second transplant? Because we have to accept that many parts of the world do not have access to CARs. So a second transplant is a reasonable option. Allogeneic stem cell transplant went out of fashion several years ago for myeloma, but still remains an option in a small select group of patients. And then we'll come to another exciting treatment called BiTEs. There's still a question about when to collect cells. Do we try and collect it earlier in the disease if we could? What is the best bridging strategy? And then I think there's some discussion about whether if we have a CAR that only gives you 12 months remission, can we use that as a bridge to something else, like a bridge to an autograft or a bridge to an allogeneic stem cell transplant? And some groups are doing exactly this. Next slide. It's just worth noting that many of the early CAR-T trials excluded plasma cell leukemia, amyloidosis, patients with poor performance status, patients with organ dysfunction. So when we start to treat patients in the real world, we just have to bear in mind that the trials did not represent these groups of patients, and the results may not be as good. Next slide. So, I want to just turn, for the next few minutes just to bispecific T-cell engagers, because this probably is a drug that is more accessible, globally, And the concept here is that you have an antibody that binds both your tumor cell as well as your T-cell and activates the T-cell locally at the site of the tumor. Next slide. And we have the luxury now of having 3 approved bispecific T-cell engagers for myeloma. The first one being teclistamab, again, a BCMA CD3 BiTE, and it's approved for relapse myeloma after 3 prior lines of treatment based on the MajesTEC-1 study, where patients with 5 or more lines of treatment were treated, 63% response rate, but a median PFS note of 11.3 months. So although we're very excited about the bispecific T-cell engagers, we're not seeing durability of response as much as with CAR-T, but maybe the toxicity profile is better, perhaps. Although one thing that is emerging is the high infection rate, and we have to really get on top of the infections very early on, because there are patients that are losing their lives from poorly controlled infections. And now teclistamab is being combined with a variety of different other agents to try and see if we can further improve the activity of this drug. Next slide. The 2 other BiTEs are elranatamab, another BCMA BiTE, and in the MagnetisM-3 study, there was an overall response rate of 61% and a median PFS of 17.2 months. People are looking at other targets like GPRC5D, and talquetamab targets GPRC5D. And again, the duration of response is, probably 10.2 months at best. One novel side effect for GPRC5D is the skin and nail adverse events and the esophageal kind of dysgeusia that they get. And that's because of GPRC5D that's expressed in epithelial cells. And that's something to be aware of when you treat patients with talquetamab. Next slide. And, people are looking at a whole host of other targets here, CD38, SLAMF7, FCRH5. And so I think you're going to hear a lot more CAR products and bispecific T-cell engagers targeting these other agents, because one of the mechanisms of BiTE and CAR-T failure will be antigen downregulation. So we will need to be targeting other antigens, at the time of relapse. Next slide. Now, I wouldn't want people to think that cellular immunotherapy, you know, in the way of giving CAR T cells and BiTEs are the only drugs around for myeloma, because they're not. You know, this class of agents, the cell mods, which sort of developed from the IMiDs, are also another exciting group of drugs. And we have two drugs that are not quite approved yet, but are in late-stage clinical trials, iberdomide and mezigdomide. And I just want to show you in the next slide the mezigdomide data, where when it was combined with dexamethasone in patients that had, you know, 3 or more lines of treatment, there was about a 41% response rate and a median PFS of 4.4 months, with those who went into CR achieving a duration of response of 7.6 months. You know, you might say that's not amazing, you know, but then the bar for success has been set so high now with CAR T cells and BiTEs that any drug that follows we seem to expect, you know, a lot more. You know. But mezigdomide is now being combined with a PI and other drugs. So, you know, just my kind of concluding kind of couple of slides, I just want to highlight, though, it's not just about drug treatment in myeloma that makes a difference, particularly in the relapse setting. You know, it is about the supportive care and management. So we are increasingly using whole body imaging to try and detect extramedullary lesions that might benefit from local kind of treatment with radiotherapy, for instance. You know, we have to be conscious of the infectious complications of myeloma. People are not necessarily dying from their disease, they're dying from infections. So judicious use of antimicrobials, making sure they're vaccinated, and importantly, giving prophylactic immunoglobulins to those with hypergammaglobulinemia forms a really, really important part of the treatment of myeloma. And I just cannot stress enough that as you start to go down the lines of treatment, ultimately we do run out of options, and we mustn't forget that. And that happens quicker in some patients than in others, you know. So hence the importance for providing that psychological support to these patients, and ultimately to accept, you know, that at some point we have to say, you know, we need to draw a line and we need to switch our approach to palliation. You know. And in my final slide, I just want to highlight another case which just shows you the repertoire of drugs we've got. You know, in a chap with myeloma, stage 1 disease. Next slide. If we just keep pressing the slide, you'll see the different treatments he's had, starting off with PAD, then a transplant, and then ixazomib, and then he keeps going and has additional lines of treatment, and then a second stem cell transplant, and then he goes on to a bispecific T-cell engager on the trial, and he has a very long remission initially, but then progresses. He goes back onto pomalidomide-based regimens, Velcade, Panodex, and this is where he is now, deciding between a bromodomain inhibitor trial or selinexor dex, or indeed palliation, because this performance status is not so great at the minute. And these are the conversations that we're unfortunately having here. So, you know, I'm going to sort of stop here and leave the last slide as, so just go one more slide. I just want to use, I want to just leave you with this slide and this thought that, you know, we have not cured myeloma yet, but we have made enormous progress, you know, but that progress comes with a price of the costs involved with these drugs, and not all countries have access to these drugs, you know, and even in the UK here, where we're relatively well off, we just don't have access to many of these drugs. We don't have access to the licensed cars, for instance, you know. So I think there is room to try and have better treatments, you know, that are more affordable and more accessible. And I'll stop here. Thank you.
Thank you, Dr. Robin. Thank you for this talk, and this is really a very good summary for the treatment options for myeloma relapsing after the first beyond the first relapse. And I think I need to check the chat box here for any questions. Sorry, I was not checking that.
Can I ask a question?
Yes. Yes, Professor.
Thank you very much for your excellent presentation. My question is on the bispecific T-cell engagers and their effect on immunoglobulin. How long, in your experience, does it take for the patient to recover from this severe hypogammaglobulinemia?
Yeah, so because the way in which the BiTEs are given is continuous treatment, so the frequency might go down to sort of 4 weekly afterwards, but it continues to result in hypergammaglobulinemia. So as long as you're on the BiTE, you are likely to have severe hypergammaglobulinemia. So you have to remain on prophylactic immunoglobulins. Whereas with CAR T cells, although you get a severe hypogammaglobulinemia, eventually your normal plasma cells recover, and eventually, your immunoglobulins recover. That can take 12 to 24 months following CAR T, but with BiTEs, it continues. And that's something that people don't always, recognize.
Yeah, thank you, Dr. Mohammed Abadat.
Thank you. Hello. Thank you for your talk, Doctor. My question about the role of allogenic stem cell transplant in the setting, especially in Jordan, we don't have access to all these new drugs. What's the problem of allogenic stem cell transplant in those patients with the relapse after autologous stem cell transplant?
Yeah, I mean, most of the early data that looked at stem cell transplantation, the results were fairly disappointing, and the alternative treatments gave just as good a result, with less toxicity, which is why certainly most of the West, allo transplants were relatively sort of abandoned. But we in our center do allo transplants in a small select group of patients. We tend to do them very early on in the disease at sort of second response, or in patients who have achieved a deep response going into the transplant. But in the past, we were not able to achieve those deep responses in the relapse setting, whereas now you can. So I think perhaps in somewhere like Jordan and other countries where access to an allo transplant might be much easier, that I definitely think is a consideration. All I would say is that you shouldn't go into the allo transplant with significant disease on board, because it just doesn't work. You do not get sufficient graft versus myeloma effect to overcome 10%, 20% disease burden in going into the transplant. So if you can achieve at least transiently a deep response, VGPR or more, then it can be considered in high risk patients early on in the disease. But if you got to the fourth line, fifth line relapse, I would not do an allo transplant myself.
Mm-hmm. Yeah. I think there are no questions. I would like to, I think the chat box, there's no question. I would like to ask you something, Dr. Robin. I know it's important, like, to define in the lenalidomide refractory patients when they relapse. How you would approach this definition? How you would define lenalidomide refractoriness? And would you consider, if they are like on a small dose lenalidomide, would you consider them as refractory, or you would try it again in your second line treatment?
Yeah, so I mean, that's a kind of interesting question, Faraz, because you're absolutely right. We know for a fact that if you have patients that are progressing on low dose lenalidomide, if you then increase the dose, to 25 milligrams from the 10 milligram dose, you can still salvage some patients. So that is definitely the pragmatic approach. I think biologically, there are patients who develop mutations in cereblon, the target for lenalidomide, where it doesn't matter whether you increase the dose, you will not get a response. Now, in some countries, if you get a progression within 60 days, and that's the kind of official definition of refractoriness, then you are not allowed to kind of continue on that. So like in the UK, we struggle to continue a drug, if you've got clinical progression within 60 days of a drug. But yeah, absolutely. I think it's an entirely reasonable thing to increase the dose and see if you can salvage the patient again.
Yeah. I think Dr. Ines is trying to ask a question. While she sends her question, would you unmute her, or shall we ask her to send it as a text?
I'm unmuted. Do you hear me?
Yes.
Dr. Ines, go ahead.
Thank you, Dr. Rubin, for this great presentation. I just have one question. Do you think GVHD is something to be worried about when using allo CAR T?
Well, in the studies so far, because the TCR gene was knocked out, we haven't seen much GVHD in any of the allo trials that have happened so far. We ran the CALM trial, which was an allo CD19 CAR trial, and we only saw 2 patients out of 25 that got grade 1 skin GVHD that was treated with steroids. And I think the myeloma CAR T trial as well, they didn't really see very much GVHD. So because the product is fully depleted of TCR alpha, that's less of an issue, I think. What's more of an issue is the host immune rejection of the CAR.
Sorry, yes, Dr. Mohammed again.
Another question, Doctor. We have a patient with relapse refractory after two autologous stem cell transplant. We gave him a reinduction treatment, and he achieved CR. Do you recommend to continue daratumumab as a maintenance or for teclistamab? We have an option for compassionate use of teclistamab. Do you recommend to?
I mean, I think, look, you can do it either way. I mean, eventually you'll run out of options. So if you have the option of giving ongoing, you salvage the patient with a Dara combination, did you?
Yes.
Yeah, so I think it's reasonable then to try and maintain the patient on that regimen and then just treat with bispecific when they relapse again, you know, because I don't think there's any data to say that you will do better if you treat a patient at sort of low levels of disease. You might have less toxicity, that's true, but I think you can salvage a patient at frank relapse with a BiTE. So I would continue with what you're on now and then use the BiTE when you need to. Yeah.
Yeah. Okay, I think that's it. Thank you, Dr. Ruben. And it was a great pleasure to have you again. And hopefully we will have you again back soon. Thank you.
Thank you very much. My pleasure.
Good afternoon. Away from hematological malignancies and benign hematology, we'll move now for a breast cancer session. It's a symposium sponsored by Roche. I would like to thank them for sponsoring this lecture. And it's my pleasure to welcome Dr. Mark Verrill from the UK. He is a consultant medical oncology at the Northern Centre for Cancer Care, Newcastle upon Tyne, UK, the regional cancer centre for the north of England. He has more than 25 years of experience in clinical practice and leadership, including head of departments of medical oncology, leading clinicians for breast cancer in the Newcastle Hospital, the Northern Cancer Network chemotherapy lead for the NCCC, and the Northern Cancer Network comprehensive local research network leader for breast cancer trials and training program director in the medical oncology. He has a rich CV in many publications in peer-reviewed prestigious journal, mainly his main interest on breast cancer. He has many publications. He has lectured a lot on breast cancer all over the world. So now we are in the era of smart medicine, in the era of personalized medicine and better quality of life for our patients, especially breast cancer patients, where we have improving their survival and they are living long, and sometimes we are hoping for them to be cured in early stages. And so our lecture will be presented by Dr. Mark about smart medicine, the move towards subcutaneous solutions in breast cancer treatment. Please, Dr. Mark, you can join. I think he is. Please unmute yourself, Dr. Mark.
Can you hear me?
Yes, we can.
Excellent. Sorry, I was... Okay, I'm going to try and share, which I hope will work.
You can share your slides. Your computer is Apple or?
Yeah, it's Apple.
Mm. You can try to share, please. Okay, no, we can see. And I know
Okay,
that...
brilliant. The wonders of technology. It's wonderful to be in Jordan, and I was reflecting that the last time I was in Jordan was back, I think it was in 2016 or 2017, and I was talking about subcutaneous trastuzumab. So we're moving forwards now, and the subject of today's presentation is the subcutaneous formulation, a fixed dose combination of pertuzumab and trastuzumab.
Wow.
So these are my disclosures. My clinical practice these days is completely in breast cancer. So the journey of Herceptin and the anti-HER2 drugs is a long one, starting back in 1987 when Dennis Slayman published his pivotal paper in the journal Science, showing that in all comers walking through the doors of his clinic, and it was around 200 patients, all stages of breast cancer, if they were HER2 normal, so they lacked HER2 amplification, their median survival was 6 to 7 years. Whereas if they had HER2 amplification, and obviously I'm showing an IHC here, but if they had gene amplification, their median overall survival was only 3 years. That included patients with metastatic disease and early breast cancer. So it was a very potent and powerful prognostic indicator. But it took another 10 years for us to be able to use anti-HER2 drugs. So these are the binding sites of trastuzumab and pertuzumab. You can see trastuzumab binding to close to the cell surface and pertuzumab binding in the receptor dimerization domain. In metastatic disease, Cleopatra was the pivotal study. This is the 2020 update and showed an improvement in progression-free survival from about a year to about 18 months. And this improvement in overall survival from 40 to 57 months, so almost 18 months of extension of overall survival. And as you can see here, compared to that original Slayman paper that I showed you, when median overall survival in all comers in the era before anti-HER2 treatments was 3 years, we're now getting up to close to 5 years with the use of pertuzumab, trastuzumab, and docetaxel. The treatment moved fairly rapidly into the neoadjuvant setting. So this is Luca Gianni's Neosphere trial, where he looked at various combinations of pertuzumab, trastuzumab, and docetaxel. And you can see the two, or the highest pathological complete response rate in this neoadjuvant window of opportunity study, where patients received 4 cycles of pertuzumab, trastuzumab, and docetaxel, was close to 46%, and that allowed the neoadjuvant license. And if you look now at contemporary studies, this is just a shout out to Berenice, the trial I was involved with. We expect now PCR rates in excess of 60% with the inclusion of either an anthracycline taxane stem or use of the TCHP regimen. So Herceptin subcutaneous was launched in Europe in 2013. This was one of the first patients that we treated actually in the SAFEHER clinical study a couple of years before that, and has revolutionized the experience for our patients receiving trastuzumab, because they're not coming up to the clinic to be hooked up to an intravenous drug. They're receiving it subcutaneously in about 5 minutes. The biggest obstacle we had was the concept of giving a 5 ml volume subcutaneously. And as you'll all know, if you give subcutaneous administration of a conventional drug, you can only inject a very small volume of fluid and you get a bleb under the skin. So the key to unlocking this was the inclusion of recombinant human hyaluronidase with the subcutaneous formulations of the drug. And what that does is temporarily disrupts the intracellular matrix, or the extracellular matrix, sorry, and allows the drug literally to ghost into the circulation. So as patients start their injection, and the nurses who give it tell me this, there's a little bit of resistance for the first very small volume of drug, and then the hyaluronidase kicks in and the drug can then be given relatively quickly thereafter. And that skin architecture is reformed within a couple of days of the injection being given due to clearance of the hyaluronidase. So it allows that administration of large volumes. And in practical terms, this is clearly a healthy male volunteer. And you can see on the left, giving a subcutaneous injection of 10 mils of immunoglobulin, so analogous to giving a monoclonal antibody, without the hyaluronidase on the left panel. You see this very significant bleb on the forearm skin, whereas on the contralateral arm, with the inclusion of hyaluronidase, there's no bleb at all. That 10 mil volume is distributed immediately into the surrounding tissues and then into the circulation. So that was the breakthrough, the breakthrough that really unlocked the technology. So We know from historical data that intravenous trastuzumab transformed the treatment landscape of HER2-positive breast cancer, initially in metastatic disease, and then following the presentation of the adjuvant data in early breast cancer. And subcutaneous clearly made it a more favorable experience for patients. If you then move sideways, dual blockade with pertuzumab and trastuzumab has improved survival without very much change in the safety and tolerability. And there's the potential for these divergent advances to come together in the formulation of a subcutaneous fixed dose combination of pertuzumab and trastuzumab in a single subcutaneous injection. And I'll come on to the advantages for patients later in the presentation. The key to the clinical trial development is to look at the pharmacokinetics of subcutaneous versus intravenous administration of a drug. And as you can see in the darker green in the panel on the left, if you give an intravenous drug at the end of the intravenous infusion, you see a very high Cmax, so maximum concentration in the plasma, and that decays over the ensuing days and weeks and reaches what's called a trough level immediately before the next administration of drug 3 weeks later. In the turquoise, if you then give the drug subcutaneously, you're not clearly getting that hit of drug into the circulation. You're seeing Cmax take some time to be achieved, and inevitably Cmax is lower with the subcutaneous injection compared to the intravenous infusion. And then you see the same pattern of decay over time and the C trough prior to the next administration. The dotted line that you can see in that is the minimum expected therapeutic level of drug. And it's clearly important that we maintain a therapeutic drug. So C trough, the serum drug concentration immediately before the next dose, is the important outcome and has been the primary endpoint of the clinical studies developing the subcutaneous formulations. So the Federica trial was a randomized clinical trial looking at intravenous versus subcutaneous pertuzumab and trastuzumab, and the primary endpoint of the study was that pre-cycle 7 serum C trough level with a non-inferiority design compared to intravenous pertuzumab, and that pertuzumab subcutaneously is in combination with trastuzumab. That leads on to the secondary endpoints of pre-dose cycle 8 trastuzumab serum C trough, looking at interactions between the drug, and then the efficacy endpoint was total pathological complete response using a conventional definition. Long-term efficacy measures have been studied, and I won't be presenting here, as well as cardiac toxicity, which is clearly important. And there are some antigenicity data, which I'll also present. So Federica used investigators' choice of chemotherapy using an anthracycline taxane block sequential design, and it combined either paclitaxel with intravenous pertuzumab and trastuzumab or docetaxel with the same drugs, and it compared those to chemotherapy plus Phesgo. Surgery took place after 8 cycles. No additional treatment was allowed to be given prior to surgery, and then patients continued on their either intravenous or subcutaneous treatment for the total of 52 weeks. So total of 52 weeks treatment, so a year of anti-HER2 drugs, as is the standard of care. These are the demographics, which I'm going to go through briefly. The median age was around 50. There were significant numbers of Asians compared to many studies, so around 20% were Asians. The majority were Caucasians. Then there were some others and unknowns, but patients were were equally likely to be pre or postmenopausal. There's no statistical difference there. A lot of patients were ER and PR negative, with 60% being ER and PR positive. And most of the patients had relatively early stage disease, so stage 2 to 3A, and there was an even split between the 2 chemotherapy regimens. Moving to the endpoints, this is the trastuzumab and pertuzumab IV geometric mean C trough level prior to cycle 8 compared to the fixed dose combination. As you can see, the fixed dose combination comes up with a higher geometric mean C trough, and the lower limit of that confidence interval is 1.14. That's the ratio of the concentration of the two drugs, and that exceeded the non-inferiority margin. So the lower limit of the confidence interval had to be above 0.8 for the trial to meet its primary endpoint. So clearly the trial met its primary endpoint of non-inferior pertuzumab concentration. And you see exactly the same pattern with trastuzumab, with again the median, the geometric mean being higher with trastuzumab given subcutaneously, and that C trough level, the lower limit of the C trough level confidence intervals exceeding the ratio. With respect to pathological complete response, the PCR rates were essentially identical in the intravenous versus subcutaneous formulations at 59.5 and 59.7%. Now, you can never prove that anything's the same, but these numbers are in keeping with previous experience and knocking on the door of that 60% that I discussed earlier from the Berenice trial. What about the effects of Phesgo on PCR related to body weight? Now, when we were launching subcutaneous trastuzumab, this was a big issue because we were moving from per kilogram dosing, so 8 milligrams loading and 6 milligrams per kilogram maintenance given every 3 weeks, to 600 milligrams given as a flat dose. Whereas with pertuzumab, it's actually less of an issue because, of course, pertuzumab given intravenously is given at a dose of 420 milligrams to everybody. And as you can see, in the underweight group where there were very low numbers, there was an excess of PCRs, but it was 100% of 3 patients. So I don't think you could read anything into that. Whereas in the other groups moving along, there were no statistically significant differences in patients receiving IV or subcutaneous treatment. There's a numerical difference in the obese patients. Then looking at secondary endpoints, the majority of patients had an adverse event, but most of those adverse events were related to chemotherapy. Around half of patients had grade 3 adverse events, 16 to 18% had serious adverse events, and there was 1 death in each arm of the study. In one of them, there was urosepsis, the other death was due to an acute myocardial infarction, and in both cases, the investigator assessed the deaths to be unrelated to study treatment. There was a very low rate of withdrawal of anti-HER2 therapy, so just over 2% in both arms of the study. These are adverse events of interest, including diarrhea, which was well matched, neutropenia and febrile neutropenia, cardiac dysfunction, and infusion or injection-related reactions. And there was a small numerical excess of injection-related actions, usually low-grade minor inflammation or pain in the skin of the thigh where the drug is injected, but there were no differences in the other adverse events. This is cardiac events, so there were a handful of primary cardiac events in the patients receiving subcutaneous treatment, secondary cardiac events, so changes in LVEF without heart failure. There was actually a numerical excess in patients receiving treatment intravenously, and the numbers of significant LVEF drops were pretty well balanced between the two arms, possibly a slight excess in the intravenous, but I would stress no statistically significant differences in any of these groups. These are anti-drug antibody reactions. So there was some concern, again, in the early development, particularly of subcutaneous trastuzumab, that giving the drug subcutaneously would represent a different method of antigen presentation to the host immune system. And because the skin is much more likely to be exposed to environmental allergens than the circulation, there was a concern that there might be a larger number of anti-drug antibodies, so neutralizing antibodies in patients receiving the treatment subcutaneously compared to intravenously. In fact, when it came to it, the numbers of anti-drug antibodies, in both arms of the study was pretty low. So there were 7 patients in the intravenous arm, 11 in the subcutaneous arm, and then as a separate exploratory study, the PCR rate in patients with anti-drug antibodies was studied. And as you can see in the lower part of this panel, there was a PCR in 5 out of 7 patients who had anti-drug antibodies. So that was important. And then there was a low number. So 1 patient had a significant administration reaction with those anti-drug antibodies. In the patients who received subcutaneous treatment, 7 of 11, so 63% had a PCR, and there were no significant reactions in the patients with anti-drug antibodies. And these are just the same data for trastuzumab, just to make the point that actually anti-drug antibodies to trastuzumab are less frequent. So 1 in the IV arm, 2 in the subcut arm, and then I think the other numbers then in that context lose any relevance. So in conclusion of the study was that fixed dose combination pertuzumab and trastuzumab was non-inferior to the intravenous delivery of the drug based on serum pertuzumab C trough level. The PCR rate was virtually identical, and certainly there was comfort with that. And the safety profile was comparable to the intravenous preparation. And in particular, there were no new safety signals and no difference in cardiac effects of the drugs when given subcutaneously. So what about patient preference? This is the Francesca trial design. This was a phase 2 open label randomized crossover study in patients who'd completed their chemotherapy containing treatment. So all of the chemotherapy was over at the time of entry to the study, and they were receiving maintenance pertuzumab and trastuzumab in the adjuvant setting. And patients on established treatment received a 6-cycle study exposure of either intravenous pertuzumab followed by subcutaneous, or subcutaneous followed by intravenous. They were asked questions about tolerability, and they were asked to express a preference for either intravenous or subcutaneous treatment. And then in the continuation period, so after the 6 cycles of treatment in the study, they were allowed to choose whether to continue with Phesgo, so subcutaneous, or whether to continue with intravenous. So in effect, the patients were not only asking to express an opinion about treatment, but were given the opportunity to act on that opinion. And you can see in all patients, the overwhelming majority, so 85%, preferred subcutaneous injection to intravenous infusion, and that didn't appear to differ whether in the trial they got the intravenous followed by subcutaneous, or whether they got subcutaneous followed by intravenous. The preference, so the level of preference, was also much higher in those who preferred subcutaneous injection, and the most common reason for selecting subcutaneous was less time in clinic, and patients were more comfortable during administration. And even though only 85% of patients preferred subcutaneous, interestingly, 87% of patients elected to continue with subcutaneous treatment for the remaining duration of their adjuvant anti-HER2 therapy. So I think a convincing signal from the patients. So what are the practical implications of this technology? Well, first of all, there's quite a lot of work goes into giving 2 separate intravenous infusions of Herceptin and Perjeta. There's the pharmacy time draw up. With Herceptin, there's the scope for error on the per kilogram dosing. It's not the same issue for Perjeta, that's fixed dose. The patient has to be cannulated or their VAD accessed. Then at the end of treatment, lines have to be flushed, the patient has to be observed, and they're then allowed to go home. So it's a very time-consuming process. And so we did an analysis in our center of the reasons why we would prefer to give subcutaneous Phesgo compared to intravenous. Now, we'd already gone through this process with subcutaneous trastuzumab before, but if you think of the individual steps, the patient may wait to get into the chair because our day units, and I'm sure yours, are oversubscribed with patients receiving IV therapies. There's that access time, infusion time, which for Herceptin first dose as per SPC is 90 minutes, with subsequent doses potentially given over reduced time. Pertuzumab first dose 60 minutes, with subsequent doses given over 30 to 60 minutes. And then there is the observation time, which again per SPC is 6 hours after the start of the first trastuzumab and 2 hours for subsequent cycles, although I have to admit that we probably were not sticking to that prior to using subcutaneous. With subcutaneous, the patient may still wait to get into the chair. There are some issues of privacy because they have to expose their thigh, but there are no cannulation or venous access considerations, and the injection time is dramatically reduced. So first dose of Phesgo, so subcutaneous, is 8 minutes, with subsequent doses given over 5 minutes. In practice, the nurses usually take a little bit less than 5 minutes. There's no issue around decannulation and flushing, and the recommended observation time is 30 minutes after the first dose and 15 minutes after subsequent doses. So we're turning the patients over much more quickly in our day unit. And this is just a time frame for trastuzumab loading, pertuzumab loading versus Phesgo loading in the top half of the panel, and then the maintenance doses if you're following the SPC. So we're saving huge amounts of time for each administration, with the best case for the fixed dose combination being 20 minutes. And of course, in the adjuvant setting, we're repeating that. So we're not just saving that time once, we're saving that time 18 times over the year of treatment. And in the Northern Centre for Cancer Care, this is the building. I'm actually, if you look at the windows, if you went another 2 windows to your right, that's where I'm sitting now giving this talk. And it is a bright sunny day here. It's been really cold, but we're giving more than 1,500 doses of the 2 drugs every year. And the number of drugs that are being given is going up and up and up. So when our centre opened in 2010, there were relatively few drugs that we can give, and 15 years on, there are many, many more, in particular, of course, immunotherapies in virtually every cancer type now. So pharmacy, we've talked about a little bit, but the pharmacists were keen to move away from reconstitution of 2 bags. There were the issues of storage, vial wastage, because of not everybody conforming to vial size. The drugs would expire. We were using consumables, whereas with subcutaneous, we just have to get the drug out of the fridge. For the nurses, they're not faffing around with intravenous pumps, with cannulation and vascular access devices. They're not waiting for reconstitution. There isn't the constant alarming of the pumps and the observation time. Whereas for subcutaneous, we've said we're all very much used to it, and all they had to do literally was get the drug out of the fridge, let it warm up a little bit, visit the patient, and dispense the treatment. So it's estimated that there are up to 85% savings on chair time, around 65% savings on the patient's own productivity losses, because they're only giving up a few minutes of their day for a subcutaneous injection rather than half a day for IV. There was a lot of time on healthcare professional costs, obviously nursing and pharmacy rather than the physicians, and significant savings on non-drug consumable costs. So this is the story of a patient of mine who was first diagnosed with breast cancer in 2014. She had a fairly large 55mm grade 3 cancer with 6 involved nodes. And interestingly, at presentation, her tumor was ER positive and HER2 negative. So 1+, she would now be categorized as HER2 low. So she had a mastectomy, FEC-T, chemotherapy, radiotherapy, and endocrine therapy. Sadly, 4 years later, in August 2018, she was diagnosed with disease in her liver. Because of the time interval, we did a new biopsy, and that showed findings consistent with metastatic breast cancer, and its receptors had flipped completely. It was then estrogen receptor negative, 0 out of 8, and HER2 positive on immunohistochemistry. And she started on docetaxel, pertuzumab, and trastuzumab, all at that time given intravenously. So if you can see it, this is her liver at baseline, and this is her liver in September 2022. So she had that rare but wonderful thing, a complete pathological response that was maintained, a complete radiological response that in her case was maintained at 4 years. So initially we talked about intravenous treatment. So she had 43 cycles of intravenous treatment and described attending the chemotherapy day unit. The visits were lasting at least half a day, sometimes longer, and most of that time was waiting for drug reconstitution, cannulation, bag changes. And the lady said that she struggled with the day unit, and she's right, it's not the most relaxing or calm environment. And there are a lot of sick people there. We assess emergencies immediately adjacent to our chemotherapy day unit. And there is that constant reminder of cancer, of chemotherapy, and the constant beeping and alarming of machines. So it's not the most relaxing environment. In 2021, when we knew that Phesgo was going to be licensed, we made the decision to switch all of our patients over. We knew that switching between IV and subcutaneous was acceptable specifically for this product on the basis of Francesca, but also based on our experience with switching from subcutaneous Herceptin to intravenous to subcutaneous Herceptin. And in the time that we've been doing this, only one patient has ever asked to go back onto IV. We made a decision not to reconsent patients because they'd been consented for the drug, not for the route of administration. We identified a private space to give the drug, and we didn't need to train staff because we were already using subcutaneous. So we drew up a new prescribing template. We ran down stock of the 2 intravenous formulations, told the patients that change was coming, and then we literally switched everybody over on pretty much the same day. And the final consideration is that we had been using innovator pertuzumab, but biosimilar trastuzumab, and even switching to an all innovator product, so an all branded product, it was still a cost-effective move for us. And our next step was to move patients out of the day unit and closer to home. So again, this is a Google Maps of the hospital, which you can see in the bottom corner there, circled in red. We have a Maggie Centre, which is a great innovation next to the hospital. And then in one of the surrounding streets, there's a Lloyd's Pharmacy. And we've partnered with Lloyd's Pharmacy to give the treatment in their pharmacy. So we actually have now a very large pharmacy a little bit further from the hospital where we give almost all of our subcutaneous drugs. So the patient was on Phesgo from March 2021 to June 2023, when unfortunately she had progressive disease. Initially, as we said, in the day unit, but then we moved it to the pharmacy, and she literally has a set time. She stuck to it. She parked right outside the door, went in, and one of the big issues for her was that she could go in her break from work without anybody knowing that she was coming anywhere to receive anti-cancer treatment. And then in 2023, unfortunately, I say she progressed and is now actually on Kadcyla and has disease that's been controlled for another 2 years so far.
Wow.
This is just a Canadian study which looked at the cost benefits and concluded the overall costs were lower with Phesgo. So in summary, for everything, it's pharmacokinetically non-inferior to the intravenous preparation. It has an equivalent PCR rates. There are no additional or new toxicities, and there are significant savings from a resource use perspective. And the drug is overwhelmingly preferred by patients. And again, my patient said it was life-changing to be able to move from the intravenous to the subcutaneous formulation. And just a little brag, we had a young patient who was on the IV preparations and had literally completely run out of intravenous access and didn't want any kind of central line because she had young children. And we actually gave the first European non-trial dose of Phesgo in Newcastle on the 24th of November 2020. And I'll leave you with that thought. Thank you very much, and I'm very happy to answer any questions that you may have for me.
Thank you, Dr. Mark, for this comprehensive overview about the role of sub-Q anti-HER2 new therapy in the treatment of breast cancer. So the floor now is open for any questions from the audience. Or, okay, Dr.
Thank you, Doctor, for this talk. I would like to ask, is there any problem to combine FISGO with chemotherapy? Do you prepare any line of or kind of chemotherapy to combine with FISGO, or you could combine with any type of chemotherapy or hormonal treatment?
Yeah, if you're using pertuzumab and trastuzumab, you can use intravenous. Even if we're giving intravenous chemotherapy, we still give subcutaneous because it shortens that visit. And if you think about it, if you've got a patient who's starting on docetaxel, pertuzumab, and trastuzumab, they're going to be on the day unit all day. Whereas if you're giving the subcutaneous formulation, it's only half a day. They're just there for the IV treatment. So we combine it with the drugs that we're allowed to give alongside, which in England is either docetaxel 3 weekly, paclitaxel weekly, or in metastatic disease capecitabine, and all of those are acceptable partners. When it's capecitabine, we move treatment completely out of the day unit, so they either come up to outpatients or to our remote facility to pick up their treatments, just to offload the IV work on the chemotherapy day unit. But we use basically no intravenous drug now.
Dr. Firas.
Thank you. Was the combination, the subcutaneous combination, was it tested in the neoadjuvant setting, and can we use it in this setting?
Yeah, so the Federica trial was a neoadjuvant clinical study. So neoadjuvant was used in a trial called HANA for subcutaneous trastuzumab, in Federica for subcutaneous fixed dose combination pertuzumab and trastuzumab. And interestingly, it's been used in almost all of the biosimilar development programs in breast cancer. And the reason for doing that is that if you're treating the neoadjuvant setting, first of all, you have a clean population from the point of view of the burden of their disease and comorbidities. And you can also actually look at PCR rates, either in breast alone, which was done in a lot of the biosimilar studies, or breast and axilla. So you get a short-term, reliable efficacy measure. So as I say, a lot of the developments in neoadjuvant, and we certainly do use the drugs in neoadjuvant. So we're thinking that probably half of the world population who give an anthracycline stem and then move to docetaxel, pertuzumab, trastuzumab in the neoadjuvant setting. In the patients that we give TCHP2, we also use subcutaneous Phesgo. So all of our use, neoadjuvant, adjuvant, metastatic, is subcut.
Okay, Dr. Muhammad.
Could you re-challenge, or in case of progression, do you advise to change chemotherapy and continue FISGO, or to change all the medications?
So it depends where the progression is. So if we've got patients who are progressing in central nervous system and they're candidates for local therapies, then we keep going with the Phesgo and we treat the local disease. But if they've got progression in another organ, so in lung or liver, then we would switch treatment completely. There are data with trastuzumab looking at treatment beyond progression, either in combination with lapatinib, so can tell you that's old data, or there was a German study looking at switching or adding in capecitabine chemotherapy, and there is a benefit of treatment beyond progression compared to stopping treatment. But I think you have to bear in mind now that HER2 positive breast cancer is a rich field, and we've got antibody drug conjugates, so we've got Kadcyla, we've got Enhertu, we've got the use of tucatinib. So I think there's much less reason to think about continuing treatment beyond progression than when the only drug that we had was trastuzumab. So progression in brain, we keep going. If they have local therapy, progression elsewhere, we switch.
My last question, thank you, Dr. Mark. I have experience in using Phesgo in the neoadjuvant setting. Actually, it's much easier for the patients. But I have a question regarding the underweight patients, lower body mass index. Do you think it What is the efficacy of VASCO in these patients?
So first of all, the weight issue is not specific to Phesgo, because Phesgo is not specific to pertuzumab, because pertuzumab has always been given at a flat dose. So it's always been used at a flat dose regardless of body weight. Contrast is trastuzumab that used to be dosed per kilogram and is now dosed flat. But if you actually look, first of all, for the majority of patients, so patients out to 100 kilograms, they're getting a slightly higher dose than they would have done. But there's also some very elegant work that was done on the back of the subcutaneous trastuzumab development program that looked at the C trough levels by body weight. And C trough levels didn't seem to vary by body weight. And there are actually as many low and underweight patients who have under the threshold C trough levels as there are overweight patients. And it looks as if there's a relationship between metabolism and weight. It slows down in drug metabolism, slows down in heavier patients. There was also a detailed safety study in low weight, and in particular in Asian patients, because as a population they're lower weight, and there were no excess safety signals. And again, it's actually the overweight and obese patients have the risk factors for safety issues, and they actually, if anything, had more toxicity than the low and underweight patients. So there are quite a lot of data to support the use of the fixed dose combination.
Thank you, Dr. Mark, and hopefully we'll see you face to face next time. Thank you.
That would be great. Thank you very much.
Okay, we move back again to hematology, and this is a Hikma symposium. And it's my great pleasure to present Dr. Rami Kumrokji to talk about a very important topic on myelofibrosis and the JAK2 inhibitors era. Dr. Rami Kumrokji has actually graduated from the University of Jordan. And since he moved to the United States, where he did his training in medicine and hematology oncology, and he's currently the vice chairman of the malignant hematology department at Moffitt Cancer Center in Tampa, South Florida, as well as professor of medicine at the South Florida, Tampa, Florida University. He's an expert in myeloid and myelodysplastic syndromes. And he has co-authored large number of papers, has conducted multiple trials, phase 1, and explored many new drugs in this setting and this area, as well as he's the editor of the editorial board of the Journal of Clinical Oncology and the Leukemia Journal. He's a regular visitor of our country. We welcome him back to give us his talk. Dr. Rami, the floor is yours.
Assalamu alaikum, and thank you for the kind introduction, Ustazna Dr. Abbadi. He is our mentor, and it's a pleasure to be at least virtually in Jordan. So I'll be talking today about myelofibrosis, mainly discussing like updates, focusing on the JAK2 inhibitors use in this disease. So, as you know, the myeloid neoplasms classification was revised in 2022. Most of the revisions were more impactful in AML and MDS. In myeloproliferative neoplasms, there were really not much changes. The common non-CML are P-Vera, essential thrombocythemia, and myelofibrosis, whether it's primary or post-ET, post-PV myelofibrosis. And now we recognize an entity called prefibrotic myelofibrosis that we'll talk about a little bit when we talk about the diagnosis. So the hallmark for all those diseases is really activation of this JAK-STAT pathway. that lead to the proliferative features of the disease. Now, the JAK-STAT pathway is activated by several mechanisms. One is by the increased ligands because there is inflammatory milieu. Then by what we call a phenotype driver mutations. And there are three that are described now, the JAK2, the calreticulin, and the MIPL. And those mutations lead to the constant activation of the JAK-STAT pathway. And they are detected almost in more than 90% of patients with those diseases. In P. vera, it's predominantly a JAK2. In ET and MF, almost half of the patients will have a JAK2 mutation. 1/3 will have a calreticulin mutation, and 5% probably have MIPL. There is an entity we call now triple negative in 10%. But you don't require the presence of a JAK2 mutation to use JAK2 inhibitors because the JAK-STAT signaling is activated by any of those phenotype driver mutations. Now, those are not the only mutations or abnormalities we see, and they drive the disease clinical features, but we think that there are other disease-initiating mutations such as TET2D and MT3A. Those are mutations of aging, or what we call CHIP now. And there are mutations that are associated with progression, like IDH1, IDH2 are associated with a higher risk of leukemia, ASXL1, SRSF2, UTAF are usually associated with poor outcome, for example, in myelofibrosis. But at the end, obviously, all those diseases are clonal. You get clonal neoplastic stem cells. In this case, the megakaryocytes are dysfunctional. There is excessive cytokine release that leads to the fibrosis in the bone marrow. So the fibrosis is a surrogate marker. It's not the underlying biology. The underlying abnormality is really a clonal stem cell disease with an inflammatory milieu. Those stem cells can also go reside outside the bone marrow, leading to this extramedullary hematopoiesis, splenomegaly, hepatomegaly, and sometimes extramedullary masses, and obviously the inflammatory burden of the disease. Now, in the new classification, there is really not much changes, and there is concordance between the WHO and ICC. We identify this entity of prefibrotic MF that's now well recognized. So the classical thing I always tell my fellows is like, you don't need to have fibrosis to diagnose myelofibrosis, and not every fibrosis seen on a bone marrow biopsy equals myelofibrosis. So on the left are those criteria for prefibrotic MF. So in cases where you have megakaryocytic proliferation, which is really the hallmark of the disease, even if there is no fibrosis, with presence of clonality and minor criteria, one can establish the diagnosis. Those cases mostly are labeled as essential thrombocythemia, and now we know that those could be fibrosis. And if you see a patient that was diagnosed with essential thrombocythemia 3 or 4 years ago and now have frank fibrosis or overt fibrosis, that probably was a prefibrotic MF from the beginning, because ET takes longer time to progress to myelofibrosis. The key to distinguish between prefibrotic MF and ET or like MDS is really the pathology and having experienced hematopathologist. In general, we see more hypercellular bone marrow, granulocytic hyperplasia. The clustering of the megakaryocytes and the morphology is different between ET, where we see loose clusters, versus myelofibrosis. Clinically, those patients will have a higher LDH. And then obviously the overt fibrosis would require presence of a grade 2 or 3 fibrosis in the bone marrow, a clonal marker, ruling out other diseases that can mimic fibrosis. But there are other conditions to keep in mind that can cause fibrosis in the bone marrow. Marginal zone lymphoma, hairy cell leukemias, connective tissue disease, some medications. I always give an example of a patient that was referred to me a week or two before going to allogeneic stem cell transplant for myelofibrosis. And our hematopathologist actually called me and said, this doesn't really look like classical myelofibrosis. Can you repeat the bone marrow? And the patient ended having hairy cell leukemia with extensive fibrosis in the bone marrow. So it's always good to spend some time assuring the diagnosis. The molecular or the clonal markers or the phenotype driver mutations are now readily tested, whether one is using a PCR for the JAK2 or the calreticulin, or by any of the targeted sequencing tests that can be done. And then there are obviously criteria for post-ET and post-PV myelofibrosis requiring prior history of PV-ET, then increased fibrosis, anemia, stopping requirement for phlebotomy, developing splenomegaly, and constitutional symptoms, etc. This is like a classical bone marrow finding of myelofibrosis. You see the hypercellularity, the bone marrow is packed. You see the clustering of the megakaryocytes. This is the reticulin stain, those gray lines that shows extensive staining. And this is the collagen fibrosis. And if you have a collagen fibrosis, that's automatically a grade 3 fibrosis. So once we establish the diagnosis, the next step, like any other tumor in oncology, is really staging. And as you know, in myeloid diseases, every disease have like 5 or 6 different staging systems, and myelofibrosis is one of those. So there are clinical staging systems, the IPSS, dynamic IPSS plus, and they, the variables are common, as you see here. Like we weigh on cytopenia, like if patients are anemic, needing blood transfusions, leukocytosis, presence of circulating blasts. Symptoms are important in myelofibrosis, and thrombocytopenia. And then you plug those variables in, and you get into a 1 out of 4 stages, where you can see that the survival for those patients can span from 15-20 years to, unfortunately, less than a year. So it's really a large spectrum. Myelofibrosis in general is not a common disease when we are comparing to solid tumors, but it's still actually one of the top 10 diseases with mortality and symptom burden on the patients. Now we've moved obviously a little bit to more molecularly enhanced models. So those are there is models called GIPS. This is the MIPS, or molecular IPSS 70. So it was particularly designed for patients younger, because this is a tool to use for transplant. So it kept all the clinical variables, but it looks also at the molecular. Calreticulin is favorable, so anytime we don't have calreticulin, that's worse. There are high-risk mutations, the ASXL1, EZH2, SRSF2, IDH1, IDH2, and in the newer version, we add also UTAF, Q157. And at the end, you divide the patients into one of 5 groups, where you can see somebody with very low risk will have a median overall survival more than 20 years, or it's unreached, while somebody who's very high risk, their median overall survival is less than 5 years. This is a model we developed along with the Italian group, looking particularly at patients post-ET or post-PV myelofibrosis, where you can plug those variables, and this is a tool available online, and again you can see the outcome for patients based on that. So we establish the diagnosis, we risk stratify the patients, because at the end, if the patients are in those higher risk disease categories, we are immediately contemplating allogeneic stem cell transplant, because it remains the only curative option. Roughly 40 to 50% of the patients will be cured. However, transplants still have the 10 to 20% transplant-related mortality. So if the patient disease is associated with more than 5 years survival, you cannot justify the upfront transplant-related mortality. While if patients are higher risk, we move to transplant. But many times those patients are sick from the disease. So nowadays we do a lot of the JAK2 inhibitors to improve patients' performance, improve the splenomegaly, and then progress to transplant. And you can see that the myelofibrosis does affect the survival compared to age-matched population. It's the out of myeloproliferative neoplasm, myelofibrosis have the worst outcome in terms of overall survival. And we also now talk about the proliferative myelofibrosis versus cytopenic. In cytopenia, if patients have thrombocytopenia and anemia, and there are some differences. The proliferative tends to be more post-ET, post-PV, so secondary. They tend to have a higher JAK2 burden, less fibrosis, while the cytopenic tend to be more primary, lower JAK2, and they are enriched with mutations similar to MDS splicing mutations. And obviously they have higher rate of AML and worse overall survival. So myelofibrosis is associated with a lot of symptoms, obviously classical constitutional symptoms. It's really progressive disease with weight loss, fevers, night sweats, symptoms related to abnormal blood counts, cytopenia, sometimes thrombocytosis, and there is risk of clotting similar to ET or PV that we don't commonly think of. And then obviously splenomegaly and the symptoms related to splenomegaly are a key feature of the disease. Most of the patients are symptomatic with this disease. So when you look at the constitutional symptoms, you can see that there are many of them. There are tools developed and actually translated to different languages, including Arabic, that capture this, which we call the symptom assessment form that will give a quantification or number for the patient's symptoms. But you can see, fever, fatigue, bone pain, itching, and all those are very common symptoms. And those symptoms are associated with, worsening of the quality of life for patients. Cytopenias are not uncommon. Anemia is present in almost 1/3 of the patients at diagnosis, but over time, half of the patients will become transfusion dependent, and anemia is associated with worse outcome. So it's thrombocytopenia at diagnosis, 25%. In our series, a little bit less than that, 15% will have platelets less than 100 at time of diagnosis. But as the disease evolves, almost 2/3 of the patients may have thrombocytopenia during the disease course and also associated with worse outcome. Splenomegaly is a key feature of this disease. Obviously, mechanically, it leads to early satiety, abdominal pain, discomfort, splenic infarct, but also over time leads to portal hypertension, cirrhosis, and ascites. I use not to treat patients with splenomegaly unless they have major symptoms, but I always say I learned to respect massive splenomegaly over time, because if you observe patients with massive spleen over time, those patients will develop cirrhosis, ascites, they become cachectic, and it becomes very challenging to treat those patients. And this is an example of a patient of mine where really the spleen can get massive, unfortunately, with this disease. This is a classical where you see massive splenomegaly, ascites. When you look at the ribs, the patients have weight loss, are cachectic. Unfortunately, this is like terminal stages of myelofibrosis. And when you look at the mortality in myelofibrosis, almost 1/3 of the patients eventually will transform to AML. But the second most common cause is really this progression, without transformation, where patients, as I mentioned, will have this progressive constitutional symptoms, splenomegaly, and you can see other causes of mortality among those patients. So nowadays, obviously, we are more than a decade in the use of JAK2 inhibitors, and that had changed really the landscape for the management, particularly for patients with splenomegaly and constitutional symptoms. And I think the consensus that those medications had improved the survival. So they are not merely a symptomatic treatment. We have in the USA 4 drugs approved for treatment of myelofibrosis as JAK2 inhibitors. Ruxolitinib obviously was the first, and ruxolitinib is obviously now going to be available generic in Jordan and the Middle East. Hikma also makes ruxolitinib. Those drugs, all of them have JAK2 activity, but they have differences in other targets, particularly the JAK1. Ruxolitinib is JAK1, JAK2. Momelotinib have JAK1. Pacritinib and fedratinib don't have much JAK1. targeting the JAK1 has advantages in terms of symptoms. It may have sometimes there's some disadvantages in terms of myelosuppression and a little bit more T-cell effect, but the efficacy and the toxicity profile is really based on that. Those are the NCCN guidelines. So we evaluate the patients if they are higher risk, intermediate or more, and they are symptomatic, whether they have spleen or constitutional symptoms. Then the treatment for those patients to start with is a JAK2 inhibitor. Obviously, any patient that is eligible for transplant, if they are a higher risk disease, we should consider that. In the United States, we easily offer transplant up to age 75 nowadays if patients are in good shape and candidates for transplant. But even before transplant, often we use those drugs as a bridge. So obviously, if patients' platelets are above 50 by the guidelines, ruxolitinib as category 1, they list fedratinib and pacritinib as option. But in most of the cases, ruxolitinib has been the mainstay as long as the platelets are above 50. If platelets are less than 50 in the United States, pacritinib is now used for those patients. So this is a patient of mine, 68-year-old, presents with constitutional symptoms, abdominal pain, found to have, she had weight loss and she has 8 centimeter spleen. Obviously, those are non-specific presentations that can end to be lymphomas, infection, myeloproliferative disease, etc. Her CBC reveals mild anemia, hemoglobin 11, white blood cell count 27, platelets 230, bone marrow, classical findings of myelofibrosis, JAK2 is positive. So this patient really meets all the criteria. They have the bone marrow findings, the clonal marker, the leukocytosis. And when you look at the risk for this patient, they will be intermediate 2 or an intermediate risk by the virtue of the leukocytosis, circulating blast, constitutional symptoms. So obviously this patient first line of therapy will be a JAK2 inhibitor to improve the symptoms. This patient will be considered for allogeneic stem cell transplant. So ruxolitinib has more than a decade of experience. The approval was originally based on 2 trials, the COMFORT 1 and COMFORT 2, COMFORT 1 done in the USA, COMFORT 2 done in Europe. And all those studies in myelofibrosis, the gold standard had been 2 primary endpoints: spleen volume reduction by 35% by measurement by MRI or CAT scans, and symptom improvement with reduction of 50% or more in that total symptom score. Why this spleen volume reduction of 35%? When we were conducting phase 1 trials, that correlated with 50% reduction of spleen size by physical exam. So in real life or practice, you don't really have to get spleen volume MRI. Physical exam is adequate. And in terms when it's difficult, maybe an ultrasound. Do you really need this 35% reduction to drive benefit? I'll show you more data on that probably less than that is even still beneficial. But those became the gold standard because the FDA wanted to look at objective criteria. So spleen volume reduction 35%, as well as total symptom score reduction by 50% became the gold standard. So in the COMFORT 1, patients were randomized between the ruxolitinib versus placebo. In the COMFORT 2, it was done in Europe versus best available therapy. Both studies showed the treatment leads to spleen volume reduction more than 35% in more than 1/3 of the patients, and almost half of the patients had symptom reduction, and those led to the approval of the drug. And you can see here the waterfall plots of the spleen reduction. In green is ruxolitinib, both on the COMFORT, and you can see that most of the patients actually have spleen volume reduction. It's 42% that met that 35%. Similarly, symptom improvement was seen in almost most of the patients. The main side effect, both in the COMFORT 1, COMFORT 2, was myelosuppression. That is very predictable. So if you start patients, usually the nadir is by week 8. The hemoglobin will drop between 1 to 2 grams. You can see also thrombocytopenia. We tend to see less neutropenia among those patients. Other than that, myelosuppression, There is a slight risk of increased recurrent UTIs, 3 to 5% zoster reactivation, and very rare cases, less than 1% of like TB reactivation. Because as you know, ruxolitinib also have some T cell effect that we use it for graft versus host disease, but those are really very rare and encountered. The main thing is really this myelosuppression that's very predictable and almost exclusively with anemia and thrombocytopenia. Similar we're seeing in the COMFORT-2. When those studies were originally designed, they were not geared to look at overall survival because they looked at crossover, but subsequent analysis from both even the COMFORT-1, COMFORT-2, and actually this has been seen with other JAK2 inhibitors, had constantly demonstrated survival advantage. So I always say if patients have indication to treat them with JAK2 inhibitor, they have spleen, they have constitutional symptoms, compared to Hydrea, those drugs definitely have a survival advantage. If patient is early stage, doesn't have splenomegaly, constitutional symptoms, no treatment, you cannot tell the patient that I'm going to treat you with a JAK2 inhibitor to improve your survival. But once patients have symptoms, ruxolitinib over best available therapy, Hydrea definitely have overall survival. And unfortunately, lecturing around this worldwide, many countries still have Hydrea as upfront therapy for those patients, where we clearly see that there is a survival advantage using JAK2 inhibitors in setting where patients are symptomatic. Now, they looked at the anemia because obviously, as I mentioned, patients will drop their hemoglobin by 1 to 2 grams. Typically, there was no impact of the anemia on overall survival. And I think it really depends on the context. So if a patient is starting with hemoglobin of 11 and they drop to 9, but they are feeling better, spleen is reduced, in practice, most of the time, that's not an issue because the patients will feel way better. Obviously, if a patient is starting with hemoglobin 9 or 8, and we are going to render them transfusion dependent, that's a little bit more challenging. And then we, probably fine-tune the dose of ruxolitinib. Sometimes we use other medications in conjunction to try to improve the anemia. So does spleen response matter? And the answer is probably yes. There are several studies that show correlation, and this had been looked at with all those JAK2 inhibitors, that a spleen reduction does correlate with survival. What is the cutoff? It seems mostly a 10% or more reduction in the spleen size does correlate with a survival advantage for those patients. So in practice, most of the time, if patients have 10 to 20% spleen reduction, we do consider that as a response and we continue with the treatment because that does correlate with better overall survival for the patients. And again, this had been constantly shown through all the JAK2 inhibitors. Now, in real world, unfortunately, most of the time, the doctors are reluctant to push dosing. So a lot of patients end on the 5 or 10 BID dosing, which in some cases could be appropriate, but in others, it's not, and one should maximize the dosing. The symptom improvement can be seen really as low as 5 milligram BID and tend to be very quick. So if you start patient on ruxolitinib, within a couple of weeks, they will be feeling better. Fatigue, itching, night sweats, fever, bone pain can resolve completely within a couple of weeks at a lower doses. But the spleen response is really dose dependent, and you have to escalate the dosing. And typically, it takes 3 to 4 months to see the spleen response. Obviously, if it is a fine balance, as I said, we typically, when we start the medication dosing, we wait 6 to 8 weeks because that's the nadir, and then we can adjust or increase the dosing if we started with a lower dose. But we tend to be aggressive. MD Anderson has the school of starting with the higher dose and then backing off. I think it depends on the context. If patients have borderline cytopenia, you can start a little bit with lower dosing, and if it is tolerated, then go higher. Because again, if somebody's hemoglobin baseline is 8, you just don't want to render them heavily transfusion dependent. Now, there have been several trials trying to look at use of ruxolitinib earlier on in the intermediate 1 group. And those patients can be symptomatic, can have splenomegaly, constitutional symptoms. And you can see that the responses are higher, and probably the cytopenia magnitude is less. So we tend to start those medications earlier a little bit if patients are symptomatic. Again, the key of using the JAK2 inhibitors in general is symptomatic. If a patient is just cytopenic, no spleen, no constitutional symptom, just anemia or thrombocytopenia, JAK2 inhibitors in general as a class are not the treatment of choice for those patients. But earlier introduction in patients that have spleen and constitutional symptoms are beneficial. So obviously the starting dose depend on the platelet count. Development of anemia does not affect the benefit, but obviously can be mitigated sometimes. We use ESAs. There are studies now on your medications to alleviate the anemia. And obviously if patients develop cytopenias, we dose adjust the treatment. So this is a consensus of experts that what's considered a response and what is considered a failure. So a primary refractory disease is failure to shrink the spleen by 20%. As I said, in practice, we use really 10 to 20% and less than 20% reduction on the symptom score. Intolerance is really development of severe cytopenias or major adverse events. And loss of response or secondary failure is increase in the spleen by 25% compared to baseline, or recurrence of all those symptoms by 30% or more of baseline. We the Italian group developed this model that we also validated, and we were part of the development, called RR6. We look at transfusions, spleen reduction, and ruxo dosing at 3 and 6 months. So if a patient, we were able to maximize the dosing of ruxo, had good spleen reduction, and was not needing blood transfusions, even if they were anemic, they will be in that right green curve where you can see that those patients drive really significant benefit. If patients obviously are on suboptimal dose, there is no spleen reduction, they are needing blood transfusions, those patients unfortunately will drive less benefit with a survival in the terms of 2 to 3 years. So that's a group of patients we are focusing on to see how can we do better. And the median duration of response is around 3 years, but we see patients with longer duration, particularly if the treatment was started earlier. Reasons of discontinuation remains mostly disease progression. Cytopenias are important. Post JAK2 failure, patient survival is impacted where they have less than a year survival. So it's important to optimize and drive the maximum benefit of those treatments. One thing to mention is there is this described phenomena of ruxolitinib discontinuation. People argue whether it's really true withdrawal versus recurrence of the disease main symptoms, but it's real. So we tell the patients always to have the medication with them. If patient is hospitalized for pneumonia or infection, they should bring the medication with them and take it, because if they stopped it suddenly, and particularly they were responders, there will be a rebound within few days. And there are patient reports that they get very sick, they get to the ICU. If patients are going to surgery, we tell them to take it the night of the surgery even, and the minute they can take oral medications, they resume it. If patients are intubated or cannot take ruxolitinib, we actually use steroids to bridge them. And the same thing when we are shifting or stopping ruxolitinib, we taper it. Same thing, patients going to transplant. Our transplant team have a tapering program that they stop the ruxolitinib at the day of the conditioning so that we don't go into those withdrawals. So that's very important to educate the patients about compliance, not skipping the medication, even if they are hospitalized, to take it. And if you are ever stopping those medications, to taper them down, not stop them suddenly. Now, there are several efforts to try to improve and do combinations, and there have been several trials. We don't have time to go through most of them. This is a drug that have potential of getting approval by the FDA called pelabresib. It's a BET inhibitor that was tested in randomization with ruxolitinib, and it had shown doubling of the spleen response, but it did not improve the total symptom score against ruxolitinib. And this had been a failure of many of the trials recently, that most of the combinations fail to improve the symptoms compared to ruxolitinib, because ruxolitinib is really a very good drug to improve the symptoms. The original studies against Hydrea, or best available therapy, it was easy to improve the symptoms. But in terms of spleen response, it doubled the spleen response. There were less cytopenias. So this is a drug can see the approval. There had been other trials like with navitoclax, showed doubling of the response, but the cytopenias were profound, so that's not going to be developed. So people are always looking, can we improve ruxolitinib, particularly in selected group, or can we have something what we call add back strategy, that at 3 or 6 months, if patients are having suboptimal response and those on this like RR6 model that I showed you, can we add a medication? There is ongoing randomized trial with a drug called nabitamidine, which is a MDM2 inhibitor, looking at that question. We have a study where we add emtilistat, which is a telomerase inhibitor that can have some disease-modifying activity in addition to ruxolitinib. Fedratinib is the other drug approved. It's another JAK2 inhibitor. As I mentioned, it doesn't have as much as JAK1 activity. It has some significant GI toxicity, and there were those cases of, they are rare, but Wernicke encephalopathy, so patients have to be on thiamine. It is active. It has probably similar, 30 to 40% spleen response and symptom improvement, but it never gained momentum up front because ruxolitinib in reality is way more tolerated. But we tend to use fedratinib as a second line after ruxolitinib failure, where it has 20 to 30% responses, good spleen response, but it never really gained momentum in the upfront setting because of the tolerability of the drug. So now most of the time it's positioned as a second line if patients are still proliferative, don't have cytopenias. Pacritinib is approved in the USA for patients with platelets less than 50. It's the only drug that can be used when the platelets are less than 50. And it had been shown to have around 30% spleen volume reduction and around 25% symptom improvement. There is some anemia response also seen where patients stop needing blood transfusions. It does have some GI toxicity as well. Momelotinib is the newest drug approved in the USA. Again, it is geared for patients with anemia, transfusion dependency, and symptoms. It was compared to danazol, showed around, again, 1/3 of the patients had spleen volume reduction, total symptom score, and 1/3 of the patients, compared to 20% with danazol, stopped needing blood transfusions. I think the main benefit of momelotinib, it's really gentle on the blood counts and the anemia response. But in general, in our experience, pacritinib and momelotinib are inferior in terms of spleen and symptom improvement. But nonetheless, in settings where there is cytopenias that are significant, where you cannot use the ruxolitinib, then they become our option of treatment. So upfront for patients less than 50 platelets, we use, pacritinib. Second line with anemias, we use momelotinib. Now, anemia is challenging in those patients, and the question is always how to treat anemia. If patients need JAK2 inhibitors, so if they have constitutional symptoms, splenomegaly, as I mentioned, now we have the second line generation, but we do also use combinations. Ruxolitinib had been, combined with ESA. There have been studies where combining ruxolitinib with danazol, thalidomide. In the Comfort 1, ESAs were not used. In the Comfort 2, they were. There's a lot of anecdotal and real-world experience using ESAs that can mitigate the anemia with ruxolitinib, and there are newer treatments. If patients don't have constitutional symptoms of splenomegaly, that they don't need a JAK2 inhibitor, then we really have less options. We try ESAs, especially if the EPO level is low, probably even way less than 500. Danazol, modest activity. We use thalidomide, we use lenalidomide if the platelets are reasonable, and we've had success with thalidomide and lenalidomide. It's 25 to 30% responses for anemia, but they could be very durable. I have patients 8 to 10 years on thalidomide or lenalidomide with a cytopenia response. If the platelets are low, we use thalidomide. If the platelets are high, we use lenalidomide, and we combine them with steroids for the first 3 months. This is just showing this momentum trial that led to the approval of the momelotinib, but in reality, it's the only randomized controlled clinical trial that showed also danazol benefit. That it has somewhere, around 20% transfusion independency. But if you look in reality, like 15% of the patients were not needing blood transfusion, 20% at week 24. So it's really 5 to 10% that stop needing transfusion. So it has very modest activity. I tend to prefer thalidomide or lenalidomide over danazol if patients have pure cytopenias without constitutional symptoms or splenomegaly. And this is some of the studies, again, summarizing use of thalidomide or lenalidomide. Again, mostly cytopenia response. Spleen response, in my experience, is very modest. Now, luspatercept is a drug that is approved in MDS and had become the frontline choice in patients with MDS with ring sideroblast. It's also been looked at in myelofibrosis. There was this study that we were part of that looked at different cohorts. The best, responses were observed in combination with ruxolitinib. So ruxo plus luspa arm had the highest responses in terms of hemoglobin improvement and transfusion independency. So now there is ongoing randomized phase 3 clinical trial looking at, ruxo plus luspatercept in those patients. So, and hopefully that will allow us to do a higher dosing. There is another drug in development. Both luspatercept and elritercept are TGF-beta fusion trap proteins. Also, elritercept is developed in MDS, but in myelofibrosis, there was an initial presentation showing promising anemia response, but interestingly also some spleen responses and symptom improvement in myelofibrosis. So I think a combination strategy sometimes can be thought of to mitigate the anemia in patients that have constitutional symptoms, splenomegaly, and need for JAK2 inhibitors. So in summary, myelofibrosis is a rare disease, but one of the most symptomatic MPN subtypes and does affect patients' overall survival. The diagnosis requires hempath and molecular testing. The modern risk stratification include molecular assessment. Allogeneic stem cell transplant is our only curative option, so we should think of it constantly for patients available. JAK2 inhibitors are standard of care, spleen symptom improvement, and among those patients that need treatment, they are associated with overall survival benefit. Use of Hybria as first line is really not standard of care, as suboptimal. Ruxolitinib is the standard of care up front. Newer JAK2 can be second line. Treatment of hypercytopenia is unmet need. And future directions include combination therapies. I would end just putting a plug. I'm part of the King Hussein Award, and the next cycle opened. I will encourage everybody to apply. There is a Lifetime Award, Young Investigator Award, and there are actually research project funding. So we'd like to see a lot of people from Jordan applying for the King Award. The deadline in June. If anybody needs any help with directions how to apply, please email me. With that, I will stop, and thank you very much for listening.
Thank you very much for this excellent presentation. Due to time constraints, I will take 2 questions. Anybody has question? I don't know if the audience has a written question. Muhammad, please.
Doctor, for this talk, my question about do you think that's all patient myelofibrosis at some day they will become a higher risk?
Yeah, so that's a good question. Probably over time, yes. And obviously, eventually, 1/3 will progress to AML. AML coming from myelofibrosis is the worst subtype of AML we can deal with. I've had patients diagnosed with myelofibrosis in their 20s. And I think, obviously, again, looking at patients in the Middle East, they tend to be on the younger age. So eventually, they will progress. with symptoms. And once you have symptoms and some cytopenia, you are automatically in the higher risk. So yes, and that's why sometimes when we see patients very early on and they don't have symptoms, still in the early phases, sometimes we try to do some treatments that may alter the natural history of the disease, like interferon. But definitely over time, all patients will progress to a higher risk or AML.
Okay. Dr. Firas?
Thank you, Dr. Rami. Dr. Rami, what do you think about the TPO-induced myelofibrosis? Is it reversible? To how much is it reversible? And if it reverses, can we re-challenge TPOs again?
Right. So this is in the setting of ITP, right? The question.
Yes.
Yeah.
Yes,
So,
it is.
Right. So obviously, it's been reported with all the TPO stimulants that they can cause fibrosis. I've seen cases where it ended to be that those patients had myelofibrosis or MDS. So in those cases, it will not be reversible. It's probably not the cause that the TPOs did not cause the myelofibrosis, but it was there and it just accelerated that. So we always do the work looking for, do they have a JAK2 mutation or calreticulin mutation or so? If not, most of the time they should be reversible. They are not that common and mild to happen. Re-challenging is hard. It depends on how extensive they happened. So I would look for alternatives, particularly now that we have other options for ITP. Ironically, we actually use TPO stimulants in MDS lower risk, where we can use eltrombopag or romiplostim if patients present with isolated thrombocytopenia and the risk of fibrosis had been very low. So if patients develop fibrosis, I'll just make sure that they didn't have unmasked myelofibrosis or MDS with fibrosis before. If that's the case, obviously those are not reversible. If it is just reaction for the drug, I'll try alternatives, but they still can be used in MDS. In myelofibrosis, there are very small series where they looked at TPO stimulants in myelofibrosis, and there are really no responses. So we don't use them in patients with myelofibrosis.
Okay, thank you very much, and thank Hikma for sponsoring this symposium. I have a question from the audience, which is, can you tell us more about the award? I assume they are talking about the King Hussein Cancer Award, which Dr. Rami Komroji was a recipient of this award. Let me say that the award is usually announced online. It's in the public domain, and there are several variants of it. One is lifetime achievement, one young investigator, and one is for an encouraging product. There are at least 3 important subjects, topics, and usually it's open to investigators of either regional or Jordanian origin, Arab origin. It doesn't matter where they work, whether in Jordan or outside. But Dr. Rami Komroji, we are very proud that you received that award, and we hope you will receive more awards in the future. Thank you very much.
Thank you, Allah Khalik, Doctorna. And yes, definitely we want to see Jordanian dominance in applying for the award. So I appreciate the invitation and thank you very much.
Dr. Atman, are you with us? Can you move the slides for Dr. Atman? Good evening, everybody. Thank you very much for attending the conference. It's a great pleasure to introduce Professor Othman Sawaf. Dr. Othman is an expert in lymphoma and especially in CLL, and he has lots of publication about the CLL in particular. So Professor Othman, he's a hematologist, a medical oncologist at the University Hospital of Cologne, Germany, and the principal investigator of the of the German CLL study group. He studied medicine in the University of Aachen, Germany, and joined the Department of Internal Medicine of Professor Halleck at the University Hospital of Sologny in 2016. Following his postdoc studies at the Francis Crick Institute and the UCL Cancer Institute in London, he became a group leader at the Integrated Cancer Research Laboratory in Sologny in 2024. His clinical work focuses on the treatment of lymphoid myeloid malignancies, with particular interest in CLL and lymphoma in general. In addition to his clinical trial work that covers national and international phase 1 and phase 3 trials, he is interested in the principles of cancer evolution and metabolism. His research laboratory focuses on computational approaches for the discovery and development of new treatment strategies in clinical oncology. So Professor Othman going to talk to us about treatment of CLL. What's the update, especially with the BTK and BCL2 inhibitors and probably combinations, and probably for the fixed duration, I mean with ibnituzumab and venetoclax, the data that was updated in 2024, ASH. The floor is yours, Professor Othman. Thank you.
Thank you very much for the generous introduction. It's a pleasure to be with you. And yeah, I'll quickly go through some of the items around CLL therapy with BTK and BCL2 inhibitors. Can you see my slides? I can't. Well, it seems you can see them. Yeah, wonderful. So yeah, I'll directly start off with sharing my disclosures and this disclaimer from HICMA. And maybe start with the group of patients that is probably the majority of patients with CLL, that is those who have asymptomatic CLL. I'm sure the same applies also in Jordan, that most of the patients who have a diagnosis of CLL do not necessarily need therapy when they present to your clinic. And so what do we do with these patients? And here we have actually one of the first randomized studies that were ever conducted in CLL in the early 90s, where patients with this kind of situation, asymptomatic CLL, just an increase in lymphocytes or a mild increase in lymph nodes, but no other complaints. And these patients were randomized to receive watch and wait, which you can see in the upper curve, or receive chlorambucil, which was at that time a standard of care. And you can see that there was no survival advantage of giving chlorambucil for these patients in that situation. And therefore, the watch and wait principle was demonstrated here for the first time in a randomized setting. And then in our study group, we had multiple attempts to change that by doing, for instance, a randomization against FCR for these patients in the CLL7 trial. And again, we don't see an advantage in overall survival for these patients. So even a more intensive chemomonotherapy does not prolong overall survival for these patients. And finally, then we had CLL12, which is a study that also focused on asymptomatic CLL, where the patients received either continuous ibrutinib or a placebo. And again, the study demonstrated that early treatment initiation, even with a very potent compound like ibrutinib, does not extend the overall survival of the patients compared to placebo. So de facto watch and wait. And so it means that also for today and probably for tomorrow and for the foreseeable future, asymptomatic CLL, regardless of whether it is high or low risk disease, should be managed with watch and wait. That should not be treated with active CLL specific therapy. And now when we have symptomatic disease, we have a couple of options. So let's say you have a patient in front of you that does have symptomatic disease and requires therapy. You have the option to utilize limited duration treatments in the first line setting. And that is, of course, on the one hand, chemomonotherapy, which is in of itself also a fixed duration treatment, or giving a fixed duration targeted therapy. And here we have, at least within what has been established in clinical trials, venetoclax obinutuzumab and venetoclax ibrutinib. And I appreciate that not all of these approaches are feasible in every region or not reimbursed in every region. Also in Europe, the reimbursement status is very heterogeneous, regardless of whether or not the treatments are really approved. So we have, in theory, these options, and then we have also the continuous treatment strategies available with ibrutinib and also with the next generation BTK inhibitors like Icala and zanubrutinib. Let's look first at some of the data on ibrutinib in the first line setting, and here we really have a lot of different data sets that really have demonstrated the efficacy of continuous treatment in that space. So we have, for instance, here the ECOG 1912 study, which is a cooperative group study, extremely well conducted with a clear randomization of continuous ibrutinib with rituximab in this case, but we can ignore that for now. Basically, it's continuous BTK inhibition, and this was compared to chemomonotherapy with FCR in young and fit patients. And the study famously showed a significant progression-free survival advantage, as you can see in the upper left corner, also in unmutated and even in mutated IDHV settings, and also an overall survival advantage for continuous ibrutinib as compared to FCR. And we have a complementary data set in that case, which is from the UK study group, the FLAIR study, which also did a comparison of continuous ibrutinib against FCR, and you can see that the advantage here is particularly derived in the patients with unmutated IDHV, whereas patients with mutated IDHV, as you can see on the left, had a similar outcome with FCR 6 cycles as with continuous ibrutinib. And this is particularly noteworthy because in these low-risk patients, a 6-cycle therapy with FCR seems to provide a similar rate of disease control as this continuous treatment with ibrutinib. So one could argue and say that for this group of patients, a treatment with FCR is still acceptable, since it seems to be somewhat similarly effective. The issue that we have with FCR in this context is that we know that it produces very long remissions or long-term remissions in patients with mutated IDHV, also seen here from the MD Anderson data set, where over half of the patients, or roughly half of the patients, remains in remission 10 or 15 years after 6 cycles of therapy. So this is very encouraging to see that with a very short therapy of 6 cycles, you can gain these long-term remissions. So why do we, for instance, in our guidelines, move away from FCR despite this efficacy? And the problem is that FCR is associated with a significantly increased risk of second cancers. And this is maybe not that relevant in a 70 or 80-year-old patient with CLL who do not have a sufficient life expectancy to experience a second cancer. But given that we give FCR for 50 or 60-year-old patients, we see that the odds ratio for patients having received FCR and experiencing a second cancer is higher than 4 or 5 times. So this means that there is a substantial risk for second cancer. So approximately a fifth of the patients will experience one, not necessarily all of them hematological malignancies like AML or MDS, but still a significantly increased risk. And therefore, it seems that given that with continuous or with targeted therapy, we do not see a similar pattern, that the risk-benefit profile of targeted therapy is more favorable also with mutated IGHV, despite the encouraging efficacy of FCR in that space. With ibrutinib in particular, we are fortunate to have really a very broad representation of patients across different randomized studies. So we have data that you saw before from ECOG 1912, which was done exclusively in young and fit patients. We have the data from the ALIGN study, which asked a similar question, but in elderly and fit patients, where a comparison against bendamustine rituximab was done, where we see higher efficacy of ibrutinib than chemotherapy, and then eventually also in the ILLUMINATE study, which focused on elderly and unfit patients and showed higher efficacy of continuous ibrutinib over chlorantraniliprole. So in that sense, we really have a very broad and robust data set when it comes to the efficacy of ibrutinib. What we also know, and we should still bear in mind, is that ibrutinib does not have necessarily the risk of second cancers and controls the immune system or restores the immune function quite effectively, but it does have the specific side effect profile related to cardiovascular toxicities. So we have things like atrial fibrillation, also more malignant arrhythmia, we have cardiac deaths and sudden deaths, we have bleeding disorders and hypertension that are associated with treatment with ibrutinib. Some of these side effects are class effects that we will always see with any BTK inhibitor, and some of them are possibly more related to ibrutinib in particular. And this is where we have next generation BTK inhibitors, where we know that, for instance, acalabrutinib is non-inferior to ibrutinib in terms of progression-free survival. So these patients have acalabrutinib is not more effective than ibrutinib based on these randomized data. But it does have a lower risk of some of these side effects. So you can see that atrial fibrillation or hypertension, for instance, is less common with acala than with ibrutinib. However, we should take that with a grain of salt because this is only a relative risk reduction. So if you have a patient with a high burden of cardiac comorbidities, also with acalabrutinib, as you can see from these curves, the risk of atrial fibrillation or of bleeding does increase over time, given that these are all continuous therapies. So up to 40% of the patients will still experience bleeding with acalabrutinib. So therefore, it's only a relative risk reduction and still a clinically relevant side effect for these agents. Pretty much the same applies also to zanubrutinib, where we have also a head-to-head comparison to ibrutinib, where we see that there are fewer atrial fibrillation events with Zanu than with ibrutinib, but this is really limited to the side effect. All other side effects like bleeding or hypertension and so on are balanced between zanubrutinib and ibrutinib, meaning that if you have a patient that develops hypertension on ibrutinib or has upfront already an increased risk of bleeding because of anticoagulation, in my view, there is no rationale based on these data to use zanubrutinib again instead of ibrutinib, given that the bleeding at risk for these patients is similar. What we do see is that the risk of atrial fibrillation is lower with zanubrutinib than ibrutinib, but beyond that, all other side effects are equally common, at least based on these randomized data. Even though there is a slight efficacy advantage for zanubrutinib in this study, it does have some methodological constraints due to the study design, but I think what we can assume is that zanubrutinib is at least as effective as ibrutinib. So now moving away from the continuous treatments, we also have the fixed duration options, and there are several strong rationales to use limited duration strategies in CLL. One of them being, of course, that we expect to see less toxicity if we have treatment that takes just 1 year instead of 5 or 6. We naturally have less drug exposure, and we hope that we see less drug resistance. And this is something that's, of course, very relevant for future retreatment strategies and considerations. So the first study that really explored fixed duration treatment in CLL was CLL fixed duration targeted therapy in the first-line setting was CLL14, a study for elderly and unfit patients who received 1 year of NO versus chlorambucil obinutuzumab. And this study, which finished enrollment almost 10 years ago now, has shown, and also in the latest follow-up confirmed, a longer progression-free survival with fixed duration than O compared to chlorambucil obinutuzumab. We do see that high-risk disease is still prognostic, so these patients with TMP3 alterations relapse earlier than those without, indicating that maybe for these patients, continuous treatment strategies might be more favorable. For unmutated IGHV, we also see a prognostic impact that is less pronounced. And we see especially that the time to next treatment for patients is very considerable. So the patients, even when they have an unmutated IGHV, the vast majority of these patients will still be treatment-free at 6 or 7 years after therapy, really indicating that the rate of disease control is quite considerable also when you have an unmutated IGHV. One variable that is of particular interest is the MRD status, not necessarily for routine clinical care, because there it's really just a prognostic variable, but within clinical studies, it allows us to identify patients at highest risk of relapsing earlier or late. And what we see in CLL14 and also in other studies is that the patients with MRD positivity relapse earlier. So we can see the median progression-free survival after end of therapy is roughly 2 years for these patients, whereas those who are MRD negative have a long and sustained remission. So we can discriminate clinical outcomes already at the end of treatment by utilizing MRD in clinical trials and identify patients who have adverse outcomes or adverse prognosis, also in terms of overall survival. So in that sense, it's a very informative endpoint that not necessarily has immediate clinical implications in routine clinical care, but certainly for clinical studies. And then finally, as I mentioned, we expect with shorter therapies to have less side effects. And what you can see here is that after 1 year of therapy, there's virtually no toxicity anymore for these patients. So all of the toxicity occurs during the 1 year therapy duration, whereas after therapy, there is no toxicity anymore, really confirming this advantage of having fixed duration therapy. And here again, we have a complementary data set from CLL13, which was focusing on young and fit patients, having 4 different arms, which are venetoclax based, all fixed duration, roughly 1 year therapy, compared to chemomonotherapy with FCR or BR. So more intensive chemomonotherapy, given that these are younger and fitter patients. And again, we see that the venetoclax-based combinations achieve higher MRD rates, especially when we use obinutuzumab with or without ibrutinib. So this shows that the depth of remissions is higher or deeper when we use venetoclax-based therapy with a type 2 CD20 antibody, and naturally this also translates to a longer progression-free survival, as seen here with these venetoclax-obinutuzumab combinations. And then alternatively, we now also have the opportunity to combine venetoclax with a BTK inhibitor, with ibrutinib, and this is something that's still under development at the moment. We know from a phase 2 study, the Captivate study, that if you achieve MRD negativity with venetoclax ibrutinib after 1 year and you stop therapy there, that your outcome as seen here is similar to patients continuing with a maintenance treatment with ibrutinib. So in that study, in the Captivate study, there was a cohort of patients who received 1 year then venetoclax ibrutinib. When they were MRD negative, they received a placebo, or they continued with ibrutinib. You can see from here that the progression-free survival is similar for patients taking placebo, thereby having stopped therapy, or patients continuing with a maintenance treatment with ibrutinib. And this really highlights the efficacy and advantage of fixed duration treatments that allow us to dispense with a continuous or maintenance treatment for these patients. So I think quite encouraging data in that space. And for the alternative here, we have a phase 3 study, the GLOW study, with fixed duration venetoclax and ibrutinib given for 1 year and compared to chemomonotherapy. And you can see that progression-free survival in that study, somewhat similar to CLL14 in this elderly unfit patients, is very favorable for I+V compared to chemomonotherapy. We again see that unmutated IGHV tends to be associated with a worse prognosis with this fixed duration approach, indicating that the high-risk features or higher risk features have a particular impact when you give a fixed duration treatment, regardless of what combination you use. And you also see in this study in particular the prognostic relevance of MRD. So anyone who stays MRD positive is more likely to relapse earlier than those who are MRD negative. I assume that this is a universal pattern that we will pick up with any combination therapy where MRD will discriminate clinical outcomes. And for TP53, it's pretty much, again, the same. We see that those with TP53 alterations have a median PFS of roughly 49 months. So again, in a similar range as to what we saw with CLL14, where the patients also tend to relapse earlier, which is why we tend to recommend continuous treatments for these patients, even though we don't have randomized data for that. We are working on generating these data in CLL17, which is a phase 3 study where we do compare continuous ibrutinib to fixed duration therapies with Ven-O and Ven-I, so 3 arms where we compare them to each other, and hopefully we'll be able to say whether, for instance, high-risk features benefit or are more susceptible to continuous treatment and fixed duration treatment. So hopefully we'll be able to address many of these points in the near future. Then finally, just a few words on retreatment considerations. What we've seen in relapsed CLL is that when the patients progress after a fixed duration treatment, they do not acquire treatment-related or specific mutations. So we don't see BCL2 mutations, for instance, after venetoclax obinutuzumab or venetoclax rituximab, and we are seeing more and more data that suggests that you can retreat these patients with venetoclax again and achieve a high response rate of over 70% when you re-expose these patients. And we are generating prospective data in our REVENG study where we do retreat the patients prospectively when they have progressed after venetoclax obinutuzumab in the first-line setting. So this is an ongoing study where we want to generate more data for this. And we see a similar pattern also with venetoclax ibrutinib, where also when the patients progress after fixed duration treatment, they do not acquire any BTK or BCL2 inhibitor-related mutations, thereby meaning that in a biological sense, these diseases are not refractory to any of these agents, and therefore retreatment is very intriguing for these patients. And there are, again, some preliminary data, for instance, here from Captivate, where virtually all patients respond to a retreatment with ibrutinib or ibrutinib venetoclax after they have progressed following venetoclax ibrutinib fixturation. So I think this indicates that in the future we will be able to use our agents multiple times when we use them for a fixturation, and thereby have the ability to reduce treatment exposure whilst increasing the duration of disease control for our patients. So with that, I would like to conclude by summarizing the main items here. Targeted therapies, as you saw from these data, have shown consistently higher efficacy or risk-benefit profile, better risk-benefit profiles than chemomonotherapy in CLL. Most patients can be offered long-term disease control with these three main tools of our toolbox: the BTK inhibitors, BCL2 inhibitors, and CD20 antibodies. And the decision whether to use a continuous or fixed duration approach should be primarily based on the patient preference, the side effect profile, and possibly also the disease genetics, and thereby still be a very individual decision based on also the availability and access to the different compounds and what works best for each patient's individual circumstances. With that, I'll conclude. Thank you very much for listening, and I'll hand back to the chair.
Thank you, Professor Othman. Impressive, comprehensive overview about first and subsequent therapies for CLL. Any questions from the audience or from on the chat? Yes, Professor Dr. Abdullah.
Yes, in our local population, the dose of venetoclax 400 milligram daily is not tolerated by almost all patients. Is this the experience in Germany and other industrial countries?
Thank you. That's an interesting observation. Not to that extent. So I've seen that this is a frequent issue in Southern America, where I also hear from a lot of colleagues and investigators there that they also often require dose reductions. So in our data sets, what we see is that approximately 20% of the patients require dose reductions. And we see a strong correlation also with the age and fitness of the patients when it comes to dose reductions. And I think what we notice with targeted therapies in general in hematology and in oncology is that in most cases we have fixed doses for all patients, which is different to what we are used to do when we give chemotherapy, where we have always considered the body surface area and other parameters to optimize and individualize the dose. And for some reason, I guess for convenience, we've moved away from that. But it makes, of course, sense that not every patient would require 400 milligrams. And therefore, typically, when you have a patient that requires repetitive dosing interruptions or reductions, it makes sense to reduce the dose of venetoclax, for instance, from 400 to, let's say, 300 or 200 milligrams. We are currently doing an analysis that we'll hopefully publish soon, where we do notice that dose reductions down to 80 or 75% do not impair the progression-free survival at all. We see that there's a slightly worse PFS when you go beyond 70% in terms of PFS, but it's a mild effect. So therefore, I would recommend that whenever you notice impaired tolerability, that you just continue the therapy with the reduced dose, and you can expect to have still a favorable outcome overall in most patients.
Thank you. Dr. Sherman, please.
Yeah, thank you, Dr. Othman. In fact, I have two questions. The first one is about using ibrutinib in the asymptomatic patients, as you started your lecture talking about that. I know the trial did not show overall survival benefit, but it showed significant improvement in the progression-free survival. And don't you think that because CLL, it has many lines of treatment options, you need a longer period of time to follow these patients, during which you can observe their overall survival advantage, if there is? I know yourself, you was an investigator in the trial. Are you conducting like a longer term data collection on these patients to see if that ibrutinib treatment would affect overall survival, or the results are final that you published? My second question is about ibrutinib treatment long term. Do you think that we need like to discontinue or stop treatment, give them break after 6 years or so, because that can decrease the rate of resistance to treatment? Ibrutinib, I'm talking about proton kinase inhibitors. What's your thought on this point? Thank you.
Thank you. These are very interesting points. So regarding the first one, there are a couple of methodological challenges in CLL12, and therefore it's difficult to say whether eventually there might be an OS difference to be detected. The problem is within the data set that when patients in the placebo arm progressed, you would expect that not all of them received ibrutinib. Some of them, for instance, progressed on the placebo and then received FCR by the investigator because it wasn't mandated by the protocol. So you will end up having a comparison of continuous ibrutinib in your experimental arm compared to placebo followed by FCR. And we already know that ibrutinib is more effective than FCR from the ECOG study and the other data that I showed. And therefore, it's not really a very clean comparison that we do. And potentially, therefore, even if you would see an overall survival difference, it might have been driven by the fact that some patients did not receive targeted therapy as a de facto first-line therapy. And in fact, they received chemomonotherapy. Some of them also received bendamustine, rituximab, and so on. So this is a caveat in this data set that it wasn't pre-specified what the patients in the placebo arm receive. And therefore, I wouldn't trust an overall survival difference too much. And I would assume, to be honest, that if all patients would have received ibrutinib when they progressed in the placebo arm, that it's unlikely that you would see a survival advantage, given, as you say, the second and third line options can be quite effective already. I think the question is very open for TP53. So it's possible that in patients with high-risk CLL, that there we might identify a benefit of early continuous BTK inhibition or any other like combination treatment maybe also for high-risk disease. But these were only 7% or so of the patients in CLL12. So this is something that we unfortunately can't properly answer with this data set. In that unpowered subgroup, there is clearly no benefit at this stage for the early treatment. Regarding your second point, yes, follow-up, I agree with you that is so essential, not just in CLL12, but in basically all other randomized and non-randomized CLL studies. So officially, the final readout was last year, where the study had to be closed, mainly because of the study budget and so on. But most of the patients have been transferred into the registry, which is like an observational registry. So hopefully we can at some point extract further data from this cohort and share it with the community. But I absolutely agree with you. I think long-term observations are so essential for us to understand such a chronic disease like CLL.
Thank you. Any other questions? I have a question. Always we're hearing about the fixed duration in those very high risk patients, ultra high risk patients, like P53 mutated patients and unmutated IVIG. So would you still, though you showed some studies showing a reasonable progression-free survival, would you still comfortable doing the fixed duration for those high risk patients? What's your thought on that? Thank you.
Yeah, thank you. That's a great point. Yes, and we have in our studies and also other studies, we do have patients with high-risk CLL that have received fixed duration treatments. And I think this is also reflected in our guidelines and in most other guidelines. It's not contraindicated. It's a question of like prioritization or hierarchy of recommendations, but it's never contraindicated or wrong to give a fixed duration therapy. So to give you an example, as I mentioned, we have the REVENG study ongoing where we retreat patients with venetoclax fixed duration. And the first patient that we enrolled in that study had received venetoclax obinutuzumab with TP53 alterations and had a remission of 4 years and then relapsed and then is now in full remission with retreatment. So essentially the patient has now disease control for 7 or 8 years now with overall 2 years of therapy with a long treatment-free window. We would possibly have been able to do a similar rate of disease control with a continuous treatment, but with much more therapy. And therefore, I think this demonstrates that when we can implement these interval therapies, fixed duration treatment can be very reasonable for high-risk disease as well. I think it needs further exploration, and ideally, we need to put these patients into clinical trials to capture these data. And I do hope that at some point we can also find like study centers and study sites in Jordan and in other countries in the Middle East to have more representation of also Arabic patients in our clinical studies. But yeah, I think ideally these patients should be somewhere captured. Maybe, I don't know whether it'd be interesting to hear whether there are efforts, for instance, in Jordan to have at least like registries and to capture these data from your communities to understand CLL in your region a little bit better.
Yeah, thank you. Any other questions? So I have just I'm a transplanter. Where you would put the allotransplant and the CAR T-cell approach in CLL patient in particular?
Yeah, that's a great point. So at the moment, transplant is pretty much considered for later lines of therapy. The reason, of course, being the toxicity and, of course, the efficacy of conventional therapies, especially in earlier lines. We have seen also, if you look at the EBMT registry, the numbers of CLL transplantations has been decreasing substantially over the last few years, but in some regions, including in ours, we see that there is at the moment a slight increase again of allotransplants for CLL. And this is particularly for patients who are double refractory. So we've been able in the last few years to keep those patients in remission with BTK inhibitors and BCL2 inhibitors. But now we are seeing that these patients are relapsing, and even novel therapies with non-covalent inhibitors and so on are also just producing a remission of 1 or 2 years at best in this space. And so if you have a 55-year-old patient with double refractory CLL, they will for sure at some point die due to their CLL. And therefore, it is essential for these patients, when they get into a remission, to consider some consolidation, either with an allogeneic transplant or possibly with CAR T-cell therapy, even though CAR T-cell therapy has very limited efficacy in CLL at this stage. There's one large data set from the Transcend study with Lysocell. Over 100 patients received this CD19 CAR in CLL. And the double refractory patients, so those where we would in practice most consider such an approach, had a median PFS of just 11 months for a therapy that costs $600,000 in the US and is also not without toxicity. And so it shows, I think, that there is still a group of patients that, in my view, will increase in size and number that will require some sort of cellular therapy. I would say from the third line onwards. And even here in Cologne in the last year, I think we had 2 or 3 patients with double refractory CLL that went into transplant who were 60 years and younger. So I think it's something that will have a revival again.
Yeah, thank you very much. Very nice talk, very nice discussion. And let's move to next session. Thank you, Professor.
Thank you very much.
So hello again. Please join me to welcome Professor Cataland. He joined us from Ohio, the United States. Professor Cataland is an esteemed hematologist and a professor in the division of hematology at the Ohio State University College of Medicine. He also serves the role of the Associate Director for Mentorship. His research interests, of course, include thrombotic thrombocytopenic purpura and atypical hemolytic uremic syndrome, with special emphasis on novel therapeutic approaches to the treatment of both disorders and long-term complications of both diseases. He co-founded the United States Thrombotic Microangiopathy Clinical Consortium that now includes over 25 academic medical centers across the United States that collaborate on research and clinical initiative to benefit patients. So the floor is yours, Professor Cataland.
Thank you very much for that kind introduction and the invitation to participate in the Jordanian Society of Hematology meeting. Much appreciated. Shall I go ahead and share my slides?
Yes, please.
My tech skills are limited, so I hope this goes well. Let's try this. I think you can see those slides, I hope.
Yeah, we can see it, so please go
Thank
ahead.
you. Well, again, thank you all very much. My talk today is going to be entitled 100 Years of TTP, and we're just getting started. And this really comes on after the year 2024, where we marked 100 years since the first reported case of TTP by, as you can see in this image, Dr. Eli Moskowitz, an immigrant from Germany who came to the US and was the first to describe what is a disorder characterized by thrombocytopenia and findings consistent with thrombocytopenia, but also thrombotic issues as well. And the case was that of a 16-year-old female, a high school graduate, went to business school, working, went to the beach for the weekend, returned on Sunday night, and Monday morning developed weakness, pallor, constipation, and these symptoms progressed over the next several days. She was eventually admitted to the hospital. And again, this is in 1924. So there's no effective therapy. And really, Dr. Moskowitz really effectively, clinically, and pathologically defined this disease. She unfortunately progressed to partial paresis of her legs, arms, and eventually died. And as we know today, this is exactly how patients with TTP can die and are likely to die. And what you see in this image here is a section from her myocardium showing microvascular thrombosis in the terminal arterioles. And these were seen throughout her myocardium. So clearly defining the disease and showing the pathophysiology, although it took many years, as you can see here, to really understand things better. And we published this with my colleagues and friends, Bernhard Paul and Marie Scully, in the last year. And this was adapted from a slide that Shruti Chatterjee allowed us to use. And you could see the time course of the first report from Eli Moskowitz all the way through the discovery that plasma therapy may be effective in TTP, understanding the pathophysiology of TTP, and then some advances that followed this in terms of therapeutics, rituximab, caplacizumab, and recombinant datum TS13, which we're going to talk about all of those today. What you should also see is a change in the mortality over time, which follows an improvement in the understanding of our disease. And you start to see a change in the goals of the therapy, or goals of treatment. First, it's just survival. Then we're trying relapse prevention. And what we're seeing now is efforts to improve the long-term prognosis of these patients, not just from acute TTP episodes, but as you'll see, some long-term complications that they're significantly at risk for. This is an image that I think created by the late Evan Sadler, really showing what we now know as the pathophysiology of TTP. And in the upper panel, what you can see is what is supposed to happen. And when these ultra-large multimers are secreted from endothelial cells, under condition of high shear forces, they will open up and be cleaved by this ADAM TS13 protease. And by doing this, thrombosis will happen where you need it to occur. Again, the physiologic. Below is the pathologic. You don't have this ADAM TS13 protease function, whether it's congenital deficiency or an antibody inhibitor of the protease. When you don't have the function, you don't get cleavage, then you get these ultra-large VWF multimers that are quite avid and will very quickly and actively combine platelets and form the microthrombotic disease that really characterizes this disorder. Trying to track back the roots and how we sort of progressed in the field. In 2013, we formed the TTP International Working Group, and this was a very informal grassroots group that just started to meet. And I think it was Marie Scully who sent out an email and said, let's all get together at EHA in 2013. We had some encouragement from Evan Sadler, who told us this was important to do this and come up with ideas of what's important in the field. And we were all passionate about TTP research, but also, more importantly, I think, interested in fostering a collaborative approach. This has now evolved into not informal meetings, but regular meetings at TMA workshops that occur at ASH, at ISTH, and this year will occur at EHA. So I encourage you to attend these if you want to. They're free of charge. This nice collegial discussion. And what Maria had done, as you can see in this image, in the States, we talk about wrangling cats being a difficult thing with doctors. And she did a very good job of wrangling the doctors and getting them all on the same page. One of the most important things we had to do was define terminology. And there was a lot of different uses and confusing reports in the literature because different people were using different terms to mean different things. And what we've talked about and standardized is a clinical response, so normalizing the platelet count after plasma exchange therapy. A clinical remission is maintaining that response for 30 days after you stop plasma exchange. An exacerbation is a recurrence in the first 30 days after stopping plasma exchange. And a relapse is a recurrence requiring the resumption of therapy beyond 30 days. And the real point of the exacerbation and relapse definitions are to define what is thought to be more likely a continuation of the prior episode, like exacerbation, from what is a new and distinct episode of TTP. So when you say a relapse patient, we all know what we're talking about. A couple years later, Adam Sucher from Philadelphia in the US led the charge to change these definitions. That was really driven, and as you'll see in upcoming data from some of the Titan and Hercules studies, the changes in the therapies that required us to change these definitions. So an exacerbation is now thrombocytopenia within 30 days of stopping plasma exchange or any anti-BWF therapy. So anything that may protect the patient from an early recurrence, we have to account for that now. And we'll talk about ADAM-TS13 activity in remission in recovery being predictive of increased risk of relapse. And those are patients you're going to preemptively treat with immune suppressive therapy. So the definitions needed to change. We have remissions, both partial and complete, of the ADAM-TS13 activity, but also an ADAM-TS13 alone, relapse alone, without clinical relapse of TTP. And these are situations where you're going to talk about preemptive therapy. If we go back to exacerbations, which I think is an important point and often overlooked in the treatment of this rare disease. Again, it's recurrent thrombocytopenia 30 days after the last plasma exchange or anti-BWF therapy. And we mentioned before, this is a continuation of prior, not a distinct new episode. But some important points to remember, it's going to happen in a third of patients. So this is a very real phenomenon when you stop plasma exchange. And it's most commonly to occur in the first 2 weeks. And it's significant. It requires the patient typically to go back to the hospital, another line placement for plasma exchange, and restarting plasma exchange therapy. So as immune suppressive therapy was being studied, now this is more almost 10 years ago, looking at the roles of steroids and rituximab we routinely use to treat this disease and why they are or are not effective in exacerbations. And steroids obviously suppress the production of these anti-ADAM-TS13 antibodies and allow the recovery of ADAM-TS13 activity. And rituximab gives a more durable response of a similar approach, targeting anti-CD20 B cells that produce these antibodies. Again, removing it by plasma exchange, blocking the production of these antibodies. But if we look what happens, and these are data from a study we did many years ago now, comparing both steroids and steroids and cyclosporin as an adjunct to plasma exchange. And to orient you, the pretreatment is obviously before plasma exchange starts. But week 1, 2, 3, and 4 are the 4 weeks after the patient is discharged from the hospital. So this is going to be at least 5 days, this first measurement, after the last plasma exchange procedure. And what you can see, I would tell you to focus on the prednisone-treated patients here, is you get a suppression of the anti-ADAM-TS13 antibodies, and you do get improvement in the ADAM-TS13 activity. But it takes several weeks, at least 2 to 3 weeks, until the majority of patients have achieved an ADAM-TS13 of at least 20% that we think is protective against relapse of TTP or exacerbations. If you look at some data from Marie Scully, where rituximab was given in the first 3 days, you see the same thing: suppression of antibodies, improvement of the ADAM-TS13 activity, but it happens beyond the window where they're at greatest risk for exacerbations of TTP. So both very effective, both suppressing antibodies, improving the activity, but they take time to act and will not impact exacerbations. If we now move to the early study, the Titan study, phase 2 study of what is now called caplacizumab in immune TTP. And you can see here the mechanism of action of caplacizumab. It binds to the A1 domain of VWF, blocking its ability to bind platelets. So you might have ultra-large multimers that very much want to bind platelets and form microthrombotic disease, but they're unable to do so because of the effect of caplacizumab. So this was a placebo-controlled randomized study where they all got a plasma exchange, all patients. Half got caplacizumab, half placebo, but importantly, the drug was treated for 30 days after the last plasma exchange procedure, allowing you to test the efficacy of this agent in blocking these exacerbations or early recurrences of TTP. So as you're blocking the consumption of platelets forming microthrombotic disease, it makes sense that there's a shorter time to achieve a normal platelet count. And that's exactly what you saw in the caplacizumab arm compared to placebo. What I think was more important and sometimes gets lost in this is the marked reduction in the exacerbations. So this agent really was protective against early recurrences of TTP. Now, what was stated initially was there's an increased relapse rate, and certainly that is the case, 31% versus 8%. But you have to remember how this is defined, and this study was using the old definition, where it was 30 days after the last plasma exchange procedure. So what you saw was 8 of the 11 recurrences were beyond 30 days, but they were just after the caplacizumab was stopped. So the caplacizumab in these patients essentially had blocked early recurrences and pushed them back, pushed the time frame back so it counted as a relapse. So what this was inadequately treated disease, we now know, allowing for this early recurrence. And this is what you can actually see. If you focus in the placebo arm, almost all the exacerbations had undetectable ADAM-TS13 activity. It had not recovered yet. If you look at very few exacerbations, but what were called relapses of presenting episodes, these are the patients that recurred in the first month, and they all had undetectable ADAM-TS13 activity. So this was an unfinished episode. ADAM-TS recovery had not occurred, and caplacizumab was removed. If anything, this really demonstrates the efficacy of caplacizumab, because if you stopped it, then disease recurrence occurred. And as we all know, the follow-up study, the phase 3 study, incorporated what we learned into this new study. Same exact study, 1-to-1 randomization. The caplacizumab or placebo covered the 30-day post-plasma exchange period, but physicians had the option to continue for an additional 28 days based upon the ADAM-TS13 activity. So those that had not recovered, either immunosuppressive therapy was added or intensified before stopping the drug. So really representing an increased understanding in this second study. This was a much larger study. It accrued much quicker, but you saw the same thing, a marked reduction in the exacerbations, which is encouraging to see. This study was not powered for refractory or mortality, but there's certainly the suggestion of more refractory disease in the placebo arm compared to no patients in caplacizumab, which might make sense given the fact that you're blocking really the downstream effects of this disease by caplacizumab. It's important to remember, and many of you obviously understand, that if we block BWF function, if we block normal function, the side effect is going to be bleeding. And that is certainly the case. The bleeding tends to be mild, tends to be mucocutaneous. In a way, we're creating a milder form of von Willebrand disease, if you will, with epistaxis, gingival bleeding, as well as menstrual bleeding. That was a bit heavier. More severe bleeding is certainly possible. So the patients you don't want to use this in are somebody who is having active bleeding or concerns for active bleeding. But certainly a very interesting agent. And as many of us suspected, caplacizumab wouldn't ever be used independent of the need for plasma exchange therapy. So caplacizumab alone. And many of us suspected that Jehovah's Witnesses who will not take, for religious reasons, blood products were actually the first, we say, the canary in the coal mine to find out. And there was a case report from Louisiana, a patient who was a Jehovah's Witness who achieved a remission without the use of plasma-based therapy. There have since been several reports, and I'll show you one from our own group of using this without plasma exchange, as well from the German and Austrian group, a larger series that shows this is really feasible. Really asking the question, Is plasma exchange and catholicism, are they equal? Are they equal temporizing therapies? And do they have the same effect of protecting patients from recurrence until you improve the ADAM-TS13? And I think the bigger question is there a biologic effect of plasma exchange in TTP? Shortly after this report from this patient in Louisiana in the US, one of our patients who follows with us every 3 months came in. And before we had her labs back, she was concerned. She had some mild abdominal pain, nausea, and was very much concerned that this may represent the earliest signs of recurrence of her TTP. And indeed, when we got her labs back, she was found to be mildly thrombocytopenic with an elevated LDH. We didn't get the ADAM-TS13 back until the next day when my lab ran it, but it was found to be undetectable. She begged us to not put her in the hospital. She's had multiple relapses. She did not want plasma exchange. She did not want the catheter. She's a very compliant patient, and we were able to get approval to dose her as an outpatient. And she was actually started on caplacizumab on that same day in the clinic without plasma exchange therapy. I tried to start her on steroids. She wanted no part of the steroids as well. And since we were going to give her rituximab, I relented. And what we saw was a slow but steady improvement in her platelet count, followed by a decrease in the LDH, which is really a marker of tissue injury, and able to achieve a clinical remission, but also eventually recovery of the ADAM-TS13 activity and stopping the caplacizumab. So this is really one case report, one of the earlier ones, but really where the field is headed. The MyARI study has just completed enrollment. It's a phase 3 open label study. Patients with a clinical diagnosis of immune-mediated TTP, immune suppressive therapy, with the primary endpoint being the proportion of patients who did not require plasma exchange therapy to achieve remission. So I hope you get these results very quickly and very soon, I hope. So switching gears to now the post follow-up, the post remission time period, when we start to look at the risk of relapse and monitoring of the ADAM-TS13 in remission, which is now quite common in patients. This really started to arise out of data from Flora Pavandi's group in Milan, Italy, where they studied 109 patients. The sample studied in remission 30 days beyond the last plasma exchange and prior to any relapse. The majority of these patients had one sample, and they roughly gauged that with undetectable activity and a demonstrable antibody, there was an increased risk of relapse in patients that are in remission. We looked at the same thing slightly differently, and since our patients were seeing us every 3 months, we modeled this as what is the risk of relapse in the following 3 months after an ADAM-TS13 measurement. And if you look at the top panel in all comers, as the ADAM-TS13 activity decreased and got below 10%, there was an increased risk of relapse in the following 3 months. But this risk is not absolute, and by far only 10%. We then broke it down by age, and what you clearly see is the younger you are, the greater the risk of relapse in the following 3 months if you had undetectable ADAM-TS13 activity. I think these data are the first to help us understand that there's more, although the ADAM-TS13 activity is important, there's more than that that are contributing to the risk for relapse in patients. That has really evolved into the regular monitoring of patients every 3 months with the use of preemptive rituximab, which was really driven by the French TMA group and Paul Campo. And they studied 92 patients with undetectable ADAM-TS13 activity that were in clinical remission. And half of these patients had a history of a relapse of TTP, so really demonstrating a relapsing phenotype. Now, the potential issues here using this can be expensive. These are not randomized data. They're compared to historical control, and there's a significant patient commitment. But what I think you can appreciate is in the rituximab-treated patients, there was a marked reduction in the relapse-free survival. Whether you're preventing a relapse or delaying it, certainly rituximab was effective in this regard. If you look at the ADAM-TS13 recovery at day 30, month 3, and so on out to 24 months, then focus on those with above 50% and especially the less than 10%, so ones that did not respond. There are a proportion of patients that did not respond to rituximab, and I don't think this gets talked about enough. If you look at the time course of recovery of the median ADAM-TS13 activity, you see really by 1 to 3 months a leveling out in the improvement of the activity. And I think if you look, this less than 10% group really stays this way throughout the entire follow-up. So I think this is starting to raise questions that not all patients respond to rituximab. These are work from our USTMA consortium that Marshall was up and presented at ASH now a couple of years ago, looking at retrospective data and the risk of relapse of patients, the risk of relapse after rituximab. And in looking at these data, there became clearly an impact of race and treatment relapse found. And patients of Black race compared to other race had decreased relapse-free survival. But when you looked at the patients and it was broken down to de novo TTP and relapse, it was really the white patients, the non-Black patients that were benefiting. And if you look at the relapse-free survival in patients, the TTP treated with rituximab versus not treated, there's a significant improvement in that relapse-free survival in white patients. But Black patients just did not benefit. And I think this is also opening our eyes to the idea that not everybody's going to respond to rituximab, which has kind of been the mantra in the field. Switching gears slightly here to talk about recombinant ADAM-TS13, and this has obviously received regulatory approval in congenital TTP in patients who lack the ADAM-TS13 protease. And you can see the data that started, the initial data that led to this with the infusion of one dose of ADAM-TS13, followed by the time course of the ADAM-TS13 activity during follow-up. It was also intriguing that some in vitro data looking at the ability of recombinant ADAM-TS13 to overcome inhibitors of increasing strength in vitro, raising the question of could this drug be used not only in congenital but the immune-mediated form of TTP. And some of those data, as well as interest of investigators, led to a phase 2 study in exactly that, using recombinant ADAM-TS13 as an adjunct to plasma exchange therapy. So this is a study, 3 arms, relatively small numbers in each arm, a bit of a heterogeneous group of patients, so efficacy is hard to comment on, but all patients received plasma exchange therapy and were mandated to receive the same immune suppressive therapy. They were randomized to the placebo arm where they did not get recombinant ADAM-TS13, arm 2 where they got it once a day at a dose of 40 units per kilogram, and arm 3 where they got it twice a day. Very similar to the caplacizumab studies. What you can see here in this graph is in the brown bars, you can see where each plasma exchange occurs. And what you see in first the brown line, which you can track here, as well as in the 2 blue lines, which is the once a day and twice a day, is the improvement in or the change in the ADAM-TS13 activity over time. You really want to focus on these measurements right before the next plasma exchange, because almost everybody improves, and this is really a function of the infused plasma. But look at the ADAM-TS13 activity before each next day's plasma exchange procedure, and you're going to start to see something very interesting. So even after 3 plasma exchanges, what you see here is nearly normal, 100% ADAM-TS13 activity in the recombinant ADAM-TS13 treated patients. And while that may not seem impressive, I think you need to look at what's happened previously. So this is a study that we did looking at 19 patients, ADAM-TS13 deficient TTP. And the ADAM-TS13 activity was studied prior to each next day's plasma exchange procedure. But if you look at these patients after 3 plasma exchange procedures and right below the 4th, 80% of them still had undetectable ADAM-TS13 activity. So this tells you how interesting this is. We're able to, after 3 plasma exchange, now achieve near normal ADAM-TS13 activity. So not only blocking the disease like caplacizumab, but restore the protease function. Now, does this translate into future benefits in preventing long-term complications or quicker remissions? Remains to be determined. But it is being studied also in an ongoing study, present, it's still accruing, looking at the use of recombinant ADAM-TS13 without the use of plasma exchange therapy, very much mirroring the minority study. So we'll finish up with the last few slides talking about a clinical remission of TTP. And in the old days, it was you were in remission, you had a normal platelet count, you're doing great, nothing more to do. Over the last 10 plus years, we've started to realize that in addition to the risk of relapse, that's very real, and it's tied at least to the ADAM-TS13 activity, these patients don't necessarily return to their baseline. They have short-term memory issues, which are significant. There's a greater risk of mood disorders as well as headaches. But even more striking was the shortened life expectancy that you saw in these patients, predominantly driven by cardiovascular complications. We were first really brought aware of this or made aware of this in one of our patients who unfortunately died during an acute TTP relapse. She was responding to plasma-based therapy, but unfortunately died of cardiac complications. And in looking at the sections from her kidneys, our pathologist said this looks like the kidney of a 70-year-old woman with many years of uncontrolled hypertension. But in fact, she was a 35-year-old woman with multiple prior TTP relapses. But a kidney biopsy showed sclerotic glomeruli, atrophic tubules, and really chronic and significant changes. So are these patients really getting back to baseline? And these are data presented now more than 10 years ago from Dr. George's group at the University of Oklahoma. Looked at 57 survivors, all with ADAMTS13 deficiency confirmed with the disease, and compared their survival to U.S. norms. There was a greater risk of mood disorders, hypertension, but most striking was an increased risk of dying, which was much greater and significantly greater than both U.S. and their local state Oklahoma norms. And you can see the increasing probability of death just with a prior diagnosis of TTP. Now, on the surface, you might say this was all just TTP relapses, and there were a couple of those. But what was striking now more than 10 years ago was what we were seeing: coronary insufficiency, cerebrovascular accidents, cardiac arrest, and strokes again. So something was happening to these patients in remission. Senthil Sukumar, as well as Shruti Chatterjee from Johns Hopkins, both collaborated looking at both the Ohio State and Johns Hopkins populations and looking at the same question. And what they found was the exact same thing: a greater risk of death in TTP survivors compared to the reference population. This seemed to be more striking in older patients. Race was a significant factor in Black patients, as well as diabetes. So again, looking at what Dr. George had found previously, this greater risk of dying. And we've talked about these cardiovascular complications, and similar work from both of our institutions, Ohio State University and Johns Hopkins, looked at the nature of these cardiovascular complications. And MACE, which is defined as the occurrence of stroke, a non-fatal MI, a fatal MI, or the need for cardiac revascularization, occurred in 28% of patients, which was a much higher rate than had been seen in previous populations with existing atherosclerotic heart disease, and stroke being the most common complication that was seen. So we're starting to see a pattern. These patients have an increased risk of death. The increased risk of death seems to be driven by cardiovascular complications. If you look at this same data set, and this is work reported by Max Brodsky at Johns Hopkins as a student, and what you can see also is the strokes and the myocardial infarctions, and when are they occurring? They're occurring at a much younger age than the typical population. So they don't seem to be related to the typical atherosclerotic risk factors, and they are occurring at a much younger age, especially in females. You see the same thing in myocardial complications. There is certainly this suggestion that ADAMTS13 activity may be involved, but at least in this work from Max Brodsky, there was no relationship between the ADAMTS13 activity and the development of these complications, despite what has been seen previously in strokes, which may be connected to that in TTP survivors. So we're really asking the question why these things are occurring and how common they actually are. These are work Senthil Sukumar presented just a couple of years ago at ASH, looking at a cardiac MRI study that we did in our cohort of TTP patients. These were patients in remission who had a cardiac MR done, a stress MR. So at rest, you had images as well as images at stress, really focusing on microvascular function. And what you can see at rest compared to the control patient, and these control patients are comparable group with age and race matched. These are patients who had MRIs done for non-ischemic heart disease reasons. But compared to controls, there was not a significant difference. But the increasing intensity noted by the yellowish red and yellow colors was certainly greater at stress, so under stress MRIs. you had greater perfusion in the control patients compared to the TTP patients. So a marked reduction in the perfusion. And if you characterize this microvascular disease, one of the metrics used by cardiologists, and Yuchi Han, our cardiologist, is a myocardial perfusion reserve. So this is the ability of the patients to dilate the microvasculature, to increase blood in response to physiologic stress. So the maximum blood flow under stress conditions. Typical is 3 to 5, and what you clearly see in the TTP patients compared to the controls is a reduction in the global myocardial perfusion reserve, but also endocardial and epicardial compared to controlled patients, which was very intriguing. So not thrombotic in origin, but a functional problem that they're developing. Again, the question of ADAM-TS13 activity and its relationship is important, but I would mention that the one patient who had a normal cardiac stress MR was this patient where you see her ADAM-TS13 activity here. She had 2 episodes of TTP that were related to pregnancy and hormones, but since moved to Columbus, Ohio, more than 20 years ago and began following with us. And we did not treat her initially with rituximab. So what you can see here is her ADAM-TS13 activity over nearly 15 to 16 years of follow-up. These improvements are spontaneous and recur back to normal. Only here at the end, near 175 months, did she get a course of rituximab. So despite nearly 15 years of undetectable activity, she's the one that had the cleanest cardiac MR of anyone, raising the question that there may be more than just the ADAM-TS13 activity involved. So with that, I'll stop and answer any questions that you have, and thank you for your attention.
Okay, bye. Bye. Thank you, Dr. Catalan, for this remarkable and outstanding presentation of the recent updates in the TTP field. So there's a room for a few questions. I think Professor Abadi will start the first question.
Thank you for your excellent presentation.
Thank you.
I have some comments and questions. We frequently observe patients with TTP in whom the severity of the disease and or the response to treatment does not always correlate with the functional level of ADAM-TS13. Second point, I wonder whether ADAM-TS13 is the whole story of TTP, or there are additional factors which we have not yet investigated thoroughly, especially in light of the mouse model.
Absolutely. Excellent question. Excellent point. You're referring to Dave Motto and his mouse model, where the mice did not spontaneously, so genetically bred mice to not have ADAM-TS13 did not develop a TTP phenotype unless they were provoked with Shiga toxin or VWF. And I think that's an exact model that compares to congenital TTP, where women may not get diagnosed until they're pregnant. I think the ADAM-TS13 activity is very helpful, but as you stated, we have to remember that this is an in vitro approximation of a physiologic function. We looked several years ago at the correlation and published the correlation between the activity and the presence of or absence of these ultra-large multimers. And in about 20%, there was discordance, meaning you had positive or measurable in vitro activity, but yet you still had large multimers, and the opposite occurred as well, where you did not have any measurable activity, but you did not see these multimers. So you're exactly right. There's a disjoint, and the activity is an in vitro test. We're doing the best we can, but there are other factors that may modify this. I think the best test is ultra-large VW multimer stats, but that's a very difficult test to do, certainly in the lab, let alone clinically. The important point, so I think you're exactly right.
Dr. Firas, you can carry on with your question.
Yes, thank you. My question is, what do you say to a lady who wants to conceive after recovering from a TTP episode, when it is safe for her to try, and when she gets pregnant, do you follow her up any way closer than the usual? Thank you.
Yeah, that's another excellent question. So I think as a physician, our job is to allow people to live their lives the way they want to do it. And historically, many patients were told you cannot get pregnant. I think it's very clear now from the accumulating evidence that if you are pregnant, And if you have undetectable activity, you are going to relapse. And this is really what we just talked about, the previous question about the second hit. So there's no question that you need to have measurable activity. So we will measure patients leading up to pregnancy and then during every 2 to 3 months, measuring it more frequently if there seems to be a trend toward dropping. Ideally, we tell patients we'd like to treat you preemptively before you get pregnant. That never seems to happen. And we'll monitor patients and use both cyclosporin, which has been used in the organ transplant literature safely in patients. And that seems to be effective. We'll also use rituximab when needed in pregnancy. There's some debate of how safe rituximab is in pregnancy, but there really is no debate that undetectable ADAM-TS13 activity in a pregnant woman is really a relapse waiting to happen. And I've not seen anybody get through pregnancy without a relapse in that situation. So it can be done. It just needs to be managed with an expert hematologist involved with the OB team. Excellent question.
So there's one more question from one of the audience who are attending virtually regarding the ultimate and the optimal testing that you can use to monitor the disease activity. I know that you have stressed and highlighted that topic, but if you can just recap on that issue.
Sure. So our patients are followed, most of them every 3 months. Some who live further away will come every 6 months. But we will monitor the ADAM-TS13 activity as a marker of increased risk for relapse. And I emphasize to our patients, just because you're undetectable, as you saw from my patient, does not mean relapse is absolute. If you're pregnancy, that's a different story. So when we see this, we discuss with our patients the risk of rituximab therapy versus the risk of relapse and determine if preemptive therapy is indicated. We're much more comfortable doing that in a patient who's already demonstrated a relapsing phenotype. When they've not done that, it's a greater discussion. As patients don't want to go back to the hospital for plasma exchange, many of them opt for preemptive therapy. As the world starts to change and we treat people without plasma exchange and with a subcutaneous injection or an infusion of recombinant ADAM-TS13, maybe that changes if you can treat this as an outpatient. But today we use the activity to guide the use or not use of preemptive therapy to prevent relapse. It is effective, but we are probably treating more patients than needed, no question.
So one last question from the Dr. Abu Salim. She's asking a hypothetical question about your opinion regarding the caplacizumab, if it may impact the unexplained or the unexplained long-term side effects and complications of TTP, which we are seeing nowadays. So do you personally think that the caplacizumab would impact the long-term complications of TTP if it's used regularly?
Yeah, I'd like to think that, but we do know that there's really nothing correlated with these complications, number, severity of TTP episodes. So I don't think it's likely to occur. Most of these complications I described, you'll start to see them 6 months, 12 months, even years after their initial TTP episode. And quite honestly, one of my worst patients in terms of mood disorders, chronic kidney disease, as well as hypertension and a terrible looking cardiac MR in our study, actually only had one episode 18 years ago. So I'd like to think that you block the disease sooner, but that implies this disease, the long-term complications are from initial microthrombotic disease, and I'm not sure that's the case. If we take it a step further and restoring protease function, many want to think that occurs as well. But I would also tell you all these cardiac MRs that were abnormal, and I would tell you 80% of them were in our study. It should be published very soon. These were all patients on preemptive rituximab with measurable activity. So I'd like to think they're going to help. I'm not optimistic they will. We've got to find out why they're happening and block them for other reasons.
Well, thank you very much. I believe your lecture is getting a lot of attention, and therefore we're having more questions if we have time for that. So please, Dr. Bawani.
Lost you for a second there. Can't hear.
We may use the other mic.
Yeah, thank you for this comprehensive talk. I have a few questions, please. The first one is a clinical observation that we observe that in people with TTP, after initial response and improvement of lab-wise, clinical-wise, they have like a deterioration in the second week or so. This again occur in almost half of the patients. The other question, did you prefer a supernatant plasma exchange with a supernatant or with plasma, simple plasma exchange? The third question, if you allowed me, regarding the congenital TTP. I have a patient with have difficulty get pregnant, and when she did, unfortunately, she lost. She has abortion. How it's a better way to manage this situation? Thank you.
Yeah, no, those are very good questions. And I'm old enough. My colleagues tell me that I've been around a while, but I wasn't around long enough for the debates on cryopore versus plasma. I think there was a lot of debates back and forth. I think at the end of the day, it was, and even to this day, we don't know really, is it the removal of an antibody that's important or the infusion of a protease? I think what we're seeing though is better treatments from better science, and caplacizumab and recombinant datum TS15 are overwhelming any effect from the infused plasma. So I think those are a non-issue anymore, especially as we're going to get away from the use of plasma exchange. What was the first question? I apologize. What's the first one?
The clinical relapse.
Clinical. You know,
yeah.
That's an interesting question. We used to talk about flares, and my colleague Bernhard Lemley will talk about that. I've seen this before, where on plasma exchange, a response to therapy is lost, and there's really nothing you can do. We add Cytoxan, rituximab at the time, and it was a real bad situation. We've seen this a lot as we stop plasma exchange when they achieve remission, and you hold it. It's thought that it's a rebound phenomenon of the antibodies. They were really a problem. Where we've just not seen that since we've had caplacizumab, really blocking the microthrombotic disease. And we've just not seen, we don't see exacerbations, and we don't see those flares anymore. But they are certainly very real, and they're very frightening. Because a patient on plasma exchange therapy, watching the LDH go up and the platelet count go down is a very ominous thing. We all know what direction that's going. The third question regarding your patient with congenital TTP, she needs some sort of help and support. She will relapse during pregnancy without measurable ADAM TS13 activity. If you look at the phase 3 study that led to the approval of recombinant ADAM TS13, you achieved over 10% ADAM TS activity for a median of 1.7 days in the plasma arm, but about 5 days in the recombinant arm. So it is more expensive, but it is easier, and you can get them at least above that 10% threshold that should prevent a relapse. The different story is how high you need to prevent these same long-term complications that you see in congenital patients as well. But recombinant is going to be better, or an aggressive plasma program every 7 days if you can do it. If they will tolerate it, we'll do it.
So one last question from Dr. Beda.
Thank you, sir. My question about, we have a lot of patients with recurrent TTP, and do you advise in such cases for a prolonged use of rituximab?
That's an interesting question. I asked my colleague Paul Calpo this, because their approach, as well as Murray Scully, and I've not done this work, we use rituximab. But when they don't respond after 4 to 6 weeks, they will give them an additional course of therapy. And I've always asked Paul, is this because you're giving an additional dose, or you're just giving them more time to recover? And I don't think I know what the answer is. The ones that don't respond to rituximab, we've had a few occasions to use, and I saw this mentioned in the previous talk, obinutuzumab, in patients who were a Black patient refractory to rituximab, now responding to obinutuzumab. So I think there are a subset that don't respond. After 6 weeks, I have less hope they're going to recover, and I really don't repeat the rituximab. We start looking to cyclosporin, which we've studied, as well as now obinutuzumab. And splenectomy is actually a reasonable, as in ITP and other antibody-mediated disease. It's a reasonable approach, not treating acute disease, but preventing relapse. And if you look at the data, there's a Capers-Clooney article. It doesn't look a whole lot different than a one course of rituximab with a small percent that relapse.
I just have a comment on the congenital TTP and pregnancy, since ADAMTS13 is not available in this region, we published years ago a report of two sisters who developed TTP during pregnancy, and they maintained pregnancy with infusion of weekly fresh frozen plasma. Since then, I've been using this anecdotally, no, not a trial, but I have seen it in several patients who can maintain pregnancy and deliver with weekly infusion of fresh frozen plasma.
Yeah, no, it can be done. It just takes a greater commitment on especially the patient part to do every 7-day plasma infusions. I think we have to understand there's variable levels of ADAMTS13 in each plasma unit that we give patients, but it certainly can be done. It's hard to do though. Our congenital patients, prior to switching them, my patients that were recombinant, it was a negotiation. You need to have more frequent than every 10, 14-day infusions, but they didn't want to do it because it takes a while. But it certainly can be done. And it's something I would do without having recombinant. I would use a more aggressive program as you've done. And you've shown that it's worked. So it's nice work there.
Well, thank you again, Dr. Catalan, for your remarkable and outstanding presentation.
Thank you for the invitation. I really
It seems
enjoyed it.
like it was one of the most popular talks, and you've got and handled several questions. So thank you again, and for more to come, hopefully.
Thank you all very much.
غدير ما سوت لنا بريك. عشان اوكي
Now we will move to the next session, Roche Symposium, with our next speaker, Dr. Rafat Suleiman, Professor of Hematology and Stem Cell Transplant, National Cancer Institution, Cairo University. He has more than 31-year-old experience in bone marrow transplantation, about 67 publications in stem cell and hematological malignancy. Please, Dr. Suleiman, he will give us an update about the management of relapse and refractory diffuse large B-cell lymphoma. Dr. Suleiman, please, the mic is yours.
Okay, thank you very much. I want to thank you, Roche. Thank you, the Jordanian Hematology Group, for giving the opportunity to be with you today. I will share my opinion. I try to share.
Yeah. دكتور بس السلايدات اذا جاهزات خليهم شغالات وبعدين شير ان شاء الله.
هي already هي شغالة معايا السلايدز بس I want to share it. I don't know why I cannot share.
كبست تحت الكبسة الأخيرة تحت صح دكتور؟
اللي هو الشير.
ايوه الشير ايوه بيطلع لك بلوك هيك في واحد من هذا الباوربوينت او برزنتيشن بتختارها ربينا تختارها بعدين بتعمل شير.
هو للأسف هي مش بتظهر في
في البلوك
الشير entire screen.
المفروض في باوربوينت مايكروسوفت باوربوينت تختارها. ايوه طلعت. شوف انت بس عملت انتر سكرين مش مشكله، تروح على على البرزنتيشن بكون ممتاز. سويتش من تحت عليه من اسفل الشاشه. ايوه تمام. اضغطها بزبط. لا
على ستوب شيرنج.
لا سويتش تحت على اسفل الشاشه في الباوربوينت اللي هي الاورنج. اختارها
دي.
ايوه اختارها بتحول. ايوه تمام. بس كبر الشاشه
تمام
دكتور ونقول بسم الله.
كده
تفضل.
كده تمام.
تمام.
لا بس لسه بده يسكر هذا.
تمام.
تمام دكتور.
تمام تفضل.
Okay, thank you. And this is my disclaimer. I will starting to speak about diffuse large B-cell lymphoma. The name of diffuse large B-cell covers a group of B-cell lymphoma that shares two morphological elements. Large cancerous lymphocyte, it is usually more than 2 times larger than a small mature lymphocyte in low-grade lymphoma. What is about the diffuse? Diffuse growth pattern in which the cells are spread evenly throughout the biopsy specimen rather than being founded in clusters. Usually, is the most common types is 80% is about primary diffuse large B-cell lymphoma arising de novo, but some of them are developing from secondary non-Hodgkin indolent lymphoma. This is called secondary diffuse large B-cell lymphoma, like follicular lymphoma or small lymphocytic lymphoma. The diffuse large B-cell lymphoma is about 30% of all non-Hodgkin lymphoma. It is frequently diagnosed from the age of 65 to 74 years old, but in Egypt, usually starting from the 55 years old. We're having unmet medical needs because usually when using the standard of care, what's the R-SHOP, the curability rate or the overall survival of the patient is around 60%. This means that 4 out of 10 patients with relapse or having a refractory disease. As you see from the left side of the slide, the progression-free survival for the R-SHOP versus SHOP, it is highly significant. It's about the difference about 25%. But what is the relapse rate risk looks like over time? You see, this is the Swedish registry trial about more than 2,900 patients. R-SHOP about 91%, completed 6 cycle about 90%. The relapse rate on the first line is about 18%. It is a 500 patient. Within first 2 years, the most common relapse usually happens the first 2 years, about 7 to 2 years. After 5 years, only 1%. So the follow-up now for diffuse large B-cell lymphoma, only 2 years is enough to follow up your patient. But what is the risk factor for relapsing after first line? Usually, the male patient has a high risk for relapse, and the staging 3 and 4 has a high incidence of relapse rate, and also the performance status 2 or more, and also higher LDH above normals, more than 1 extranodal sites, and also the IPI risk scoring 4 to 5 having a fit. Also, the remissions for more than 2 years, also the sex, staging, performance status, LDH, extranodal size, and the IPI scoring system. The progression-free survival and overall survival outcome is stratified by age-adjusted IPI as a starting 2 years treatment. You see that the patient with the low-risk patient having a very good progression-free survival and overall survival, and the low progression-free survival and overall survival for the patient with the high-risk patient. So, what about the patient of primary refractory? The primary refractory patient having an event-free survival not more than 20%. And also of the patient of refractory second line and the patient which relapsed post less than 12 months, especially the patient relapsed post autologous stem cell transplantation. Autologous stem cell transplantation is a standard of care for patient who is having a remission rate for more than 1 year, but We can transplant your patient in a complete remission. You can transplant your patient in a partial remission. But there is a difference. If you transplant patient in a complete remission, you're having about 50% of the patient having a progression-free survival. But if you transplant the patient in a partial remission, you're having only a 20 to 25% event-free survival. So the early relapse associates with poor survival in a diffuse large B-cell lymphoma. This is a Gaia trial. Overall survival for refractory versus non-refractory patient, you see that non-refractory patient in a Gaia trial having an overall survival about 91%, and the primary refractory having only overall survival for about 35%. Also, the progressions on the first year, the progression is very high for patient with the refractory disease, then and relapsed patient in the first 1 year, then the patient in CR. Still until now, the high-dose chemotherapy followed by autologous stem cell transplant, the current standard of care for late chemosensitive relapses, especially patients with having a remission rate more than 12 months. But only about half of the patients with relapsed diffuse large B-cell lymphoma are eligible for transplantation. This is due to older age or comorbidity which prevent autologous stem cell transplant. Moreover, patients with relapsed diffuse large B-cell lymphoma are also ineligible for transplant if they are insufficiently chemosensitive. Also having a problem if the patient is having more than one relapse, usually cannot collect or has a difficult to collect stem cell transplant more than 2 million CD34 positive for per kg. So only 50% of relapsed refractory diffuse large B-cell lymphoma are eligible for transplantation, and curability for transplant is only 50%. So about 50% transplant eligible, 25% responding to autologous stem cell transplant, so 10% will be cured. At the even, about 60% of your patient will be cured, and about 40% of your patient will need for another line of treatment. So according to the data until 2020, when you're having a relapsed patient, you should go for biopsy. Why? Because both anatomic and functional imaging studies have a limitation and may have false positive results. Some patients who present with diffuse large B-cell lymphoma are found to have a follicular lymphoma at the time of relapse, but usually follicular lymphoma, Hodgkin lymphoma can be transformed to diffuse large B-cell lymphoma, but a little hint of patient can having from diffuse large B-cell lymphoma discovered that he having a follicular lymphoma, which having a different treatment, because usually in a follicular lymphoma, you can treatment as a chronic disease. You can using BTK inhibitors for life, but in a diffuse large B-cell lymphoma, you targeted to cure your patient. If your patient is eligible for transplant, usually what is the high-dose therapy do you use? In my center, usually we're using ICE or ESHAP, but because DHAP usually having a higher ototoxicity in our centers with using cisplatin. So if I'm using the DHAP, I substitute cisplatin with the oxaliplatin. This is for transplant candidate patient. Transplant candidate or non-candidate can using GDP, GDC, or GMOX, which is most common protocol used now, the GMOX. And also for patient for non-candidate for transplant, you can using etoposide with CVP, or etoposide or dose adjusted EPOR, or bendamustine single agent, or lenalidomide with rituximab. This is a transplant eligible patient, as I said before, the most common using in worldwide until now, and especially in Egypt, we don't have bispecific therapy or having CAR-T. We're using still until now for transplant eligible, even the patient relapsed within the first year, we're still using the autologous stem cell transplant. The high-dose chemotherapy autologous stem cell transplant in a diffuse large B-cell lymphoma having a very good result, increasing more than 50% when adding rituximab for the treatment. This is the CORAL study. The algorithm for management of first relapse of diffuse large B-cell lymphoma in a first relapse patient less than 12 months since last treatment or primary refractory the CAR T therapy. If the patient is relapsed more than 1 year and not primary refractory, you can using salvage chemotherapy followed by autologous stem cell transplant. Patient responding to salvage therapy, okay, go for transplant. The patient receiving salvage therapy like ICE or ESHAP, but not responding, again, you can go for CAR T cell. So, who the patient is eligible for CAR T therapy? The fit patient who would otherwise be eligible for autologous stem cell transplant. And the primary refractory disease remission lasting less than 12 months after first line therapy. This is the three lines of CAR T therapy which are available now and having FDA approved and EMA approved, the axis cell and T cell and T cells, and I will go very rapidly in this era because until now in Egypt we cannot use it usually. The difference between, or the characteristic between the axis cell, T cell, and T cell, see that. The axis cell, this is the CD28 retrovirus, but the T cell and T cell, this is the lentivirus, and the cell T cell manufacture. And the axis cell and T cell, it is using the bulk T cells, but in the Liso cells, usually CD4, CD8, 1-to-1 ratio. And also the absolute lymphocytic count in apheresis and the axis cells is more than 100 cells per microliters, more than 300 microliters in the T cells, but there no minimum in the Liso cell. And also the lymphodepletion. The lymphodepletion used usually using fludarabine with cyclophosphamide. An axis cell trial using fludarabine 500 milligram with the cyclophosphamide 300 milligram for 3 days. In the T cell trial, the fludarabine only 250 milligram and cyclophosphamide 25 milligram per meter square for 3 days, but adding bendamustine 90 milligram per meter square for 2 days. In the Liso cell trial, the fludarabine is 300 milligram with for 1 day, and cyclophosphamide 330 milligram per meter square for 3 days. This is the trial for the second-line treatment of the axis cell versus a standard of care, what is high-dose therapy, DHAP, or ICE, or any other, according to the standard of care in the center. You see from this trial, the result of axis cells overall response rate is about 83%, and the CR rate is about 65%, versus overall response for the standard of care is only 50%, and the CR rate is about 32%. And also for the second line for the Liso cells, the overall response rate is 86% versus 48% for standard of care, and the CR rate is about 66% versus 39% for standard of care. The last one is the T cell, which is an equal data. There is no difference between the T cell and the standard of care in the overall response rate and also in the CR rate. Well, the most common side effect for the CAR T cells usually the neurotoxicity and the CRS. What about the transplant ineligible patient? This is usually patient with transplant ineligible usually having a problem to using also the CAR T therapy. So second line transplant ineligible, yes, CAR T cell can be used, yes, some of them can be acting in a low performance status, but usually needing a good performance status to use it. But still, if in guidelines, yes, you can using the CAR T cells, but the most common to using it in the ineligible transplant patient is the bolotuzumab vedotin plus bendamustine and rituximab. And in a chemosensitive immunotherapy, you can using rituximab with gemcitabine and oxaliplatin, which is the GMOX. So Consider difference in CAR T cell therapy procedures and outcome in real world versus clinical trial. Yes, there is a big difference when using the CAR T cells and the data in clinical trial with the data of the real world when be published, especially from the Chinese trial. This is the case of 75 years old, starting with Bula R-ship because the age, and starting the first line to continue the 6th cycle and the 2 doses of cyclophosphamide. This is a stage 4 diffuse large B-cell lymphoma, achieving complete remission, but hopefully it is relapsed after 6 months later. It is having a bulky stage 4 disease at relapse with a high serum LDH level and DB symptoms. This means this is a high risk patient. He having a comorbidity of chronic renal impairment. GFR is 45 milliliter per minute. What is the treatment option for this patient? CAR T cells, platinum-based chemoimmunotherapy, followed by autologous stem cell transplant if chemosensitive, or lenalidomide with tava, or bendamustine, rituximab. As I said before, the first line is the Bula-ship with rituximab, or clinical trial with bispecific therapy. What is the Bula-tuzumab vedotin mechanism of action? This is a microtubule inhibitor can disrupt the microtubules and also let this bind to the CD79B and then leads to internalization of the cells, with the microtubular disruption leads to what apoptosis of the cells. So this be in the 2019, the FDA granted accelerated approval for the polatuzumab vedotin in a combination with bendamustine and rituximab for adult patients with relapsed refractory diffuse large B-cell lymphoma received 2 or more prior therapy. And now the current NCCN guidelines in 2025 has listed polatuzumab as a preferred second-line therapy for relapsed refractory diffuse large B-cell lymphoma. This is the action again for the Bula action. Anti-CD79B targeted the B-cell malignancy, and also the monomethyl orostatin leads to the microtubular disruptions and also go to the valine citrulline linker cleavage by the lysosomal proteases. When the cleaved by the lysosomal proteases with the microtubule disruptions, as I said before, leads to the apoptosis of the malignant clone of the diffuse large B-cell lymphoma. So this is the first randomized trial with overall survival benefits of the relapsed refractory diffuse large B-cell lymphoma. 40% of the patient achieved CR, and increased the median overall survival with a 58% reduction of the deaths and 56% of the patient reduction according to the progression-free survival. And this is a fixed duration of treatment, only 6 cycles of Polivy and 2 cycles more for the rituximab single agent. The safety profile are demonstrated good tolerability, so there is approved now by the EMA and the FDA. This is the trials of the polatuzumab plus bendamustine and rituximab as second-line treatment for the diffuse large B-cell lymphoma relapsed ineligible for a stem cell transplantation. According to the long-term efficacy, you see that the patient overall response rate is about 63% for Bula bendamustine rituximab, 53% CR rate, duration of response about 10.9 months, and the median progression-free survival is triple. It is 9.2 versus 3.7. The median overall survival is about 12.4 months versus 4.7 months for bendamustine rituximab alone. So the Polivy plus bendamustine rituximab provides CR rate in nearly half of the patient versus 17.5% for the bendamustine rituximab without Polivy. And also, a twofold increases in the overall survival with the Pola-Penta R versus Penta R was observed with decreased in the risk of deaths by about 58%. And also there is increase in the progression-free survival, tripled, as reduction in the risk of progression by about 65%. So Polivy with bendamustine rituximab delivered overall survival beyond 1 year. It is about 12 months, 0.4 months. This is more than 1 year, and only 3.7 months for bendamustine and rituximab. And from the data from the ASH 2019, with additional years of follow-up, progression-free survival and overall survival remained significantly better in a Pola arm versus bendamustine rituximab in a diffuse large C lymphoma in a progression-free survival and also in overall survival. So, Vitutin plus bendamustine rituximab more than doubled the median duration of response. It says 10.3 months versus 4.1 months. And what about the safety profile? The safety profile is the polatuzumab vedotin usually having an issue about the pancytopenia and the other issue about the neurotoxicity, especially the peripheral neuropathy. But it is not usually needed to stop treatment. So the most treatment patient in the study, there is no stop for the treatment toxicity. Even in grade 3 and 4, you can stop treatment or you can decreasing the dose from 1.8 milligram per kg to 1.2 milligram per kg and to continue treatment. So this is the Polivy dosing. It is 1.8 milligram per kg, bendamustine 90 milligram per meter square for 2 days. Rituximab, the standard dose, 375 milligram per meter square IV, and you can using also the subcutaneous rituximab. This is the dose modifications according to the new toxicity, and I said before, the most common is neutropenia, thrombocytopenia, and the other is the neurotoxicity. But what about the infusion-related reaction? Usually is not reaching the grade 0 and 4. Usually it is a grade 1 and 2. Don't need to stop treatment. So the summary for the Pola arm. It is used in a relapsed refractory diffuse large B-cell lymphoma. It is doubled overall survival and tripled the progression-free survival versus bendamustine rituximab alone, and also provided a best TCR in nearly half of the patient. And also the safety profile indicated Pola was tolerable. The adverse effects were manageable. And also, there is, I said before, the FDA approval and EMA approval, and this is a breakthrough therapy for approval in United States. The third part is about the bispecific antibodies. The bispecific antibodies are now approved 3 drugs, the Ibuco and the Glo and the Andro. This is 3 drugs available. The 3 drugs having a difference between them. I will go also very rapid to speak about the bispecific. This is different from the CAR T cells because this is on shelf. This is available on shelf. You can using your patient for 1 cycle, 2 cycles, 3 cycles, continue until disease progression. It is not CAR T cells. It is not used once. The first trial treatment is the Epoco. This is a subcutaneous administration, CD3, CD20 bispecific antibody. It is 1-to-1 treatment. This is inducing T cell activation by binding the 2 CD3 on the T cells and CD20 on a malignant B cells. This promotes immunological synapse between binding, resulting in apoptosis of the B cell. So, binding to distinct epitope of the CD20, as you see from the left side, different from the epitope of rituximab or obinutuzumab. So, you can using with it the presence of the CD20 monoclonal antibodies. The result of the EPICORE trial for this, the CR rate is about 39%. Median duration of response is 15.5 weeks Overall response rate is 63%. The subgroup CR rate post-CAR T-cell is about 34%. Refractory disease 30%. The progression-free survival median is about 4.4 months, and the estimated overall survival is 15 months. This is the EPICORE trial. All the monoclonal antibodies and the CAR T therapy have a unique side effects, especially the CRS and also the ICANS, that neurotoxicity for both. And this needs usually in CRS using the tocilizumab and the ICANS syndrome. In ICANS syndrome, you should stop treatment and manage the neurotoxicity for your patient before the next cycle. The second one, which is available now in Egypt and available in Saudi Arabia, I don't know its availability on Jordan or not, the glofitamab. This is a bispecific antibody targeting CD3 and CD20, but you know that it is a 2-to-1 ratio, not like the others 1-to-1. This is 2-to-1. What is the advantage of 2-to-1 designation? Associated with superior potency under preclinical experimental condition compared with the 3 specific monoclonal bispecific therapy, 1-to-1 binding bispecific constructs, the 2 of which use the same domains in the different configuration. This allows concomitant treatment with the anti-CD20 antibody for your patient. This is the phase 2 expansions of the GLOW after 2 prior lines of therapy in diffuse large B-cell lymphoma, the primary endpoint CR rate, and the key second endpoint overall response rate, duration of response, CR rate, progression-free survival, and overall survival. As you see from the subtyping of the group, diffuse large B-cell lymphoma, primary one 74%, transformed from follicular lymphoma 17.5%, and high-grade B-cell lymphoma 70.1%, primary mediastinal B-cell lymphoma 3.9%. Previous CAR T-cell is about 33%, previous autologous stem cell transplant 18.2%. 3 or more lines of treatment is about 59.7%. What about the river? The overall response rate is about 51.6%. CR rate is about 39.4%. The median duration of response per month is 18.4 months. Duration of CR 26.9 months. The progression-free survival and overall survival for the majority of the patient at the end of treatment, there is extended follow-up. This is published in the ASH 2024. You see that the progression-free survival of the patient per month is not reached. 24 months progression-free survival rate is about 57.3 months. And the overall survival at the end of treatment not reached in the overall survival, and the 24 months overall survival rate is 77.2 months. The third one is odronextamab. The odronextamab is a bispecific therapy, CD20 by CD3, and as I said before, it is 1-to-1, not 2-to-1. This is a trial, LM2 trial for the bispecific, the third one, but go to the result. The duration of CR is about 50%. Progression-free survival for the CR patient is about 33%. When comparing the two, the 3 drugs, the EPICO with the GLOW and the ANDRO, as you see, the overall response is equal, but the CR rate is equal. But if you see the duration of and the progression-free survival only also higher for glofitamab, but the toxicity is equal for both, but more or less is higher in more than 3 in the GLOW. At the end of my talk today, I speak about allogenic transplant. Why I speak about allogenic transplant? As I said before, in Egypt, we're having availability of bispecific therapy is very limited. CAR-T until now not available, will be available in the next 6 months. So if my patient with autologous stem cell transplant relapses after this, or my patient cannot collecting CD34 to 2 million per kg to be transplanted for autologous stem cell transplant, I will go for allogenic stem cell transplant, even I have a good donor, a good sibling fully matched. But the limitation of allogenic stem cell transplant is the high transplant-related mortality is about 33% for myeloablative patient. So usually using the REC transplant followed by donor lymphocyte infusion. The benefits and indication: patient with chemo-refractory relapsed diffuse large B-cell lymphoma, long-term disease-free survival, young patient who relapsed after autologous cell transplant, failure of Is there any problem? Failure to mobilization, bone marrow involvement at the end of chemotherapy. My experience on polatuzumab, I use the R-SHIP in 8 cases. Usually I use it in a female patient with
Dr. Suleiman, we have 2 minutes to go.
Okay, sir. Okay. The 8 cases usually primary mediastinal diffuse large B-cell lymphoma to omit radiotherapy, having a very good response in a first line, and also having a very good response to my patient. I used it as a bridge for transplant in the 2 patients. I end my talk by the diffuse large B-cell lymphoma guidelines. This is the last guidelines from the 2025. As you see, the polatuzumab vedotin as in a patient of primary refractory or the second line treatment now is considered a preferred regimen for using in a patient who not candidate for CAR T cell. So take to come home measures. Options for second line transplant in eligible patient now including Bola plus bendamustine, and using if you're not having availability for CAR T cell or bispecific therapy. This is my last slide, and thank you for your attention.
Thank you very much for this nice lecture, Doctor, for the comprehensive talk. Cover all aspects of relapse, refractory, diffuse large B-cell lymphoma. I think we have just time for one question. Okay, Doctor, just one question. Do you think there's availability in the future to combine bispecific with chemotherapy for the treatment of diffuse large B-cell lymphoma?
Yes, this is a very good question. Yes, having a trial, especially adding the treatment with the bispecific therapy and gemcitabine and oxaliplatin. Yes, we having a very good result when combining this result, and in the data until now having that the CR rate and the progression-free survival is higher for patient receiving bispecific with gemoxin, but it's not approved until now.
Okay, thank you very much, Doctor. I think there's a lot of questions in our mind, but because of the sake of the time, we don't have enough time, and we are already late for the next speaker. Thank you very much. Thank you, Doctor.
Thank you for me. Thank you.
السلام عليكم. الآن احنا مع السيشن الثامن Bleeding Disorder Symposium of the Novo Nordisk. Thank you to Novo Nordisk. معنا دكتور جيري تايتل، وعنوان اللي راح يكون السيشن congenital hemophilia with inhibitor and the role of the recombinant factor 8, recombinant factor 7 in the treatment of the bleeding. Dr. Jerry Title is a professor of the medicine at the University of Toronto and the staff physician part-time in the division of the hematology and oncology at St. Michel Hospital, a fully affiliation university teaching hospital. At that hospital, he is medical director of the Hemophilia Treatment Center, the largest such a program in Canada. Dr. Title obtained in his MD degree and residency training at the University of Toronto. He then did a 3 years research fellowship at Harvard University under the supervision of the Dr. Robert Risenberg, where he worked in the novel assays for the detection of the coagulation activation. After return to the University of Toronto, he studied the immune accessory activity of the vascular endothelial cells, and then focused on clinical research in the field of the hemophilia and related bleeding disorder. Dr. Title is past president of the Canadian Hematology Society, the Association of the Hemophilia Clinic Director of the Canada, and the Hemophilia Research Society of North America. He remained active in the Association of the Hemophilia Clinic Directors of the Canada as member of several of its committees, Novel Therapeutics Inhibitor and Bleeding Disorder Registry. Welcome, Dr. Title. We thought that his speak today, congenital hemophilia with inhibitor and the role of the recombinant factor 7 treatment of the bleeding. Dr. Title, the floor for you.
Thank you, Mr. Chairman, and thank you to Novo Nordisk for sponsoring this symposium. And I'm going to share my screen. Let me just get set up. All right. I hope you can see my screen. And I'm going to talk, as you said, about, sorry. There we are.
Your screen is not shared. Could you please repeat the process again?
Okay.
Stop the sharing and start the sharing again.
All right, let me try again.
Actually, just
موجود.
Sorry. If we can't.
Yes.
We can now. You can see it now. Okay, good. Sorry for that delay. All right, so let's get started on congenital hemophilia inhibitors.
It's from our doctor.
Oh, it's from yours.
Yes. Yeah. Okay.
Well, then let me. Okay, so I think I can see it. So you're on the opening slide. Yes. Good. So can I have the next slide, please?
Next.
You'll have to change for me. Okay. So these are my disclosures, and I will be referring to some products that are not approved for use in Jordan. And the next, please. Next slide. Thank you. So we're going to talk first about the characteristics of inhibitors. Hang on. Yeah, I'll let you know when to change the slide. So we're going to talk first about the characteristics of factor 8 inhibitors, which is the subject. No, go back, please. Wait till I ask you to change. So anti-factor 8 inhibitors, first of all, we should define them. So it's a poor term, inhibitors, so it's a loose term, but what we're referring to in this talk is alloantibodies, that is, antibodies directed against a foreign protein. In this case, it's exogenous factor VIII used for treatment of congenital hemophilia A patients. Now, the term is also used for factor VIII autoantibodies in patients who don't have congenital hemophilia, and that's the syndrome of acquired hemophilia. We're not going to talk about that at all today. I will say a little bit about anti-factor IX alloantibodies, which have characteristics generally similar to those of the anti-factor VIII antibodies. And just as a note to point out that there are some anti-factor VIII antibodies which aren't inhibitors, but they do accelerate the clearance of factor VIII. So they are clinically relevant, but that's not the subject of the talk today. So the next slide, please, just shows shows the life cycle of factor VIII, just to give you some orientation. Most factor VIII is produced in endothelial cells, specifically sinusoidal endothelial cells in the liver. There are other sites of production, but that's the major source of production. Factor VIII is secreted from these cells as a dimeric protein, a heterodimer, two-chain molecule, which circulates with circulates bound to a molecule, a carrier protein, which is von Willebrand factor. Von Willebrand factor carries it to the site where it's required, namely the site of bleeding, where it is released from von Willebrand factor and activated by thrombin. And activated factor VIII, which is a three-chain molecule, then functions in its role to support coagulation, and specifically it is a non-enzymatic cofactor in the activation of factor X by factor IXA. So IXA is the enzyme, factor X is the substrate, and factor VIII, or the activated form of factor VIII, is a non-enzymatic cofactor. After having done that, then has to be removed. And there are several ways that factor VIII is metabolized. First of all, the activated form of the molecule is inherently unstable. And one of the chains, the A2 chain, tends to dissociate spontaneously. It's also proteolyzed, limited proteolysis by activated protein C, APC, and then it's cleared by binding to various receptors on many different cell types. So that's a little bit about the life cycle of factor VIII. Now the next slide, please. So how do factor VIII inhibitors actually inhibit? Well, they may prevent the dissociation of factor VIII from von Willebrand factor. They may prevent the activation of factor VIII by thrombin or accelerate the dissociation of activated factor VIII. So all of those mechanisms prevent the ability to generate or sustain activated factor VIII. Some inhibitors block the binding of factor VIII to von Willebrand factor or phospholipid, or block its interaction with factor IX or factor X. In other words, they may interfere with its function in the intrinsic activation of factor X, the intrinsic pathway of coagulation. And the next, please. So some of the clinical characteristics of inhibitors, and we'll talk about this, and then we'll go on to talk about factor VIIa. So the next slide, some of the demographics. So most inhibitors occur in patients who have severe hemophilia. That means by definition, less than 1% of the normal amount of factor VIII. So their presence makes bleeding difficult to treat because generally they become unable to respond to factor VIII concentrate. But since they already have severe hemophilia, their bleeding may not be worse, but it's difficult to treat. Now, the inhibitor incidence in treated severe hemophilia patients is very high, up to 35%. Inhibitors are rare in severe hemophilia B, less than 10% of patients. And they do occur, but they rarely occur in patients with mild or moderate hemophilia A, that is non-severe hemophilia A. Now, why are these rates of inhibitors, the incidence, so different in hemophilia A or B? It may relate, or we know it does relate, at least in part, to the genotypes of the molecule. And I'll show you a little bit about the genotypes of factor VIII in a coming slide. Also protein homologies. As you know, factor IX is a vitamin K dependent protein, so it's homologous to a wide range of proteins. That's not the case for factor VIII. And there may be differences in the inherent immunogenicity of the two molecules. Inhibitors tend to arise early in life, usually within the first 35 to 50 exposure days to factor VIII concentrate, which means in a severe hemophiliac, these usually occur in young children. And the next slide, please. So this is just to elaborate on what I've just said. First of all, the incidence. This just shows 4 clinical trials of different factor VIII products. And if you look at the 4th column here, total inhibitor, you can see they're all in the range of roughly 25 to 35% for an incidence. And most of those are high titer, 15 to 25% of those inhibitors are high in titer, by which we generally mean greater than about 10 Bethesda units. We're not going to talk about the assays for inhibitors today. And the next slide, please, just to show you again the timing of inhibitors. This is from a consortium, the PEDNET registry, an international registry, and this is over 1,000 patients with hemophilia, and you can see that these inhibitors occur early. So on the x-axis is exposure days. You can see that about 80% occur within the first 11 to 20 exposure days to factor VIII, and almost all of them, 98%, within the first 50 exposure days. And again, a severe hemophilia patient is generally going to get those number of exposures very early in his young life. And the next slide, please. This is just to point out the difference between incidence and prevalence. So prevalence means how many people currently have an inhibitor. And this is data from our registry in Canada, just to show that the prevalence of factor VIII inhibitors this is in over 3,000 hemophilia A patients, the prevalence was only 2.2%. So why is the prevalence so much lower than the incidence? It's because most of these inhibitors we are able to eradicate with immune tolerance induction. Some of them are also very low in titer and may appear and disappear on different occasions and don't interfere with treatment. And you can see among almost 700 hemophilia B patients, the prevalence was less than 1%. So that's the current prevalence as opposed to the incidence. And the next slide, please. So risk factors for inhibitor development, we generally divide these into variables related to the patient and variables related to the product, the factor VIII that incites the inhibitor. And the most important patient variable, and I'll show you this again a little bit later, is the genotype. In other words, the specific mutation in the F8 gene that causes hemophilia. There are also variables in the patient immune system, immune accessory cell, and other biomarkers, family history, and the nature of exposure. So for example, if the patient receives factor VIII at the time of an active infection, intensive exposure in the context, say, of surgery or trauma, or just after vaccination, there would be a higher risk of inhibitor development. And product variables may relate to the derivation, whether it's plasma-derived or recombinant factor VIII, the cell of origin, human or non-human, mammalian cell origin, purity, processing, the presence of von Willebrand factor, which can mask some of the immunogenic epitopes, and whether the molecule is altered. So the next slide shows the effect of genotype. Thank you. And you can see that some mutations in the F8 gene, large deletions, which generally means over 200 base pairs, nonsense mutations, and this unusual but common mutation, an inversion in intron 22 of the gene, these are associated with a high incidence of inhibitors, over 30%, whereas small deletions, missense mutations, and splice site mutations, a low incidence, less than 10%. Next slide, please. So what is the liability? What are the consequences of having an inhibitor? Well, as I said, it usually prevents the response to factor VIII replacement with increased overall healthcare costs, more hospitalization, difficult to do surgery, if you do happen to have non-severe hemophilia and the rare case of developing an inhibitor, your hemophilia then generally does become severe. And at least in those who have mild or moderate disease, there is increased mortality and more joint dysfunction and disability. And the next slide, please. So we're going to turn now to the main subject of discussion today, which is the role of factor 7A, recombinant activated factor 7, in the management of congenital hemophilia A patients with inhibitors. In the next slide, this is just an overview to let you know what products are available to treat bleeding in inhibitor patients. Not all of these are available or used in Jordan, but just to give you an idea of what's available around the world, we're concentrating today on recombinant factor 7A, which is usually effective, and I'll elaborate all these in the following slides. It's usually effective with a wide therapeutic margin, a low adverse event rate. It's a recombinant protein, so it has the inherent safety of recombinant molecules. It's safe to use with antifibrinolytic agents, and in fact, that's a very useful combination. We typically do use them with antifibrinolytic agents. There is, however, no validated laboratory monitoring for recombinant factor 7A, and it does have a short half-life. And just to let you know the other things which may be considered for inhibitor management, human factor 8 is there for completeness. It's rarely effective. However, if the titer of the inhibitor is very low, patients may respond at least transiently to human factor 8. Activated PCC, not used in Jordan, but this was introduced 2 decades before factor 7A, and it's still used. It is a plasma-derived molecule, so it doesn't have the recombinant safety of factor 7A, and the use of antifibrinolytic agents with it is discouraged. And this is also not used in Jordan, but his recombinant porcine factor 8 is used in other places around the world. It is authentic replacement therapy. However, it's actually not approved for use in congenital hemophilia A with inhibitors. We use it in acquired hemophilia. So the next slide now to concentrate on factor 7A. So this is the proof of concept. And this is from a very important researcher, Professor Ulla Hedner from Sweden, who in the 1980s, working with Dr. Walter Kissel in Washington, Seattle, Washington in the US, first used human plasma-derived factor 7A. They purified it from plasma and demonstrated that it was effective in treating congenital hemophilia patients with inhibitors. This is the proof of concept. And this is, you can see in 1983. In a later review of her career, Dr. Hedner wrote these lines, which I'll quote on the right-hand side of the slide. From the experience of purifying factor 7 from human plasma, it was obvious that such a procedure would never be suitable for large-scale production. However, in the early 1980s, it was demonstrated that human factor 7 could be expressed by baby hamster kidney cells. The idea to use recombinant technology to produce factor 7A was approved by Novo Nordisk on the 30th of June, 1985. So that quickly led to the production of recombinant activated factor 7A. And the next slide shows the first patient. I remember when this paper came out in the 1980s, 1988. This is the first patient treated with recombinant activated factor 7. This was a 31-year-old inhibitor patient in Stockholm, Sweden, who had knee surgery, a synovectomy and debridement, successfully treated with factor 7A. And then the next year, if you show the next slide, please, this is the next patient treated with factor 7A. This was in Chapel Hill, North Carolina in the United States. This was a 23-year-old hemophilia patient who was at risk of dying from a retropharyngeal hemorrhage. He was almost going to choke because of this hemorrhage, and he was given recombinant activated factor 7, and he survived. And since then, from that point, there was a tremendous interest and activity in factor 7A for treating hemophilia with inhibitors. And the next slide just illustrates, this is from a PubMed search I did, just looking at hemophilia and factor 7A, and you can see that from the late 80s until the early 2000s, there's a tremendous spike in interest in research interest in factor 7A, which then declined in subsequent years. And the next slide, please. So let's talk about some of the characteristics of factor 7A. First of all, how does it work? Sounds like an easy question because it's a single recombinant molecule. So it should be a simple mechanism of action, but in fact, it's not that simple. There are multiple mechanisms of action of factor 7A. First of all, there is the physiological mechanism, which is the tissue factor dependent activation of factor 10. So factor 7A is the enzyme, tissue factor is a cofactor, and factor 10 is the substrate. So that's the extrinsic activation of factor 10. But there is also a tissue factor independent mechanism in which factor 10A is generated on the surface of the platelet. That is a pharmacological mechanism. It requires very high concentrations of factor 7A, which we use therapeutically. It's not physiological. It's also been shown that factor 7A binds to a receptor on endothelial cells called the endothelial protein C receptor, the EPCR. And when it binds to that receptor, it leads to generation of procoagulant microvesicles, which are secreted in the circulation and circulate. And finally, this is a reminder that bleeding in hemophilia is not just caused by the defect in coagulation. There is actually hyperfibrinolysis, accelerated fibrinolysis in hemophilia. And that is caused by a diminution, a reduction in the activation of a molecule called TAFI, the thrombin activatable fibrinolytic inhibitor. And when you restore thrombin generation by factor 7A, you restore the activation of TAFI and turn down the hyperfibrinolysis. So all those mechanisms are relevant to the action of recombinant activated factor 7. And the next slide, please. So this is to illustrate what I've just said about the activation of factor 10 by factor 7A. This is the physiological circumstance. And factor 7A contributes in the extrinsic activation by being the enzyme that activates factor 10 on a tissue factor bearing cell. And then that's augmented by intrinsic activation that requires factor 8. Now, in a patient with hemophilia, in the next slide, a patient with hemophilia lacks factor 8, so that you don't get this augmentation of coagulation by the intrinsic pathway. But in the presence of high pharmacological concentrations of factor 7A, as we use it therapeutically, the next slide shows that high concentrations of factor 7A will directly activate factor 10 on the surface of the platelet without the need for tissue factor. So both tissue factor dependent and independent activation are mechanisms by which factor 7A functions. And the next slide, please. So a little bit about the clinical pharmacology of recombinant activated factor 7. As I said, it is derived from baby hamster kidney cells. So these are mammalian cells. The approved dosage is 90 micrograms per kilogram, which can be given as often as every 2 hours. During the course of therapy, we will often then start to increase the interval between treatments. It's also approved for use in a so-called megadose of threefold higher than the 90 dose, which is 270 micrograms per kilogram. And for mild to moderate bleeds, this leads to a faster subjective response with equal efficacy and no significant adverse effects. Now, this is an interesting phenomenon which we really don't see because it's kind of invisible. There have been some non-inhibitory antibodies against factor 7A, but since they don't inhibit the activity, the patient still responds. So even if they're there, we are really blind to them. We don't see them and we don't measure them. We don't look for them. And the next slide, please. This shows a little bit about the pharmacokinetics of factor 7A. And if you just concentrate on this column, recovery, the second last column from the right, you can see the recovery is very good in non-bleeding patients, a little bit poorer in factor 7 deficient patients. That's another indication for the product that we're not talking about today. But if you look at the half-life on the right-hand side, you can see the half-life is about 2.5 to 3 hours in the hemophilic patient, the factor 7 deficient patient, or in patients on oral anticoagulants. Now, 2.5 hours is a very short half-life for a drug. It's a long half-life for an enzyme, but for a drug, it's a short half-life, which is why we administer it in such in high frequency, up to every 2 or 3 hours for dosing. And the next slide, please. So let's talk about the efficacy and the safety. So first of all, the efficacy of recombinant factor 7A in inhibitor patients. And this is from randomized controlled trials with conventional doses in the 90 microgram per kilogram range. Efficacy within the first 12 hours is in the roughly 85 to 95% range. And this illustrates an important principle, which is early treatment is most effective treatment. This is also true for factor VIII in non-inhibitor patients. The earlier you treat, the more effective. So efficacy within 12 hours, 84 to 93%, 86 to 88% in 24 hours, and 76 to 97%, a wider range within 48 hours. And as you know, a lot of the outcomes in hemophilia are patient reported. This patient will feel a bleed in his elbow or his knee, and he can tell us and decide when he feels the bleed has resolved. We don't, in most cases, have the opportunity to do point-of-care ultrasound or other imaging studies to document an objective response. So patient-reported resolution rates in 9 hours in almost 500 spontaneous bleeding episodes in this study reported here showed a 63% response rate with conventional doses less than 120 micrograms, 60% with doses in the 120 to 250 microgram per kilogram range, and 56% with the so-called mega doses. And in a registry maintained by the Hemophilia and Thrombosis Research Society of North America, the conclusions were that recombinant factor 7A showed consistently high control of bleeding, approximately 90% across all bleeding types, all procedures, and all sites of bleeding. So the next slide. So that's efficacy. What about the safety of factor 7A? Well, the manufacturer estimated the total number of standard doses, that is based on a 90 microgram per kilogram dose, that was administered for all approved indications in the period of time between 1996 and 2013 was 4 million. So 4 million doses. How many adverse events were reported? Well, the number of thrombotic events, which is the most concern when you're giving a prothrombotic or a procoagulant agent, the number of thrombotic events reported looking at all the post-marketing sources, observational studies, registries, spontaneous literature reports was 169, which was an incidence of one thrombotic event for 2.37 times 10 to the 4 infusions, 23,000 infusions, one thrombotic event rate, a very low rate. And when they looked just at the use of congenital hemophilia with inhibitors, in other words, not acquired hemophilia, not factor 7 deficiency, but just congenital hemophilia with inhibitors, the estimated thromboembolism rate was 3.75 per 100,000 infusions. In other words, a very high margin of safety, even though we were giving a huge dose range between 90 micrograms and up to 270 micrograms per kilogram. And the next slide, please. So prophylaxis. Now, this is not an approved indication in Jordan, but prophylaxis with factor 7A would seem to be non-intuitive because it has such a short half-life. How can you give a prophylactic agent with such a short half-life and prevent bleeding? So you would predict it would be an impractical agent, but there in fact is some evidence, and this is from a randomized trial, that once daily, factor 7A has shown efficacy for prophylaxis as a single agent, either when used, as I said, in a randomized trial for patients with persistent inhibitors, or in earlier studies in patients undergoing immune tolerance induction. In other words, an agent with a half-life of 2.5 to 3 hours given once a day actually showed efficacy to prevent bleeding. So it's counterintuitive, but it has been suggested that factor 7A may in fact have a longer biologic effect than is indicated by its pharmacokinetic half-life. Perhaps it leaves the circulation and remains bound to tissue factor where it has a longer duration of action than predicted by the pharmacokinetics. And the next slide, please. What about surgery? So we often have to do surgery in patients with inhibitors, and I'm going to show you some of the experience from my center. This is a single center experience. We reviewed 17 consecutive surgical procedures in 10 inhibitor patients that we did at our center between 1998 and 2013. I won't go over this in detail, but we use the conventional regimen of 90 micrograms per kilogram initially every 2 hours, and then we slowly decrease the interval. Now, most of these studies were done with factor 7A. A smaller number were done with APCC, again, an agent that is not used in Jordan. But with factor 7A, we did use concurrent tranexamic acid. We didn't use it with APCC. And we did not give these patients DVT prophylaxis. And most of these surgeries were major surgeries. I'll show you that in a moment. But the outcomes were favorable in 82% of all surgeries and in 92% of the surgeries treated with factor 7A. And that was 14 of the 17 procedures were done with factor 7A and with a 92% success rate. And the next slide, please. This just shows, I won't go over this in detail, but it just shows the surgeries we did. And you can see we did major surgeries, ankle fusions, ankle replacements, knee replacements, hip replacements, craniotomy, tracheostomy. So we did some minor dental surgeries, but a lot of major surgeries, and we had really very good results with factor 7A. And the next slide shows some data from the literature on the safety, thank you, of factor 7A in surgery. This is from 2 randomized controlled trials. Also the HTRS, the Hemophilia and Thrombosis Research Society registry, and literature reports of almost 400 procedures in 263 patients. The overall efficacy was 84%, very similar to the results I showed you from our single center. A very low thrombotic adverse rate, event rate of 0.4%. And so that's postoperative thrombosis, extremely low, despite the fact that you're giving a potent procoagulant molecule, and only 0.025% of procedures. Now, the next slide is something that has become very important to us in recent years, and that is since the release of emicizumab, a bispecific monoclonal antibody that is now widely used for prophylaxis in hemophilia A patients. Emicizumab is incompletely protective, and so some patients have breakthrough bleeds which do need treatment. And if these patients have inhibitors and they're on emicizumab, the treatment again has to be for a breakthrough bleed, has to be with a factor VIII inhibitor bypassing agent such as factor 7A. Some of these patients will also need surgery, and emicizumab is not sufficient to provide prophylaxis for major surgeries. So what is the safety of factor 7A in patients on emicizumab? So for the treatment of breakthrough bleeds, the review of all the emicizumab clinical trials, and that program was called HAVEN. That's the Roche clinical trial program for emicizumab. The results of all these breakthrough bleeds was reviewed jointly by the two manufacturers, the manufacturer of emicizumab and the manufacturer of recombinant factor 7A. And what they found was reviewing these clinical trials. So this is during trials, this is not in post-licensure use. 61 patients used factor 7A to treat over 200 breakthrough bleeding events. And in HAVEN 1, which was an adult and adolescent trial, 62% of the patients needed treatment for only 1 day, and almost half of them needed only a single dose. In other words, factor 7A was very quickly effective in treating breakthrough bleeds. There were no new or unexpected safety concerns. There were no thromboembolic events reported. And this is on trial, so we know that all the events would have been reported. And there was no thrombotic microangiopathy. Now, why do I even mention that there was no thrombotic microangiopathy? The reason is that in the emicizumab, in the original HAVEN 1 trial, some patients were treated with high doses, really unusually high doses of APCC and incidences of thrombotic microangiopathy, a very previously never seen before adverse effect of bypassing agents was seen, and that has never been seen with factor 7A use in inhibitor patients on emicizumab. Similarly, for surgical prophylaxis, in reviewing all the HAVEN clinical trial programs, 117 procedures were performed, most of them minor, 107 minor, in 69 inhibitor patients. Most of them didn't, since these were mostly minor surgical procedures, most of them were done without bypassing agents, but a little over a fifth of them, 21%, were done with factor 7A, and none of them had any major complications, no deaths, no thrombosis, and no thrombotic microangiopathy. So the next slide. And this is my last data slide, and I'm just showing this to make brief mention of the treatment of factor 9 inhibitors. Much of what I've said with respect to factor 8 inhibitors also does apply to patients with hemophilia B, these rare patients who have factor 9 inhibitors, but there are a few special considerations that are worth mentioning. Inhibitors, first of all, may be preceded by anaphylactic reactions to factor 9. So these are very severely threatening reactions, and these may occur even on first exposure to factor 9, whether it's factor 9 that's plasma-derived or recombinant. They usually occur in patients with large deletions in the F9 gene. The response to factor 7A is roughly similar to that of factor 8 inhibitors, so they respond well. We do tend to, we try to avoid the use of APCC in factor 9 inhibitor patients because APCC, being a plasma-derived form of PCC, does have factor 9 in it, and it can stimulate an anamnestic response of the inhibitor or even of anaphylaxis. This is an unusual phenomenon. Some of these anti-factor 9 antibodies can cross-react with factor 7A. The significance of that is uncertain. It doesn't seem to interfere with the response. So that was my final data slide, and I thank you for your attention. And Mr. Chairman, if there's time for questions, I'll be happy to try and answer them.
Thank you very much, Dr. Teitel, and for your informative and excellent presentation. And we hope to see you soon in the Jordan, the Holy Land, rich in history and kind people. There is any question, Dr. Abdullah?
Yes, I just have a comment. In the place where I work, which is the University Hospital, we use more recombinant factor 7A, NOVO7, in glandular thrombocythemia rather than inhibitors. In fact, the ratio is probably 6 to 1 because we have large cohort of patients with plasma thrombocythemia.
Yeah.
I don't know how you would comment on this. And the point is, low dose, which is the standard in inhibitors, may not work in plasma thrombocythemia. You really have to go 150 microgram and above. Can you comment on this, please?
Yes. We also use factor 7A for Glanzmann patients. We have you seem to have a very high incidence, so you've got more experience, probably I'm sure than I do. We do like to use it because we like to avoid, as you know, platelet transfusions, because patients can become sensitized to platelets with the Glanzmann's patients. But there is a very good literature demonstrating, as you say, the response to factor 7A. I don't know if it's on the label in Jordan, but we use it as well. I must say we've tended to use the 90 microgram per kilogram dose, and it's usually been effective. But as I say, you've got a large cohort and you've got more experience. We have a fairly large number of patients with congenital factor 7 deficiency, and we use it in that setting as well in much lower doses. We often use it in 15 or 20 micrograms per kilo for 7 deficient patients. But your Glanzmann's experience is interesting, and I hope you do report that. It'll be interesting to see the dose response observations that you've made.
Thank you, Doctor, for this nice lecture. My question is, can we reuse factor 8 in patient with inhibitor after being using a Hemolibra for a period of time, for example, 1 year, 2 years? And yeah, how we can, it's a little bit challenging to follow the inhibitor level and while we are using Hemolibra.
Yes, you raised a very important point. When we get patients who have been tolerized, who've had immune tolerance to factor 8 and their inhibitor disappears, we have always kept them on prophylaxis lifetime. And we call it prophylaxis, but what we may actually be doing, we may be giving them continuous immune tolerance. Maybe that prophylaxis is what is preventing the recurrence of the inhibitor. So when we stop factor 8 and we put them on Hemlibra or emicizumab, as you've said, and we do the same, we put our inhibitor patients on emicizumab. What happens if you then give them factor 8 after an interval of 1 year, 2 years, 5 years, when they haven't seen any factor 8? Is there a risk of recurrence of the inhibitor? That's an important question. I don't think we have a good answer to that yet. What I do know is that in patients in whom the inhibitor is not completely tolerized, but has been suppressed, and it's still there, you can still measure it at very low titer. If you do give those patients factor 8, I have seen, I've done that in surgical situations to cover the patient for the first few days with factor 8. They have had a very rapid anamnestic rise in the inhibitor titer. So if you have a patient, as you're asking, who has been completely tolerized, no inhibitor titer, and you give him factor 8 for surgery, will the inhibitor recur? I suspect it will. However, you can say that's acceptable. You've given him factor 8, he has responded, he's gotten through the surgery, he's still on emicizumab, and the inhibitor will probably decline again with more time. So it's an interesting question. It's also, as you point out, challenging to monitor inhibitor levels on emicizumab patients. We can't use the conventional assay because emicizumab interferes with PTT-dependent assays, so we have to use a chromogenic substrate assay to measure the inhibitor titer. And not every lab has that assay available. So I hope that answers your question.
A curious question. Why hasn't Novo worked on extending the half-life of Novo 7 with, say, pegylation or nanoalbumin?
Yeah, actually, that has been done, and there are products in development. And I think you're right. Why have we gone so long and we haven't had in all these decades we haven't seen an extended half-life version of factor 7? There certainly have been lots of reports over the years of people developing molecules. Novo Nordisk did try to develop a product years ago, and they had to abandon it because it was immunogenic. Patients developed antibodies against it, and so they abandoned that project. But other companies, other investigators are still looking at it. So I suspect immunogenicity has been the problem. It certainly was with this product. I've forgotten what the molecule name was, but this was probably 15, 20 years ago that Novo Nordisk abandoned that, what looked like a promising molecule.
Thank you, Mr. Dr. Title, again, and we will go to the session, next session, Dr. Majdi. Thank you.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Hello everyone. Welcome again to the 12th International Conference of the Society of Hematology, Jordan. And really we are very excited about the great program that we are doing today. I want to say a special word for all attendees and for our distinguished speaker, Dr. Giovanni Balladini, whom I will give a brief introduction. Dr. Balladini is a consultant and acting director of the Amyloidosis Research and Treatment Center at the University Hospital of San Matteo, Pavia, Italy. He has a major role in many scientific societies. He contributed a lot to the introduction of novel agents in the treatment of amyloidosis. He authored more than 200 papers on peer-reviewed journal. I think Dr. Balladini have a lot to share with us, and we are fortunate to have him speak with us today. So please, Dr. Balladini, the mic and the floor is yours.
Thank you very much for your nice introduction. It is my pleasure and honor to have the opportunity to join virtually the conference of the Jordanian Society of Hematology, and I am grateful for this opportunity, and also I'm grateful to the sponsor. I am trying to share my slides, and I hope you can see the slides. And I am now moving to full screen.
They are clear.
Okay, so I will proceed with my own slides. So these are my disclosures, and in the next few minutes, I will discuss with you the state of the art in the management of patients with AL amyloidosis. Of course, AL amyloidosis is the focus of my talk today because we are hematologists. But as a background, I would like to remind you that amyloidosis is not a single disease, but actually a group of diseases. We now know 42 different types of amyloidosis, and these 6 types are those that we most commonly find in our clinical practice as systemic amyloidosis. So we have light chain amyloidosis, of course, that is caused by monoclonal immunoglobulin light chains, but also transthyretin amyloidosis that can be hereditary in the mutated form or sporadic in the wild type form, and other rarer forms of...
Excuse me, Dr. Balladini, will you please do and share slides?
Okay.
Slideshow. Yes.
Okay. Okay, was I able to unshare?
Yes, you can share it again, please.
Do it again, please.
Okay.
Again.
Is it fine?
Yes, now but make it on mode. Put it on the glass.
So I put it in. I put it.
To the slideshow, please.
Slideshow. The projection mode.
Okay.
Right hand side.
أيوه.
Yes.
Is it fine?
اشتغلت.
Go ahead.
Okay. ماشي.
I go ahead. Okay.
Into a large slideshow.
You could make it more large.
No, I can't, unfortunately, because I am already in the presentation mode. So,
In the bottom bar, please. The most right before minus plus.
okay, but you know, this was, I was in the presentation mode, so I couldn't see this.
You can run by selecting. Excuse me, doctor. You can run the presentation by selecting on the left side each slide. Manual.
Okay.
Manual.
Okay. I will do this manually.
Okay. Thank you.
So I was saying that this is what we actually find in our clinical practice. And I am sorry that in the presentation mode you cannot see this, but probably if I do like this, you see all the slide. Can you?
Yes. Yes.
So this is the epidemiological pattern of systemic amyloidosis now. So the two most common forms are AL and transthyretin wild-type amyloidosis that was previously called senile systemic amyloidosis. You see that you know very little about the annual incidence because we have a really a wide range in the publications that I was able to find. But if you look at the panel in the upper left corner of the slide, you see what we now see at our center. So they represent approximately 50% of our patients. So you do the diagnosis of ATTR amyloidosis because this form of amyloid has a cardiac uptake of bone tracers at scintigraphy. But sometimes also light chain amyloidosis can have this uptake. So really what guides all the diagnostic workup is the presence or absence of the monoclonal protein. And this is where the hematologists come into play at the very beginning of the diagnostic process. So in AL amyloidosis, we have a small B-cell clone that is most commonly formed by plasma cells. This clone usually infiltrates the bone marrow by less than 10%. And the light chain that this clone produces are unstable, can aggregate and form amyloid deposits, but they also exert a direct organ toxicity that explains actually some of the clinical manifestations and the behavior and natural history of the disease, and also the pace of response to treatment. This is a systemic disease. Many organs can be involved, as illustrated in the right panel. I would like to show the slides of patient survival in the last 10 years at our center. Not only to show that we have made improvement, and many centers have published this type of slides before, but I would like to draw your attention on the shape of the curve. This is the pattern of a acute disease. You have an acute phase at the beginning where we are actually losing many patients. These are those with advanced heart involvement from the beginning, and then we reach a plateau. So how do we react to this two-phase disease? We need to diagnose the disease early and to stratify the patients based on their risk in order to treat them appropriately and safely. And also we need to assess very quickly and closely whether the patients are actually responding to treatment. But can we really diagnose amyloidosis early? And there are several studies out there about screening amyloidosis and detecting AL amyloidosis at a pre-symptomatic stage in patients with monoclonal gammopathy. Of course, this is a rare disease, so we have to enrich our samples. And we are starting to identify a population at risk amongst those patients who have a monoclonal component. For instance, we already know that the lambda isotype is more common. We know that some light chain germline genes are associated with a higher risk of amyloidosis. We know that in kappa light chains and glycosylation of the light chain is associated with an increased risk of amyloid, and this glycosylation occurs in specific hotspots. The incidence rate of pre-symptomatic AL amyloidosis in MGUS that is followed by hematologists is 2.5 per 1,000 person year. And very recently, two studies, one from my group and one from the Tufts University in Boston, US, showed that a screening approach is feasible. Our was based on biomarkers. The group of Professor Comenzo worked on germline gene usage of light chains and the level of the free light chains. So this is our algorithm to diagnose AL amyloidosis, or better, systemic amyloidosis. You are hematologists, so you are in the best position to screen for a pre-symptomatic AL amyloidosis. What we use is biomarkers, as I told you. But sometimes, and unfortunately most often, amyloidosis is detected because of symptoms. So the first step is looking for a monoclonal component with adequate sensitivity. So by combining both the serum and urine immunofixation electrophoresis and the free light chain assay. If there is no monoclonal protein, we can think that AL amyloidosis can be reasonably excluded. But if there is a monoclonal protein, then you have to do a tissue biopsy. The American Society of Hematology recently reviewed, and this is a slide that was presented at the last ASH meeting in December 24, the different technologies that we can use to diagnose amyloidosis. And you see here the sensitivity of organ or less invasive biopsies. We used the abdominal fat aspiration at our center. In our hands, this has a diagnosis sensitivity of about 80%. But if you suspect amyloidosis and if you stain your bone marrow with Congo red, then you can increase this sensitivity. Unfortunately, diagnosing amyloidosis, I mean recognizing the presence of amyloidosis, is not enough. You need to type amyloid deposits, and this can be done with light microscopy immunohistochemistry. Unfortunately, as you can see in the panel, this technology is not specific. So commercial antibodies cannot reliably distinguish AL amyloidosis. For instance, in the left part of the slide, you see a patient, the endomyocardial biopsy of a patient with AL lambda amyloidosis that stained very strongly with anti-TTR antibodies. So if you need to use light microscopy immunohistochemistry, you should use custom-made antibodies that are specifically raised to recognize the AL amyloidosis. At our center, we use immunoelectron microscopy, immunohistochemistry in electron microscopy with commercial antibodies. Here you see the antibody co-localizing with the amyloid fibril. So you don't have the background interference effect. And now several mass spectrometry methods have been developed, and we also use mass spectrometry. Of course, this requires appropriate technology and expertise. The International Society of Amyloidosis has recently conducted a survey about the attitude towards typing in different large, medium, and small referral centers for systemic amyloidosis. And I'm showing here what are the perceived barriers to amyloid typing. And lack of technologies and expertise is really a major problem. Many people, many physicians, and many patients do not have access to centers that have adequate technology. And I think that only national and international networks can actually overcome this difficulty. And the International Society of Amyloidosis is working to help centers that do not have access to typing across the world. So please keep tuned, because you will see some news from the society. Here I have to move my panels, and I hope that you can see the slide, because this was an animated slide. And I just wanted to point out in this slide that we have staging systems to prognosticate the outcome in this very heterogeneous disease. In the left panel, you can see the Mayo Clinic European staging system that is based on cardiac biomarkers, NT-proBNP and BNP. And this discriminates very sharply groups of patients with different survival. Unfortunately, we are still seeing many patients, the black curve, with very high NT-proBNP, who have a very dismal prognosis. We lose 80% of these patients in the first year, and the median survival is only a few months. You can use BNP if you don't have NT-proBNP. The Mayo Clinic incorporated the free light chain in the staging system. And of course, the lower the concentration of the free light chain, the better, because this is not only a marker of the bulk of the disease, but it is the very toxic agent that causes the disease. And at the ASH meeting this year, the London group, Professor Vechalekar, showed that stage 3B, the black curve that I showed at the beginning, can be stratified with advanced echocardiography. There is global longitudinal strain that is a measure of regional systolic function. And what about the clone? Well, a myeloma-like phenotype by flow cytometry is rare, fortunately, but actually portends a terribly bad outcome, as you can see in this slide. You can also stratify patients for renal outcome. The staging system is very simple, based on proteinuria and eGFR. If you don't want your patient to collect a 24-hour urine sample, excuse me, you can use urinary albumin to creatinine ratio, and you see that also UASCR can discriminate very well the renal outcome, that is the risk of dialysis of these patients. Unfortunately, it looks like urinary protein to creatinine ratio does not work as well. Now we have guidelines for the treatment of AL amyloidosis, which I am summarizing here. Sorry, I cannot get rid of this and of this to show you everything. Here we are. So these guidelines were actually designed by the International Society of Amyloidosis and by the European Hematology Association. So the first step is to assess the eligibility for stem cell transplant. And here I summarize the most important eligibility criteria, but I would like mainly to draw your attention on the cardiac biomarkers. The transplant has been difficult in AL amyloidosis because of early deaths in cardiac patients. And the Mayo Clinic very elegantly showed that all these early deaths actually segregated in patients with high biomarkers, with high cardiac biomarkers. And these patients should not be considered candidates for stem cell transplant. So if you have a patient that is a transplant candidate that is eligible, you actually don't transplant this patient, but you treat this patient with daratumumab, cyclophosphamide, bortezomib, and dexamethasone. And we proceed with transplant only if less than complete response is attained with daratumumab Cyborg-D, or if there is a large clone, a myeloma-like clone, or a clone that harbors high-risk myeloma-like cytogenetics. And the reason for that is that in AL amyloidosis without multiple myeloma, if you adopt a sequential response-driven approach that offers stem cell transplant only to patients who have an unsatisfactory response to induction treatment, then you have a very low treatment-related mortality and a very good rate of deep responses that are long-lasting. But most patients are not eligible for transplants, and most patients are treated with Dara Cyborg-D again. In many countries, and in Italy, for instance, Dara Cyborg-D is not accessible for stage 3B patients. Indeed, in these very delicate patients, the issue is not daratumumab, but it's more bortezomib and dexamethasone. So these patients are treated with attenuated regimens or with daratumumab alone. So as you have seen, daratumumab has a key role in the treatment of AL amyloidosis, and this is due to the results of this trial, the Andromeda trial, that compared daratumumab Cyborg-D versus Cyborg-D alone. Here I'm presenting the response results, which were in favor of Dara Cyborg-D, as you can see, and I would like to draw your attention on cardiac and renal response. At 6 months, patients treated with Dara Cyborg-D had an almost 50% chance to reach cardiac response, which was unprecedented, and more than 50% chance of reaching renal response. This is why Dara Cyborg-D became a standard of care. And last year in December, we presented at the ASH meeting the survival results, the overall survival results of the trial. And you see that after a few months, even overall survival of patients treated with daratumumab Cyborg-D becomes significantly better than that of the control arm. Still, this does not happen at the very beginning, and we have some early deaths, even in patients treated with Dara Cyborg-D. In a retrospective collaboratory study that again was presented at the ASH meeting, we identified the risk factors associated with early deaths in patients treated with daratumumab. And these are again high cardiac biomarkers, high NT-proBNP, age, cytogenetics, absence of translocation margin 14, and performance status. Cytogenetics is an issue even with Dara Cyborg-D. Is there any problem? Can I go on? I hope I can proceed. So,
yes, you can.
Okay, so I wanted to show you that again in this retrospective study that we published on Blood last year, this was an international study, we observed lower rates of hematologic response and a shorter progression-free survival in patients with AL amyloidosis harboring the amplification 1q21. Daratumumab is very effective also in patients with very advanced disease. I am showing here the results of a prospective study by the European Myeloma Network. You see that the overall response rate was quite good, more than 70%. We had 1/4 of patients who responded, who had a cardiac response at 6 months. But even if the overall survival was better than we were used to see in patients with cardiac stage 3B AL amyloidosis, still we were unable to abolish the very early deaths. So daratumumab is not enough in patients with stage 3B disease. However, this is the best option that we have. As was shown in the, as you can see this in the bottom right corner, in a study by the Heidelberg group, and they showed that there is an overall survival advantage in stage 3B patients treated with daratumumab Cyborg-D. I have been speaking of hematologic response. I would like to emphasize that differently from multiple myeloma, in AL amyloidosis, we have a validated response criteria that actually can predict overall survival. They are based on measurements of the free light chains, and the lower the better, because again, the free light chain is not only a marker of the bulk of the disease, but it is the very toxic agents that causes organ damage. So you see that the best outcome is obtained, of course, in complete response, but any improvement is associated with slowing down the disease. And recently we have seen, and this is a study from the National Amyloidosis Center in London, again, Professor Vechalekar, he and his group showed that we can stratify complete response by increasing the sensitivity with free light chain detection by mass spectrometry. We have been working on MRD assessment with next generation flow cytometry. Here I'm presenting the results of the multivariate of a meta-analysis that show that patients in complete response who attain MRD negativity with a sensitivity of 10 to the minus 6 by next generation flow cytometry are more likely to attain organ response and have a longer time to next treatment. Organ response in AL amyloidosis is measured by biomarkers. I am getting rid of this because I just want to emphasize that we follow cardiac response with NT-proBNP. If NT-proBNP decreases, patients survive longer, and we follow renal response with proteinuria. Recently, we have been able to grade organ response. We observe that NT-proBNP after chemotherapy, if hematologic response is maintained, continues to improve over time. And if NT-proBNP normalizes, you can see this after 1 and 2 years, then the survival of these patients is very good. And remarkably, we have shown that the survival of patients with AL amyloidosis, even those who started with very advanced cardiac disease, if they attain a complete cardiac response, that is normalization of NT-proBNP, then this survival is the same of that of matched healthy individuals of the same age. So I am telling you that in a few patients we can be able to operationally cure AL amyloidosis, even with heart involvement. In the same international study, we have shown that renal response can also be graded and improves over time. So one issue remains, why some patients have a very deep hematologic response, but they don't have an organ response. And this was recently studied by the Boston University group, and you see in the left part of the slide the factors that they find as hampering organ response despite a deep hematologic response. And I think many factors are playing here, including factors related to the host, like as sex, for instance, factor related to disease extent before treatment, the possibility, for instance, that the amyloid deposits that are very slowly dissolved in the absence of treatment that is targeting directly the amyloid deposits can actually make the organ involvement irreversible. Well, if response is not attained, you have to rescue your patients. And this is actually a slide that I made pooling all the data published with rescue treatments in daratumumab naive patients. And the mainstay of rescue treatment that we had was IMiDs. However, the rate of complete response that we had with rescue treatment based on IMiDs was rather low. Things improved with ixazomib and with combinations based on daratumumab, particularly with daratumumab, pomalidomide, and dexamethasone. However, these were daratumumab naive patients, but now we very rarely see these patients. In most instances, we have to rescue patients who have been exposed to daratumumab. And this very difficult setting was explored by the Mayo Clinic group and by the Athens group. And amongst the treatments that they tested, stem cell transplant and BCL2 inhibitors in patients harboring the translocation 1114 were the best options. Here I am pulling data on treatment with venetoclax in patients with the translocation 1114 as rescue. And you see that the results are really remarkable, and with an overall response rate of 90% and more than 50% of patients attaining a complete response. And in the right reddish panel, I am showing a Chinese study that was presented last year at the ASH meeting about venetoclax as an upfront treatment. Isatuximab PDEX is an interesting publication, an interesting combination. This was not published yet. This is what they presented at the ASH meeting. And I'm presenting this year because some of these patients were also exposed to daratumumab. So isapom is a combination that you may consider for rescue. Teclistamab is one more option. Two retrospective studies have been published so far with encouraging results. There is some toxicity, particularly respiratory infections. Another anti-BCMA bispecific antibody is elranatamab. This was also presented at the ASH meeting in December, and this was also retrospective. So bispecific antibodies targeting the BCMA, particularly teclistamab, are great options, I think, for rescuing these patients. And we are designing clinical studies, and we are looking forward to their results. BCMA can be targeted by belamaf. These are the results. You see that organ and hematologic response are poorer in patients who already received daratumumab, and toxicity was not negligible in this European prospective study that we have just completed, and particularly ocular toxicity. Again, at the last ASH meeting, anti-BCMA CAR T cells were presented with these very encouraging results in heavily pretreated patients. You see response rates of greater than 90%. The toxicity profile was surprisingly good. So this also warrants further investigation. I think in the rescue setting, because you really don't have time to prepare CAR T cells at the beginning, where treatment should be started in a matter of a few weeks. There are strategies targeting the amyloid deposits, as I briefly mentioned before. Anselimumab is one of these antibodies. Anselimumab showed promising results in an uncontrolled study, and has been tested in 2 randomized phase 3 trials together with immunochemotherapy. The studies are closed, and we are waiting the results. Similarly, birtamimab, one more antibody targeting the amyloid deposits, is being tested in a phase 3 trial on top of immunochemotherapy. The reason for that is that a previous phase 3 trial that was closed for futility, actually in a post-hoc analysis of Mayo stage 4 patients, showed, as you can see in the right panel, a very promising results. So the FDA granted the permission to continue studying this antibody in Mayo stage 4 patients. And again, the trial is about to be completed, and we are waiting for the results. One last idea, treatment option that we will have in the future is light chain stabilizers. The light chain needs to misfold and aggregate to form the amyloid deposits, and probably at some stages here we have the toxic compound that causes organ dysfunction. Small molecules are being tested as stabilizers, and the clinical trials are about to begin in patients with lambda light chains. Studying the stability of the amyloid light chains allowed the same investigators to realize that we can use the instability of amyloid light chain to specifically measure that and distinguish amyloid light chain from non-amyloid light chain. This is a new assay that is being tested and will probably offer a new biomarker for patients with AL amyloidosis. So in conclusion, I hope I convinced you that AL amyloidosis is treatable, and we can be encouraged that in some patients an operational cure can be reached, and we need to increase the number of these patients. Of course, to do so, we need to be fast, to do an early diagnosis and an accurate diagnosis in order to discriminate the different types of amyloidosis. What do we need? We need to be able to screen pre-symptomatic patients, I think. We need new treatments for high risk and daratumumab refractory patients. And I am also very interested in new biomarkers that can provide new treatment endpoints. Again, I am very grateful for the opportunity to present at this meeting today. I just regret I couldn't be with you in presence. Thank you so much.
Thank you very much for this actually comprehensive talk. It's our pleasure as well. So I will open the floor and for any question, please. Dr. Abdullah, have a question?
For patients who have intestinal amyloid and who were treated with autologous bone marrow transplant and responded for, say, 6-8 years, and then they relapsed in the kidney. What's your approach in these cases?
I would treat this patient with daratumumab. We have shown, we have not published yet, but we have presented at the meeting of the International Society of Amyloidosis in Rochester, Mayo Clinic last year, a very high efficacy of daratumumab in daratumumab naive patients who have been transplanted. This was a series of almost 200 patients, and the results were really good. And also, after transplant, you are safer because GI amyloidosis is very tricky because sometimes it looks like localized, so you don't have other organ involvement, and you may think, and sometimes I do think, that patients may not even require treatment. But if you transplant them, the problem may be GI bleeding because you can find amyloid deposits in the gut as well. So I think daratumumab can be safe in these patients.
Is there a role for a PET scan in organ monitoring and AL amyloid?
It depends on the tracers that you use. So tracers that are used to detect, for instance, multiple myeloma cells do not really work very well to detect the amyloid clone, for instance, in localized. I mean, if you are looking for cells in the GI tract. I don't think this will work. But we are many centers are working on amyloid-specific tracers that are some of them are new, some are derived from tracers that can image the amyloid deposits in the brain of patients with Alzheimer's disease. And there are preliminary reports and trials ongoing that these tracers can actually image the amyloid in the heart of patients with systemic amyloidosis. Whether or not these tracers can also be used in the follow-up, we don't know yet.
We have just one extra question from the audience. Can you clarify more about the best time for transplant, early or delayed, and what is the maintenance post-transplant?
Yeah, so this is still a debated issue, but let's say that most of the amyloid centers actually do not transplant upfront. So stem cell transplant is becoming a rescue treatment. So if after induction, what I do is starting with Dara-CyBorD, and they're collecting the stem cells after 2 or 4 cycles. And then we proceed to transplant only in case a complete response is not attained. But sometimes I do transplant a few patients after induction, even in CR, if they have a large clone or a clone with unfavorable cytogenetics. Maintenance, there is no study. So we do not do maintenance in after transplant in patients with AL amyloidosis who do not have multiple myeloma as well.
Thank you very much again. I hope to see you in person here in Jordan. And I will leave the mic for the next session. I think Dr. Hussam Al-Qaisi will moderate this session.
Good evening, everyone. I would like to thank you for your attendance. We do apologize for some delay in the schedule today for some technical reasons. Please allow me to introduce Dr. Litzo, who is a professor of medicine in the Division of Hematology at Mayo Clinic. He was the director of BMT program at Mayo from 1992 to 2008 and continues to remain active in the BMT group. He was the director of the myeloid disease-oriented group in the Division of Hematology from 2002 to 2016. He was appointed as chair of Leukemia Committee of the Eastern Cooperative Oncology Group, American College of Radiology Imaging Network in September 2013, after having served as co-chair of this committee since 2001. He is a past co-chair of Acute Leukemia Working Committee of the CIBMTR. He became board certified in hospice and palliative medicine in 2013 and is a member of the palliative medicine program at Mayo Clinic in Rochester. His research interests include clinical trials of acute and chronic leukemia, including blood and bone marrow transplantation and supportive care of blood and marrow transplant patients. He's the author of over 600 manuscripts and multiple book chapters. Please join me in welcoming Dr. Litzo. Dr. Litzo, the floor is all yours. Please unmute the mic, Dr. Litzo. We can't hear you. I'm afraid we still can't hear you.
Can you hear me now?
Yes.
Okay. And are my slides in presentation mode?
Yeah.
Okay, very good. Well, thank you so much. It's a great honor to speak with you today. I'm certainly pleased to be here, and several of you are close friends, and so again, I appreciate this opportunity. My topic today is recent advances in acute lymphoblastic leukemia. These are my disclosures. And my objectives today are to review advances in the diagnosis and treatment of pre-B ALL.
Dr. Lizo, the slides, if you may turn them into the slideshow, please. We can't, they're not moving.
Okay. I think
Sorry
I
about
thought I
that.
had them in presentation mode.
Yeah. Okay.
I don't know why that's. Can you see them?
Now they're fine now.
They're fine now. Okay. So they're advancing?
Yes.
Okay. So here are my disclosures. Here are my objectives. To review advances in the diagnosis and treatment of pre-B ALL. I want to describe the results of the seminal E1910 clinical trial with blinatumomab, review other studies utilizing immunotherapy upfront in B-cell precursor ALL, and go on to discuss the role of TKIs and immunotherapy in Philadelphia chromosome positive ALL, and then conclude with some comments about T-cell ALL classification and treatment. So we've heard a lot about the WHO and ICC classification of acute myeloid leukemia and some of the controversies and differences between those two. The WHO and ICC also weighed in on ALL, less controversial. This is a WHO classification, which I won't go through in detail, but the right side is the revised 4th edition, and the left side is the 5th edition, which primarily is adding some additional molecular and genetic markers to the classification scheme as these have been sorted through. T-cell ALL is still more in I'll say a descriptive mode related to flow cytometric analyses. And this is the ICC classification with some similar categories of B-cell ALL. And I've left the references for these for you if you want to delve into them in more detail. So there are three major advances that have improved outcomes in Philadelphia or BCR-ABL negative B-cell precursor ALL. I think you're familiar with these. Assessment and prognostic significance of measurable residual disease, utilization of pediatric intensive chemotherapy regimens in adolescents and young adults, and then the immunotherapeutic revolution, which has really led to great advances in the treatment of this aggressive malignancy. So I won't focus on MRD, but I want to just touch briefly on the use of pediatric intensive regimens. This was first identified by Dr. Wendy Stock from the University of Chicago back in the early 2000s and published in 2008, showing that these were adolescents aged 16 to 20. They were treated on a pediatric regimen by the Children's Cancer Group versus the adult group CLGB. Showed a significant improvement in outcome if a pediatrician used a pediatric regimen. And there are multiple reasons for this improvement, but I think the most important one is the use of higher doses of non-myelosuppressive drugs, including steroids, vincristine, and asparaginase. And this led to prospective trials in multiple countries, including in the United States, where Dr. Stock led the C10403 regimen using now the Children's Oncology Group in the United States regimen in patients up to the age of 40, and showed a 2-year overall survival of 79%. The outcomes appeared similar between the different age groups, as I've highlighted in orange, although certainly we saw that in the older individuals, these regimens are not easy to tolerate, but we can get them through them with intensive supportive care. And then the immunotherapy revolution, starting with rituximab in the upper left. then going on to blinatumomab, which I'll focus on in more detail, the bispecific T-cell engaging molecule, and then antibody drug conjugate in the lower right with inotuzumab, ozogamicin, and then finally CAR T-cell therapy on the lower left. So the MD Anderson group led some of the early published studies in this area, adding immunotherapy to their hyper-CVAD regimen, initially abbreviating the 8 courses of chemotherapy to 4 and substituting the last 4 with blinatumomab in orange, and then adding inotuzumab, which are the greenish arrows that you can see, and then introducing some blinatumomab during the maintenance phase. And they gave this regimen in, I'll say, younger adults, age 18 to 60. You can see the median follow-up of 26 months, a very high CR rate and a high MRD negative rate with a low 60-day mortality. And on the lower left, you see the overall and relapse-free survival. And then comparing in the upper middle the 3 agents versus the hyper-CVAD plus blinatumomab, and then for relapse-free survival, and then the middle bottom panel, the overall survival. And then on the right is showing the blue curve is hyper-CVAD plus ofatumumab, which is a CD20 antibody, not used so much. And the upper curve is various iterations of hyper-CVAD plus the immunotherapy. And this was presented as an abstract in 2023 and just published very recently in the American Journal of Hematology by Dr. Kentarjian. So I have highlighted that reference at the bottom in red and showing these very similar curves in that manuscript. They've also applied this regimen to older adults using their mini CVD regimen, where they omit anthracyclines and reduce doses of methotrexate and cytarabine, and then adding inotuzumab plus minus blinatumomab in a somewhat similar regimen to their full hyper-CVAD regimen. And you can see in the middle, these are patients above the age of 60, with about a third of them over age 70. We know these patients have many high-risk features, PP53 and poor cytogenetics particularly. And despite a very encouraging early response rate, you can see that in the lower middle, the blue curve, that the overall survival still declines, and not totally clear that it is plateauing. And many of these, unfortunately, are related to deaths in complete remission from toxicity. And then some patients also actually developed, interestingly, myeloid malignancy, AML or MDS. So a word of caution, and this particularly may apply to the inotuzumab. In the Alliance Cooperative Group, I'll just mention, I'm not showing the data, did a trial adding inotuzumab in a randomized fashion to the C10403 regimen, giving it later in the course, and they had an excess of infectious deaths on the inotuzumab arm of that study, and the study actually was halted by the DSMB. It's now been closed actually for a couple of years, and they're planning to resurrect that study with a pilot using lower doses of inotuzumab and then adding blinatumomab now to that regimen. So we'll see what happens with that study. But a word of caution in the use of inotuzumab. In the U.S., there's also an intergroup trial that I mentioned in the upper right that's randomizing patients to mini CVD plus inotuzumab versus dose-adjusted hyper-CVAD, and that trial is accruing rapidly, so we look forward to those results. And then Matt Wiedewelt, who's at Wake Forest in the United States, did a pilot study, led a pilot study of giving only immunotherapy, inotuzumab and blinatumomab, to patients over the age of 60, either newly diagnosed or relapse refractory. This is a newly diagnosed cohort of just 33 patients, but gave inotuzumab as induction therapy, as you can see. Then if the patients responded, they could continue on inotuzumab for additional treatment and then go on and get blinatumomab as consolidation. If they didn't have a CR, CRI, then they were transitioned to blinatumomab. They did get intrathecal chemotherapy, but no systemic chemotherapy. And the CR rate you can see was 85% plus the inotuzumab rising to 97% with a 1-year survival of 84%. There were relapses. It's not clear this in the study that the survival curve is plateauing, but certainly these are encouraging early results. And this study is going to be published soon. So I think this is an exciting development that is worth pursuing further. And then I want to turn now and talk about a trial that I had the good fortune to lead, to be the principal investigator for, an intergroup trial in the United States, the E1910 trial that I presented at ASH in 2022 and was just published last July in the New England Journal. And this is with adding blinatumomab to chemotherapy. So we used the chemotherapy backbone was based on a trial that we did with the British, the E2993 UCAL12 study. So patients get 2 cycles of induction chemotherapy, you see up at the top. If they achieve a conventional complete remission or CRI, they stay on study and they get intensification with high-dose methotrexate and asparaginase for CNS prophylaxis. And then at that point, we're randomized and we focused on the MRD negative patients, as I'll point out in a moment. And they were randomized either on the right side to get 4 cycles of consolidation chemotherapy and then go on to maintenance therapy, or they could go off to an allogeneic transplant at the discretion of the investigator. We did not specify the conditioning regimen of the donor. We left that open. On the left side, we added blinatumomab on the typical 4-week continuous infusion with a 2-week break, so 2 cycles of blinatumomab. Then patients got the same 4 cycles of consolidation chemotherapy as the other arm with 2 more cycles of blinatumomab, and then also could go off to an allogeneic transplant as investigator discretion or go on to maintenance therapy. And you can see the stratification factors that we used on the lower left. And this was a study done in the US, Canada, and Israel. And it was a 1-to-1 randomization. We assessed MRD centrally in our Leukemia Translational Research Laboratory by Dr. Elizabeth Paeta, and we had a cutoff of 10 to the minus 4 or 0.01% for positivity. Because of the Alliance trial that I mentioned earlier that was recruiting adolescents and young adults, we restricted this study to somewhat older patients aged 30 to 70. We were able to give the blinatumomab for a longer infusion rate than was initially approved by the FDA, which enhanced feasibility. And you can see the median age is right in the middle of the 30 to 70-year-old range. Our CR/CR rate was 81%, with most of these being CRs. And we enrolled the 488 patients. This is a consort diagram on the right. The study activated in December of 2013, and it took us a little under 6 years to accrue to October of 2019. Of the 488 patients that enrolled at diagnosis, 286 were randomized or assigned, 224 MRD negative and 62 MRD positive. 2 arms were well balanced. You recall the FDA approved blinatumomab for MRD positive disease in March of 2018. We had intended to randomize the MRD positive patients also, but felt that we couldn't after this FDA approval, and so we assigned them Arm C, or the blinatumomab arm. So you can see MRD patients on the right, and then the MRD patients, MRD negative positive on the right, and MRD negative on the left side. And a minor point, but we said that the duration of therapy would continue from the start of intensification for 2.5 years. So the patients on the blinatumomab arm actually got less maintenance therapy than the patients that got the chemotherapy. So here's the disposition of the patients. You can see the 81% CR/CRI rate on the left. We had a 4% induction mortality. And then of the 395 who achieved remission, 109 did not reach the randomization. And you can see some of the reasons for that. Some patients died from either early relapse or toxicity, had adverse events, or the patient or physician decided to withdraw the patient. So the 488 patients, 59% reached the randomization or assignment stage. And this is a primary endpoint of the study, the overall survival in the MRD negative patients. The black curve is blinatumomab plus chemotherapy. The red is chemotherapy alone. And the 3-year overall survival was 85% for blinatumomab and 68% for chemotherapy alone. And you can see the hazard ratio of 0.42 and the significant p-value. And most of the excess of deaths in the chemotherapy arm were from relapse. Now, nothing we planned, but 22 patients in each arm actually underwent an on-study transplant. So that was 20% of the patients. And not all patients received all 4 cycles of blinatumomab, but 80% received 2 or more cycles, and a little over half received all 4 cycles. Now, in a post-hoc analysis, we looked at outcomes by age, and we chose the age of 55 because above the age of 55, we did not give asparaginase, and we reduced the duration of some of the steroid therapy and induction. So you can see on the left that in the patients less than 55, the benefit of blinatumomab plus chemotherapy was striking, with very few relapses compared to chemotherapy, with a very low hazard ratio and a significant p-value. In the patients over 55, we did not see significant benefit from additional blinatumomab, although with time we may see the curves separate further. But at this point of this analysis, we did not see a significant difference. And why was this? We don't know entirely, but Dr. Bajal Shah actually put this slide together for me, and these bars represent the different molecular and genetic subgroups. So the first bar, which is more purple, is the pH-like and CRLF2. The green is MLL. The darker next is a complex hypodiploid near haploid. And the gray is TP53 mutated. And you can see that particularly the complex abnormal cytogenetics and TP53 are at a higher frequency in the older patients. And this may have impacted the outcome for these patients somewhat. We did do a fairly sophisticated genetic and genomic analysis. This was done with the assistance of Dr. Charles Mulligan, who's done remarkable work at St. Jude Hospital identifying molecular subgroups of B and T cell ALL. And so you can see the favorable group that the high hyperdiploid and the DUX4 intermediate group, and then the unfavorable group, the usual players we worry about, KMT2A, the low hypodiploid near haploid, BCR-ABL-like, et cetera. A few patients we couldn't assign risk. But with this analysis, you can see on the left side the outcome of the favorable risk patients who got blinatumomab plus chemo versus chemo alone, and we're not seeing any relapses in that group in this curve. On the far right is the unfavorable risk, where encouragingly we're seeing that blinatumomab seems to be overall benefiting these higher risk patients. For reasons that aren't entirely clear to me, in the middle, the blend plus chemo is not showing as much benefit in the intermediate risk group. And this may be a matter of smaller numbers, but I'm not exactly sure why that is. But certainly the unfavorable group is encouraging. And so one of the questions that's come up, certainly in my practice, I always felt that an unfavorable risk patient, even if they achieved MRD negativity, should be considered for a transplant. But as you can see here, these are small numbers, but among 50 patients with unfavorable risk in MRD negative CR who are randomized to chemotherapy plus blinatumomab, that the patients that had no transplant are actually doing a bit better than the 14 patients that had a transplant. And so it's certainly given me pause about whether to transplant these higher risk patients, and perhaps if they achieve MRD negativity and get blinatumomab, they may not need to be transplanted. But I think we need further data and larger numbers to definitively answer this question. So based largely on this study, the FDA approved blinatumomab for consolidation in June last year, and they did this pretty broadly and just said it's for consolidation in Ph-negative B-cell ALL and for both children and adults. Now, for those of you that have followed the ASH meeting, at the plenary session, the Children's Oncology Group here in the United States presented the 1731 trial. This is the NCI standard risk patients, and showed that blinatumomab plus chemo versus chemo alone improved outcomes. There was a study in the New England Journal that had previously shown benefit retrospectively in infants. And we now have the adult study from E1910. So the high-risk pediatric patients don't have a study, but I hope you can see the green arrow there suggesting that it's almost certainly going to benefit these patients as well, and show blinatumomab appears to be a benefit in consolidation across multiple age groups. Well, let me turn now and briefly talk about inotuzumab ozogamicin. I already mentioned the MD Anderson studies, and this is the CD22 antibody linked to a DNA intercalator, the calicheamycin. So we're delivering the toxic drug to the leukemic cells with the antibody. And I found this study to be quite interesting. It was just published last year in the JCO, and this is from the German GMAL group. They enrolled 45 patients over the age of 55 with CD22 positive Ph-negative B-cell ALL. And they gave 3 initial cycles of inotuzumab, and those are in the white boxes, induction 1, induction 2, induction 3, and then went on and did multiple cycles of chemotherapy, and then went on to give these patients maintenance. But you can see they give the inotuzumab early on. And of the 43 evaluable patients, and these are patients above, again, the age of 55, you can see the outcomes on the right. 12 of them had high-risk cytogenetics, but the event-free survival at 1 and 3 years was 88 and 55%, and overall survival 91 and 73%. They did not have any deaths in the first 6 months, and their MRD negative rate was 71% after the 3 cycles of inotuzumab. So they didn't see a lot of the late toxicity that we had noted with the Alliance trial and also some of the MD Anderson data. And so I think giving inotuzumab as an induction agent may be the way to go, and then follow that with either blinatumomab, as I showed in Dr. Wiedewelt's study, or in this trial with chemotherapy. So I'm just going to very briefly touch on CAR T-cell therapy in the interest of time. There are now 3 agents that are FDA approved. This is Kymriah, or tisagenlecleucel. It was first approved in 2018, updated in 2023 with data from the Eliana trial. And this is for patients up to the age of 55. And you can see the duration of remission, event-free survival on the upper right, and the lower left is the overall survival. And they're not seeing any long-term adverse events with this agent. The second was the ZUMA-3 trial that Dr. Vishal Shah led, brexucabtagene autoleucel, and showing here benefits in overall and relapse-free survival, with the purple curve being patients that achieve a remission, the red curve of the non-remission patients, and then the black curve is all comers. And this was approved in October of 2021 for all adults and not restricted by age. And then most recently, the obacabtagene autoleucel study. And this is an interesting CAR T. It has intermediate affinity, so it has a rapid on and off rate. So that has contributed to lower toxic effects, but improved persistence. And you can see the survival curves on the upper right in 127 patients, of whom 94 achieved a morphologic remission. And they only had a higher rate of cytokine release, grade 3 or higher, in 2.4% of patients, and ICANS in 7.1. And so the FDA approved this just a few months ago. These agents remain quite expensive, but have certainly added to our armamentarium. So let me turn and talk briefly about pH positive ALL. I'll discuss the use of ponatinib. This is the FALCON study, a global registration phase 3 trial in adults with newly diagnosed pH positive ALL, and 232 patients were randomized in a 2-to-1 randomization. They get ponatinib 30 milligrams per day or imatinib 600 milligrams with reduced intensity chemotherapy, and then continued on the single agent of the TKI. The ponatinib dose reduced to 50 milligram per day if a patient achieved an MRD negative CR to reduce the risk of some of the vascular toxicity. The primary endpoint was early one of MRD negative CR that needed to be maintained at least 4 weeks, and this was for BCR-ABL by RT-PCR. So this trial had a median age of 54 years. You can see the numbers of patients in each arm. And the primary endpoint was achieved with MRD negative CR of 34% in ponatinib and 17% with imatinib, with arterial occlusive events fortunately being infrequent. And you can see the event-free, progression-free survivals suggesting the curves are splitting, although at this point the overall survival is not different. But this led the FDA to grant accelerated approval to ponatinib based on this study. And as you recall, accelerated approval allows faster approval of drugs, but relies on surrogate endpoints, in this case, MRD negative CR. So the MD Anderson has led the way with use of their hyper-CVAD regimen and a TKI. And in this propensity score analysis published a few years ago, they suggested that adding ponatinib versus dasatinib led to improved outcomes with the ponatinib versus in terms of event-free and overall survival. And this with the FALCON trial, I think, to me, suggests that ponatinib in general would be the preferred TKI to use in these patients. And here's some further follow-up from the MD Anderson, their phase 2 trial combining ponatinib and hyper-CVAD, just published in 2023. And they had 86 patients, 66 that had active disease and enrollment, and all of them achieved a complete remission with a complete molecular remission of 86%. 20 patients went on to allotransplant, and they didn't see a difference in outcome between those who were transplanted and those who were not. And they did do the dose reductions of ponatinib. Started at 45, decreased to 30 with complete remission, to 15 with a CMR. You can see the encouraging survival curves. Now, this is the D-ALBA trial, adding TKI to blinatumomab. This was from the Italian study, which was initially published in the journal in 2020, and then this follow-up last year. And they gave dasatinib for 3 months as a single agent, and then added blinatumomab at that point. And you can see the encouraging disease-free overall and event-free survival with this program. And MD Anderson has gone on and combined ponatinib with blinatumomab, starting both of them at the diagnosis, not delaying with the blinatumomab, and then doing dose adjustments of the ponatinib depending on the patient's response. And this slide shows some of the parameters from their study. The first column, ponatinib plus blinatumomab. The second column being the D-ALBA trial. And then the third column, I'm not presenting the details of this study, but it was a smaller SWOG trial giving dasatinib plus blinatumomab in older patients. You can see a median age of 73. And you can see the high rates of PCR negativity and very encouraging for your overall survival with low rates of allotransplant, although the D-ALBA trial was somewhat higher. And then noting the CNS relapses, which have led to increasing the doses of intrathecal therapy in these patients to try to lessen the risk of relapse, because these patients aren't getting the high-dose methotrexate and Ara-C that one gets with the hyper-CVAD regimen. So encouraging results. And this was the publication just again last year showing the results in detail from the ponatinib and blinatumomab arm, not a study from MD Anderson in 60 patients. And you can see the high rates of complete molecular remission. I'll show a slide about this here shortly, about how to assess MRD in these patients. And only a few patients went to allotransplant. You can see the relapses and the estimated 3-year overall event-free survival. So they have looked at how best to consider assessing MRD in pH-positive patients. The options are to use BCR-ABL by the RT-PCR, or to do next-generation sequencing. And this is the clonoSEQ assay from the company Adaptive in the United States, which has a higher sensitivity. And what the MD Anderson folks with this study have suggested is that if you become MRD negative by NGS, even if you remain positive by RT-PCR for BCR-ABL, your outcomes are similar. So you can see on the second lower curve, you can see PCR positive, NGS negative in the blue curve, and the red curve is PCR negative and NGS negative. So as long as you achieved NGS negativity for MRD, it didn't matter so much what your BCR-ABL result was. And it may be because that's being detected in more mature progenitors that aren't contributing to potential relapse. So this is the algorithm that is used at MD Anderson. They give ponatinib and blinatumomab, and if a patient becomes NGS MRD negative, they continue maintenance TKI. And if they are MRD positive, they give CAR T cells. If they become negative, go to maintenance TKI. Otherwise, if they remain MRD positive, they're considered for transplant. And in the United States here, to answer this question of whether TKI plus blinatumomab or TKI plus chemotherapy, in this case hyper-CVAD, is of more benefit, we're doing this randomized trial, and it's accruing well. The updated accrual is up in the 260s, so we should finish accrual to this study this year. This is being led by the ECOG-ACRIN group with participation from the other cooperative groups. So it's giving TKI a TKI run-in and then TKI plus blinatumomab or TKI plus hyper-CVAD, and then we're doing MRD testing. And then going on to either maintenance, or patients can cross over if they remain MRD positive. We had hoped to try to randomize patients to TKI versus transplant, which is an important question in the field, but we didn't have the numbers to be able to do that. And along that line, these encouraging results that we're seeing with TKI plus either chemotherapy or blinatumomab is making us question the role of allogeneic transplant in Ph-positive ALL, where we used to think all these patients needed transplant. And now this retrospective study from 5 U.S. centers suggests that if patients achieve a complete molecular remission within 3 months of diagnosis, they may not need a transplant. And you can see that the survival curves on the upper portion of the figure on the right, the red curve is allogeneic transplant, the blue curve are the patients that did not get transplanted. And there was no significant difference in overall or relapse-free survival. And interestingly, the non-relapse mortality was not difference between the two arms, although the relapses were somewhat higher with the patients that weren't transplanted. And then they did a Griffiths GVHD and relapse-free survival. Now that doesn't really apply to the chemo patients, but suggested that the non-transplanted patients were doing better than the transplant patients. So it's really changed our therapy, and Ph-positive ALL has now become a more favorable risk acute leukemia, somewhat analogous to APL. So let me briefly conclude with some comments about T-cell ALL. This is a review that I published with Adolfo Ferrando now 10 years ago in how I treat in blood. And this is the ICC classification. The left side is the small number of categories, primarily based on flow, and then the right are from a provisional categories that are now incorporating some of the molecular testing. And you can refer to this publication to look at this in more detail. So nelarabine has been an important agent in the treatment of T-cell ALL. This is a prodrug of ARA-G and is active in this disease. It's been shown to be a benefit in the relapse refractory setting by the Germans and also by a U.S. trial. And the pediatricians suggested if they added it in newly diagnosed patients, that they could see an improvement in 5-year disease-free for survival from 82 up to 88% with a significant p-value, and they saw fewer CNS relapses. In adults, it's not been as clear that nelarabine is beneficial up front. This is a phase 2 study from MD Anderson, adding it to hyper-CVAD and not showing a difference in overall or complete remission, overall survival or complete remission duration. And the UCAL-14 trial, the successor to UCAL-12, randomized T-cell patients in a phase 2 fashion to nelarabine plus chemo versus chemo alone, and didn't see a benefit. So the role of nelarabine up front is not as entirely clear. The MD Anderson did a relatively small study, but added venetoclax to hyper-CVAD along with nelarabine and asparaginase, and saw some encouraging outcomes. And they looked at different cohorts. And you can see that there were 46 patients that were treated with venetoclax. And in this cohort, they did see improved outcomes. So venetoclax also appears to have benefit in T-cell ALL, as we've seen in other malignancies. I sometimes call it vitamin V. It's so active in so many of our lymphoid malignancies, and also in, of course, in AML, and hopefully in MDS as well. And then CAR T-cell therapy has been difficult to implement in T-cell ALL because of the concern that The CAR T cells are going to kill the normal T cells. This is called fratricide. The Chinese have led the way in studying this, although there's now multiple studies around the globe that are investigating this approach. They use various methods, which I won't go into in detail here, to prevent the fratricide from occurring. And they have seen encouraging results that they just published in 2023 using CAR T cells for T cell ALL, achieving a high remission rate and respectable survival rates with, although they saw high rates of cytokine release syndrome, it was only grade 3 to 4 and 12%, and ICANS in only 5%. So this is a field, an area to follow with interest if you're interested in T cell ALL. So I'll conclude here that blinatumomab is effective and FDA approved for relapse refractory B-cell ALL, MRD positive ALL, and now as consolidation therapy for newly diagnosed patients. Patients with relapse disease, I didn't show data on this, but if you use it in a relapse setting, you want to limit the amount you give prior to a BMT to limit the risk of sinusoidal obstruction syndrome or VOD. And the use of allogeneic transplant, again, I wasn't able to go into this in this talk, but as a patient that gets CAR T cell therapy, you need a bone marrow transplant. I think this is controversial and the decision needs to be individualized. And then I show the data suggesting that ponatinib is a preferred TKI to use in pH-positive ALL, and patients with BCR-ABL ALL who achieve an MRD negative remission within 3 months of diagnosis may not need a blood or marrow transplant. With that, I'll conclude and acknowledge my multiple collaborators across the United States intergroup, SWOG, the Alliance, and ECOG, and then our longtime collaborators in Great Britain, Adele Fielding and Tony Goldstone. And with that, I will stop and thank you for your attention.
Thank you so much, Dr. Lizzo, and I open the floor for any questions.
Thank you for your excellent talk. You're well known to Jordanian since you took care of our king in 1999. I remember you very well. Thank you.
It's a great honor.
Yes. I'm really interested in genomics and drugging the mutations in genes. I don't know why the lag behind in solid tumors. There is a plethora of druggable genes. And in ALL and AML, you have like FLT3, BCR-ABL, IDH, just a couple of few genes druggable. Why this dilemma? Do you have an answer? As an oncologist, I'm asking you.
Yes, well, that's an excellent question that haven't been directly asked before. There's and this is a little bit of me too, but some of the pH-like ALL, they affect the Abelson kinase, and so the TKI have a role in that setting, and the pediatricians have done more in that regard than we have in the adult world. And then some of the CRLF2, which mutations that affect the JAK-STAT pathway, the JAK2 inhibitors appear to have some role with ruxolitinib leading the way. But
you certified the genes for favorable groups and unfavorable groups. Why did anybody look at drugging these genes?
Well, I think there are studies underway to look at that. I can't quote the exact studies right this moment, but I think that's attempting to be addressed. But exactly why those are difficult to target, I can't answer precisely. I know. The Notch inhibitors. There was an attempt. There's in T-cell ALL. Notch is a gene that's frequently mutated, and Notch inhibitors were developed, and they were not found to be very efficacious. So I think it's a good question, but I don't have an easy answer for you. I'm not a molecular biologist, and so I can't speak to that as precisely. What, is it the structure of these mutations, or, what is it that makes them so difficult
We are on
to...
the same page, me and you, on the same page.
Yeah. Okay. Well, that's a very good question, and I think it's an area that's being explored, but we haven't made much progress.
There is a question from the audience here. Do you prefer to do CSF analysis directly before starting chemotherapy or to delay this after starting induction? And the second question, during induction chemotherapy, for how long would you prefer to use the TKI for?
What was the second question? How long do you use a TKI and in what setting?
For how long do you use the TKI during the induction chemotherapy?
So the first question about the CSF analysis, I mean, this is, I'll say, controversial. Our practice at Mayo has been if the patient has circulating blasts, as they frequently do at diagnosis, and if they have no neurologic symptoms, to delay the first CSF analysis until we've cleared their blasts, so we lessen the risk of if we have a bloody tap and have a red cell contamination from peripheral blood, that we don't have blasts that we introduce into the CSF. So that tends to be our practice, but that's, I'll say, have some controversy, but that's what we tend to do. Now the TKI, I think giving that continuously is reasonable, and that tends to be our practice as well. I know MD Anderson, I think, with the first cycle of hyper-CVAD in the past, they sometimes only gave it for half the first cycle. But I think it's reasonable to continue it continuously, and it is important to start the TKI right away, and even do a pre-phase with that is not unreasonable. So I would I recommend starting it early and then continuing it. This is not the direct question to that, but how long to continue a TKI after, say, a patient completes their other therapy is an area of uncertainty, and whether to use it prophylactically or to monitor the patient closely and give it preemptively if they say a molecular test becomes positive is also of some controversy. We did a study, SWOG trial, where we gave a TKI after transplant for up to 5 years, and that may be overkill, but that's tended to be my practice. That's to give it for up to 5 years after transplant, and if a patient's not getting transplanted, to potentially continue it long term. But there's a lot of uncertainty in that area.
Thank you, Dr. Khalid.
Thank you, Dr. Halala from King Hassan. Thank you, Professor Lidzo. Very comprehensive as usual. In Jordan, we don't have Lina, Ina. I mean, we're not using that. And for Philadelphia positive, we still transplant our patients in even first CR, and we're trying to get patients in MRD negative within the first, would say, month or two. So the question, which patient you would still insist and send for a transplant from ALL in general? I mean, Philadelphia negative, Philadelphia positive, and even Philadelphia like. What do you think?
Well, that's an area of uncertainty, and I think it primarily applies to the high-risk patients, which I was talking about. So I think if you have a favorable risk patients, which many of our adult patients are not, and they achieve MRD negativity and they get blinatumomab in the pH negative setting, I don't think they need a transplant. The high-risk patients, I think, particularly a younger patient, I would be inclined not to transplant, but to follow them closely. And if they become MRD positive, then to intervene with treatment and potential transplant. The older patients, I think what to do with them is uncertain. Given the data that I showed up, blinatumomab may not be as effective. I think that needs to be individualized. I think in those patients, if they're a high-risk patient, as many of them are, and you think they're a transplant candidate, I would lean toward transplanting them. In the pH positive setting, I think if they achieve complete molecular remission within 3 months of therapy, then I would not transplant them. So I think that would be my guideline. For the pH-like, I would also go by the age. And I put them in the high risk category, but I think my comments about higher risk disease would apply there as well. For the T cell patients, I think if you have a younger patient and they achieve MRD negativity, I would not necessarily transplant them in first remission. But if they remain MRD positive, then you could look at try to give them the larabine and then take them to transplant.
Thanks so
So
much.
I hope that answers, yes.
Thank you. Thanks so much. And I will leave the floor to Dr. Ala Sharman, who will be leading the next session.
Thank you.
Good evening, everybody. I would like to thank all for attending today's presentation, and we'll move to our next session with speaker Dr. Walid Ghanima. He will present about ITP, current management and future perspective. Dr. Walid is a head research and consultant hematologist at Ostfold Hospital, Norway. He is also professor in the Institute of Clinical Medicine at University of Oslo. Dr. Ghanima gained his medical degree from the College of Medicine, University of Baghdad, Iraq, and he joined Oslo Hospital in 1996, becoming a consultant hematologist in 2004, and assumed his current position as head of research in 2014. Professor Walid main research field is venous thrombosis and immune thrombocytopenia. Welcome, Dr. Walid. You can start.
شكرا جزيلا دكتور علاء. مساء الخير للجميع. اتشرف بالاجتماع بكم والقاء هذه المحاضرة. أشكر الجمعية طبعا، الدكتور عبد الله والدكتور غدير على هذه الدعوة. أعتقد هاي المرة الثانية أو الثالثة اللي ألتقي بالزملاء الأردنيين الهيماتولوجيست لإعطاء محاضرات. Well, let's switch to English. Current management, future perspectives in ITP. Moving from malignant hematology to benign, a lot is happening in ITP as in other diseases. This is our hospital. This is Østfold Hospital, which is around 90 kilometers southeast of Oslo. So it's 500 beds, and we're expanding it already now by adding another 100 beds. Okay, so let's move. Just a second. You are seeing it in presenter mode, or
No.
Not?
No.
So it's not working? I mean, it's...
Can share the slide.
Yes, I've already shared it. You cannot see it?
Mm.
Now it's okay?
It's okay, yes.
Yes, now it's
okay. So let's start by the guidelines. And they are this, like the upper two are the international consensus, the American Society of Hematology guidelines. Both of them are from 2019. Their efforts, I mean, we are about to update the international consensus. The American Society of Hematology, they have started the updates, will take several years, I think. And the lower one is the German, Swiss, Austrian guidelines, and they've just been updated last year. So I'm going to give you a kind of summary of these guidelines rather than presenting them. This is the efforts that is sponsored by European Hematology Association and the European Research Consortiums on ITP, creating new guidelines. I'm leading this work. We've just had a meeting, a steering committee meeting an hour ago. That will be the most comprehensive guidelines. Will cover all topics around ITP. We're using great methodology. We're combining evidence and consensus based. We're answering 76 questions. The ASH guidelines answered 18 questions, but we are answering 76. And I'm thinking of a dynamic guidelines, not like you publish it and you wait 5 years to start the, it takes 2 years to update it, and then it will be outdated by the time you have finished the update. So this will be a web-based and will be continuously updated. Okay, from these guidelines, if we try to summarize the guidelines, this is actually the way. We start with the first line treatment. I'm covering each and every one of these lines of treatment. So let's start with the first line of treatment. It's still corticosteroids and IVIG. Now, what are the main current, how they currently manages ITP in the first line, and what are the future perspectives probably? I'm going to touch on multimodal combinations. Okay, all guidelines says that when you treat with steroids, whether prednisolone or dexamethasone, but to maximum of 6 to 8 weeks. And if you give dexamethasone, which I like it very much, then I give a maximum of 3 cycles, usually 2 cycles of dexamethasone. And if I don't get a response by 2 cycles, I don't continue. I move to the second line. Now, why is this? There's no evidence that 6 months is worse than 2 months or better than 2 months. But anyway, the side effects are a lot. You're all aware of these sides. This is from the IWISH study that was conducted. It's a survey that was conducted 4 or 5 years ago. Half of the patients, they complain of weight gain. The swelling, cushingoid changes, the anxiety, psychological impact or changes, sleeping difficulty. All these were reported by the patients. And then we have the more serious side effects that we are very much afraid of. This osteoporosis, of course, the high blood pressure, infectious, all these. So that is the issue. We don't want to prolong the treatment with corticosteroids to avoid side effects, and we don't think that will achieve more remissions. So there's been and the response rate to corticosteroids is around, well, on the long term, maximum, not response, but remissions rate that we're interested in. Response is 70-80% response, but then most of them will relapse. Long-term remissions, they are around 25%. And there's been a lot of there have been a lot of efforts to prolong this response by adding either rituximab to dexamethasone. As you can see, better response with rituximab, longer duration of response versus dex alone. MMF by the British, this was done, this study, better time to relapse, longer time to relapse with the combination versus prednisolone. The Chinese have tried several combinations. Combining Atra to Dex provides, once again, longer duration of response versus Dex alone. Combining the recombinant to Dex better than Dex alone, but none of these has been adopted as a standard treatment. Why is that? Well, for several reasons. This is meta-analysis, recent one, showing that all the combinations actually are better than the single arm. All of them are in favor of the combination. The early response is twice as much the odds ratio, and the sustained response 2.5 folds higher than the dexamethasone alone. Now, toxicity, partly because of the toxicity, we don't use them regularly. Another reason is the cost of these. The third reason, availability and use. Like, who uses ATRA and ITP? It's not usual. And you have all these other treatments. So it hasn't gained very much popularity. Now, there has been several attempts, single-arm studies showing very high remission rates when we combine TPO and dexamethasone. And there are currently 2 ongoing combination studies, one with romiplostim dex and the other with eltrombopag dex. And both of them about to be completed. I think if the combination of a short treatment of like 3 months of TPRA plus 2 couple of Dex be shown to be much better than Dex alone and safe, of course. We don't know the thromboembolic rate, how much is with the early use of romiplostim or eltrombopag. This might change actually the practice. Another combination, now industry has gone fully into this, investing into the first line, because they understand if we induce remission early, then it will be a winner. Ianalumab it's called, or ianalumab, 2 different names, but the same drug, is a monoclonal antibody that targets both the B cells, so deplete B cells, and targets the B cell activating factor. So this will prevent the conversion of B cells into plasma cell and block the antibody production in 2 ways. This study is ongoing. It just included last week a patient in it, and let's see how this medication will turn out to be. Okay, this is with regard to the the current treatment and future perspective in the first line. How about the 70% of patients who fails to respond or relapse after first-line therapy and will end up needing a second-line therapy? Okay, in the second-line therapy, we have now at least 3 medications, the TPRA, rituximab, and fostamatinib. The international consensus enlisted these 3 medications and said that you could try any of these. The ASH guidelines said TPRA the best, because they provided the highest durable response rate. Fostamatinib was not included in the ASH guidelines. The German guidelines, they recommend either TPO or fostamatinib, because both of them are approved, licensed for ITP, or rituximab as unlicensed. Splenectomy, well, of historical reason, I included it here, and it's an option, but should not, preferably, not be performed during the first year. We have a lot of investigational product, and you have in Jordan participating in some of these studies. Okay, let's talk a little bit of what is the current practice. Earlier use of TPRA as a drug of choice in the second line, also touching on tapering and discontinuation. So why TPRA, despite being expensive drugs, become the standard of care in the second line? Well, because of their response rates. Because of their high durable response. A durable response is defined by the study as multiple platelet count above 50, around the end of the study, like in the last 2, 3, 4 months, or 2, 3 months of these studies. 60% with eltrombopag, 49% with romiplostim, and we have avatrombopag. I understood that avatrombopag has not been introduced yet in Jordan. We use it very much. It has replaced all other because there is no, it's oral and it has no food interaction or liver toxicity. I mean, with food interaction with dairy product, milk, all these precautions. You take it with, you give it with food, and the patients are very happy. It's very effective. So these are our preferred right now, and we don't need to measure the liver enzymes after using it. Anyway, all of them are effective. And what do we do if the patient does not respond to avatrombopag or to eltrombopag or to romiplostim? Well, we change to the second TPRA because 50 to 80% will respond to a second TPO. Whether we switch to a third, well, we can do it. We don't know what is the response rate, so we switch sometimes when we get a refractory patient. Remember, and I should have mentioned this, let's go back to this slide. It's a shared decision making. So whatever you want to use, TPO or rituximab or fostamatinib or splenectomy, you should discuss this with the patient because patients has different preferences, and some of them would favor rituximab, others would favor TPRA. Okay. This is in case of the patient is not responding to TPR. So we switch to other TPRA. What about if the patients with the majority do that, respond very well to TPRA? Well, there are and maintain this response for some time. So there's been 4 prospective studies looking at the discontinuation. Now, when these drugs were introduced, we thought this will be a lifelong treatment, but we have learned later that a substantial number of patients can taper and discontinue. Now, this is the when to taper, when to discontinue, at what blood count to do that, the different in the 3. In this one, romiplostim study was used 50 platelet count. In this eltrombopag was 30 as a baseline. In the eltrombopag, the taper study was 100 for 2 months, and this French study, Stopago, was 100 also for 2 months. And the rate of so-called sustained response of treatment was around 30%, as you can see in these 3 studies. So these discontinued and remained of response for 6 months or 1 year. The French, what they did, if the patient had been on TPO for 3 months and platelet counts above 100 for 2 months, and you discontinue at this level, then around 50% will remain at response at 1 year, a platelet count above 100. And the majority have a complete response, actually. So what I'm sure all of you and all of us have patients that have been on steroids and on TPRA for quite some time, some of them many years, and they have very good response. So please go and try to decrease the dose gradually until discontinuation, because you will be able to discontinue a substantial number of patients. And if you failed the first time, you can wait 3-4 months and try again, and never give up. Many will achieve sustained response of treatment. As a kind of summary of these studies, because we are confused, all of us, just to let you know, a substantial number, around 30% can discontinue if without losing response. And there is no consensus on the optimal duration of treatment, but I would say 6 months, everything from 3 to 6 months, let's say 6 months. If the patients maintain nice platelet count, then start tapering gradually until discontinuation. If the patient has had platelet count for above 100 for 2 months or more, then that patient has really high possibility or probability of achieving response around 50%. Okay, now I'd like to leave TPRA for a moment and introduce another drug. Don't think fostamatinib is available in Jordan. It's been available in Europe for 3-4 years now. The phase 3 study actually showed durable response of 18%. This is as opposed to the 40 and 50 and 60 that I showed you. But it is like in this study, 18% durable response rate. And the response is achieved within a couple of weeks, and the majority in at least half of the patients. Now, there are many real-world studies are coming up showing that the responses actually are higher than that, especially if we use it earlier. The problem with fostamatinib is the side effects, diarrhea in around 1/3, hypertension in 1/3. And it's not a joke, the hypertension. The patient might get a hypertensive crisis. So I check the blood pressure regularly, actually only in this category of patients. You get transaminitis in around 10% and neutropenia. But the beauty of fostamatinib, it does not increase the rate of thromboembolism, which I'll get back to it. Only one patient had a transient ischemic attack out of almost 150 patients, 146, and in another study, none, and very few also in the real world data. So it does not cause increase in the rate of thrombosis. So what do we do if we have a patient with high risk of thrombosis? Another problem. We learned a lot after the introduction of TPRA about thrombosis, actually, to trigger the interest in this field. But these are all this randomized control trial, even including the Chinese Hetrombopag, which is another oral TPRA. You can see that most of the studies have shown increase in thrombosis, arterial or venous, in favor of control. That's in this condition more with TPORA. But none of the meta-analyses, I think there are 5 meta-analyses, have shown a significant increase. You can see that there is an overlap here. The odds ratio is 1 almost 0.8, so there is an increase, there is a trend, but the p-value is not significant. More data are coming from real-world studies like this one, 220 patients with 37 thrombotic events, 2 per 100,000 year venous thrombosis per 100 patient year. So you treat 100 patients, for 1 year, you get 2 venous thrombosis. And that's higher than what we expect in the general population. Age above 60 was identified as a risk factor, secondary ITPs, multiple prior therapies, but look at the TPRA use. The hazard ratios were 3. And this is showing clear increase, significant association between TPRA and use of TPRA and the thromboembolic risk. And it could be PEDVT, splanchnic, or cerebral, mostly venous. 2/3, more than 3/3 are, no, 2/3, more than 2/3 are venous thrombosis, or 1/4 is arterial, 3/4 venous thrombosis. One thing I want to draw your attention about, headache is a side effect of TPRA, and particularly of a thrombopag. But so if you get a patient with headache after starting, just think of the possibility of cerebral venous thrombosis. So what to do if we get a patient with high risk of thrombosis? Well, we have fostamatinib or we have rituximab or other immunosuppressing agent. Don't give them TPRA. Now, the main issue is how to define high risk. Now, all studies, and as I showed you, have shown that elderly patients, they have are at higher risk. But when you set the cutoff 60, 70, 80, well, the risk of thrombosis goes up with both arterial and venous with age. Previous venous and arterial, if they're not on anticoagulation, particularly venous, well, there's a really high risk patient. So be aware of that. Either use something else or put the patient on anticoagulation. Patients with SLE, particularly if they have antiphospholipid antibodies, patients on having antiphospholipid syndrome. Actually, antiphospholipid syndrome, most patients are on anticoagulation, so there's no problem. Patients having lupus anticoagulants, maybe you don't want to put them on TPRA, use other agents. And if the patient, as I mentioned, has an atrial fibrillation on or has a previous thrombosis on anticoagulation, I don't worry at all. I put that patient on TPO. Actually, the best choice. Okay, these are the available therapies for the second line. At one moment, these patients, all of us have patients that we label as refractory. We don't have a good definition of refractory. We don't know where this line is crossed from second to third line, which I would call it refractory. So when to consider these patients are refractory, we don't know. Most experts would say failing 2 TPRAs and 1 immunosuppressant, that patient is refractory agent. Or don't call it refractory. That patient is more difficult to treat and require a new approach. So how to deal with that patient? Well, either we continue on monotherapies or we use combinations therapies of TPRA and immune modulatory or splenectomize that patient. So what to do and why? Well, monotherapies, there are a lot of them, and all of these have been tried as monotherapies and with different rates of failure, different safety. My drug of choice has been mycophenolate until lately. I think Dr. Abdullah mentioned last time I met him sirolimus or tacrolimus. I think the sirolimus can comment on that later as a good option. We have investigational products that rilzabrutinib and CD38. I will touch upon these at the end of I think they are very promising. But my favorite treatment right now is the approach to this category is a combination. And what the French has showed us that based on their registry, that if we combine a TPO to immunosuppressant, whatever TPO to whatever immunosuppressant, whether azathioprine or mycophenolate or cyclosporin, the rate of success is high. They had 39 patients, multi-refractory, 2 TPRAs, they have failed, rituximab and splenectomy. And then they re-challenged them with TPO, despite the fact they didn't respond initially, adding an immunosuppressive. 30 of the 39, that about 75% responded. At the end of the study, at around 2 years follow-up, still had the patient were in response. Now, my favorite combination has become avatrombopag and fostamatinib, very expensive combination, but works nicely. Eva Mingot from Spain, in Ashbilia, Spain. She did this study. We had 2 patients who participated, multi-refractory, 5 previous treatments. Started with a combination of fostamatinib and avatrombopag. 83% responded, and quite quickly. That is the beauty of fostamatinib, because MMF would require 2 months, and I'm sure the cyclosporine is the same, and azathioprine is the same, 2-3 months. Here, within 2 weeks, you can tell if the patient responding or not. Some patients relapse due tapering, because once the patient responds to a combination, you want to taper one or another to see what happened. Usually some of the patient would relapse. So during the tapering, what you do is that you go back again to the initial dose, and some will manage after some time to discontinue. Splenectomy is still a choice. The main question is that whether when we splenectomize in the 5th line, we get the same response remissions rate that we used to learn when we started medicine or hematology 20 years ago, when splenectomy was used as a 2nd-line treatment. Now, the French went back to their registry, looking at around 185 patients, and looked at different time intervals in the patient splenectomized between 2011, 2013, when we didn't have TPRA and probably rituximab not that wide used. Well, that's the remission rate, 75%. And is between 2017 and 20, wide use of TPRA, well, slightly around 55% responded, but it's still substantial number respond. So it's still a valid option. Now, last EHA, the British presented their data from their UK ITP registry, showing totally different data. If you splenectomized in the 3rd line, that would be substantially worse outcome than the 2nd line. With that, I would like to end the current treatment, and touch upon the interesting therapies that we are going to see, and focusing on 2-3 of these, mostly the BTK inhibitor rilzabrutinib. Now, inhibiting BTK, this is a Sanofi sponsored study or medication. It's a very potent BTK inhibitor, reversible, oral, twice daily. It interferes with B cell activation. It interferes with phagocytosis. It interferes with the inflammasome, the NLRP3 inflammasome. And that inflammasome, you block the inflammatory or pro-inflammatory cytokines like the interleukin-1. And so it has multiple function. And attacks various pathways, both an anti-inflammatory and autoimmune or immune modulator. Okay, the phase 2 showed nice result, went to the phase 3, which was presented at ASH in the plenary by David Cooter. And it will come any day now in Blood. The phase 2 was published in the New England, but for the sake of time, I didn't include it in this presentation. It was 2-to-1. It was 2-to-1 randomization between rilzabrutinib and placebo, and the primary endpoint was a durable response, which was defined at week 25, which was defined as platelet count above 50 in more than 2/3 of the last 12 weeks visits. So 2/3 of the platelet count. A little bit about the age of these patients was around 47 median duration of disease 6 to 8 years. but the median number of prior therapies was 4 to 5 prior therapies. So really refractory population, 1/3 or about 1/4 splenectomized, and 2/3 were on TPO previously. Now, the durable response rate was 23% with risabrutinib versus 0 in the placebo. We'll hear more about this drug, and they have applied for approval both at the EMA and the FDA, and I'm sure it will be approved, and they will launch a first or an early line study right after steroid failure very soon. You can see here the durability of response. Those who responded to risabrutinib the platelet count continued to increase nicely. Even those who did not respond, some of them responded after week 13. So what is nice about this drug also, it reduced physical fatigue. This is week 13 and 25 in responders. They had substantial decrease in fatigue. That, I mean, going up is a decrease. But not only responders, the non-responders who were on risabrutinib, that confirms in a way indirectly that it's anti-inflammatory action. But those who were not on placebo, they had worsening of fatigue actually. Okay, 2 words about efgartigimod, the neonatal FcR receptor inhibitor, which Jordan participated in the subcutaneous study. The intravenous was successful. It should be given every week or every other weeks, and it's a continuous therapy. The durable response were 22% versus 5% in the placebo. The problem that the subcutaneous study failed to show any benefit, any difference, actually better results with the placebo compared to the efgartigimod. So it is approved in Japan, the intravenous, and they are going to start another study on intravenous efgartigimod in ITP. CD38 inhibitors, very promising, I think. Strongly believe in CD30. This was a Chinese drug, intravenous, and was given for 8 weekly injections, and the response rate was 95% actually, and that is any time during the study the response rate was taken. I didn't agree with them. I reviewed this paper. I didn't agree that it was an appropriate endpoint, but this was how it was done. But the durable responses were also around 60%, so excellent results. I mean, who have seen 95% responses? This is mezagitamab, Takeda product. This is a subcutaneous one. The same thing, 90% response rate, durable response, but here durable was defined at 2 visits. Once again, and the durable responses were also in the 60 or slightly lower. Now we have completed our daratumumab study, subcutaneous, also 21 patients. We are about to submit it to Lancet today, tomorrow, and we'll submit it to EHA and ISTH. Slightly lower response rate, but then we have daratumumab available. I think this approach is very interesting in the future. Very nice safety profile, not much infections. Since I don't have a summary, I will do the summary very briefly, and remember, short term corticosteroid, not more than 2 months. Those who require second-line treatment, TPRA is our first choice in the second line. But rituximab, it's a decision of the patient, shared decision with the patient to say it that way. Many would want, whether prefer rituximab, fostamatinib is an option. Those 10% who would not respond to the multiple second line, these will benefit from a combination of immunosuppressive and TPRA. And don't remember to taper. Don't forget, sorry, it's a bad advice not to remember tapering. It should be, remember please, tapering TPRA in a patient who are responding nicely for sometimes. And I'm very hopeful about the future of ITP. We need biomarkers. We still sequence our medications based on just preference and responses. We need biomarkers, but still very bright futures with what we have and with the new medication. I like this picture. It was by Edvard Munch, a very famous Norwegian painter. He's painted the Scream, if you know. I'm sure a lot of you remember that. And that painting actually this is the University of Oslo, the old university building in the central downtown of Oslo. And it decorates the main hall of this building. And thank you very much. We'd be very happy to take your questions.
Thank you, Dr. Walid, for this very interesting and informative presentation, and floor is open for any question to Dr. Walid. Dr. Firas.
Thank you for your talk. Actually, I was met with this scenario, an 18-year-old female who developed ITP, newly diagnosed ITP, and she had her exams 10 days later. So starting her on steroids, I mean, I really felt bad to inflict of this medication on her while she will be sitting up all night, insomniac, and you know.
Yeah.
So what would be choice in such a scenario with a fast response, apart from steroids?
Okay, so that's a pediatric patient. You said 8 years?
Oh, 18 years. 18 years.
18 years. Okay. If that patient, I mean, we still use steroid as a first line.
She had a platelets of
8,000.
10,000 with ecchymosis, petechiae. Florid case.
Yeah. So I mean, if you are clear about the side effect, you don't want to expose this patient, then TPRA is I mean, why not? You can still use this to get a quick, or IVIG. Quick elevation of the platelet.
You know, IVIG, you need to admit her to the hospital, and she will waste her time.
Yeah, but
easy way to start her.
Yeah, you can start on a probably. I mean, in that case, which you have clear reason for, probably not to use a steroid at this period. TPRA, and then you can consider later giving that patient steroids or rituximab, but steroids of short course when she finishes the exam.
Thank you very much. Very comprehensive talk. What type of evaluation you're doing for a patient, adult patient? You go and do like a flow, like genetics, genomics study. Are you doing these studies, or just you're looking on a blood? How far go with an investigation?
Yeah, I mean, still the recommendations are, and the guidelines still recommends the complete blood count, the blood film, peripheral blood, and thyroid function, serology, viral serology. We don't do the Helicobacter. I do antiphospholipid antibodies in all of them, just for later to know what this patient have or how to treat in a way. That's for the first line. We don't do flow if there is a complete only isolated thrombocytopenia, normal hemoglobin, normal whited, normal differential, and a blood film showing nothing special. So we don't do bone marrow. But once if the patient gets more to the refractory, I mean, does not respond well or so, then we go further and do bone marrow, and at one stage, if there is a family history, if you find if you find abnormalities in size, very big platelets, or other abnormalities in the white cell, and you suspect genetic hereditary disease, yes, we do a panel, the hereditary molecular panels, to see if there's any hereditary disease.
Dr. Firas?
Thank you, Dr. Walid. Dr. Walid, can I ask you, please, how do you think it is right to just not to push too hard on patients who are refractory ITP? Personally, I have come across a few patients that I can recall who are refractory, and they don't get their platelet count to more than 20, or it is all the time, maybe between 10 to 20 or even less than that, but they are really asymptomatic. They don't have bleeding symptoms, and they have never had any bleeding events. And I have consumed all available options in Jordan. For example, after 1 or 2 TBOs and using rituximab and some calcineurin inhibitors, I'm out of options. So personally, I started to just observe them because they don't have bleeding symptoms. I'm not trying to push any further by doing splenectomy, for example, just to get the platelet count to a number that looks safe, but it is practically safe. They have been bleeding free. Do you agree on this, or do you?
Absolutely, and that's what all the expert and the guidelines says the same. Don't overtreat. Now, I mean, for the sake of time, I didn't include this slide, which always say that reassess the goals of your therapy.
Even when the platelet count is really low.
Yeah, I mean, it's 10 to 20. If the patient is not bleeding, is not on anticoagulation, at the age of it's okay, that's the 75, 80, and even 75, 80. If you don't have other options, then no, I don't treat. We all have such patients in the region of around 15 to 20. Don't. I mean, treat them to the level of getting side effects, and rather reassure them and try to improve their quality of life by reassurance and trying to accept the disease and other measures to avoid bleeding. But have you tried a combination of TPO and immunosuppression?
Yes.
Okay.
Thank you.
You're welcome.
Last question from the audience. Any advice regarding use of erythropoietin in chronic kidney disease and calcium, including TAP or calcium resinol for antihyperkalemia management?
Yeah, I mean, it should not be given with calcium. It may interfere, but otherwise, there's no other restrictions with regard to renal disease. But if you use it and it's just don't give it with calcium. And if it's working, continue. If it's not working, give other medications.
Thank you, Dr. Walid.
You're welcome. A pleasure.
Dr. Abdullah?
Can I ask the last question? Walid, I'm Abdullah.
Of course.
Now, comments. Do you do any isotope scan for the spleen before you decide on splenectomy like the British did?
We don't have this. We don't have the isotopes. We
Because-
tried to introduce it, but it's very difficult. We don't have it in Norway. We don't have it in Scandinavia.
Because the British select only patients who have higher uptake on the spleen for splenectomy. Otherwise, they don't do splenectomy.
Yeah, I mean, or even, maybe mixed, but not hepatic, definitely. But the results, like your success rate is 86%, or let's say more than 80% if you pick up the...
Second comment on patients with ITP in whom you excluded secondary causes. How hard do you push for a bone marrow examination?
Well, this depends. I mean, it should be individualized. If just excluded, it's in the first line, and everything else is okay and fine, and the blood, like the peripheral blood counts and morphology is normal. I wouldn't do it, but in general, I wouldn't do it, to say it that way. But it's difficult to give a clear answer. I mean, it's individualized.
Thank you, Dr.
Thank you.
يا أهلا وسهلا.
أهلا فيك سيدي.
With this, we conclude the session of today. Thank you, Dr. Walid. We'll see you all tomorrow at 1:30. So please be back again. Thank you.
combination بتاع 50 150 تعمل combination شفت عليه success
مشينا عليهم